Good morning. So we are starting. So a formal welcome inauguration will be there at 10:20 or 10:30 in the main hall. We have to break the session and join there. We will start with the first lecture. That is Dr. Prashant Nayak, who was with us. I forgot the years, but now he became professor at AIMS Bhubaneswar after his MCH studies, and currently is at AIMS Bhubaneswar. Welcome. Please start.
Thank you for that introduction, and it's a pleasure and an honor to be here. Last year also, my sir had asked me, but I could not come. A lot of things were happening over there. So yeah, but this is an honor to be here. So today my mandate is to talk about lap nephrectomy, video collage. I just collected some of the challenging cases that we have done over last 10 years. So lap nephrectomy, we do simple radical for RCCs, simple for all other indications. Nowadays, partial nephrectomy is as good as a radical nephrectomy with almost equivalent oncological outcomes. And then, of course, there is donor nephrectomy for renal transplants. This is our experience. This was in SAGC, about 10 years, 106 cases. So the technical difficulties, troubleshoots, guide, and a lot of tips and tricks about how we tackle difficult issues when we're doing a radical nephrectomy. So this is a simple radical. So radical nephrectomy generally, because it's a malignancy, unless the planes have been violated or it's a T3 or T4 disease, most of the cases you get excellent planes and you can do a good job. So here we see just a short video, right kidney, IVC liver. So my advice to my juniors is always that take the fear of IVC away from it. The IVC is your biggest friend when you're doing an nephrectomy. Use that as a guide. And here we are just dissecting on the IVC. And our goal is to create an upper window. So you can see the moment I see the psoas muscle, I am very happy. So I try to get the psoas muscle above the hilum and I try to get it below the hilum. So once I get it, I know that there is nothing else there. So I just have the hilum to tackle. So this was a large tumor. So the kidney was pushed down. I got the artery high enough. Artery is clipped. And then I tackle the renal artery. Once I have done that, the tumor also shrinks a little bit. And the further dissection becomes easy. The colon gets easily mobilized down. And once I have mobilized the colon, so this is just a basic radical nephrectomy, how we go about it. So we are just mobilizing the colon. Next comes the cauterization of the duodenum. So duodenum just lies on the IVC. So once I cauterize it, I am seeing the IVC underneath. And I have already taken care of the artery. So once I get done with the duodenum, I'm going lateral to this is again, the tumor was large. It was overhanging the IVC. I'm working on the IVC close to the wall to get a plane. So most of the times you get a plane near IVC. So even if the rest of it is, so I try to get close to IVC. So this is the inferior window. Now I had the superior window. I have gone below the hilum to get the inferior window. And now I am tackling the renal vein. So renal vein is an offshoot from the IVC here. And we are just getting both the lower border and the upper border. And I see the renal vein. So this is more or less what a radical nephrectomy following oncological principles. Not much tumor handling has happened. Although that is not important because we are seeing partial nephrectomy, we do a lot of handling and still outcomes are equal. And we get into the aortas and then remove the tumor very close to the kidney and still oncological outcomes are almost equivalent to a radical nephrectomy. So partial is the flavor nowadays because if you do radical, even somebody who has got a good renal function upfront, about 15% of them would end up with CKD in the long run. So that is why earlier partial used to be what is called imperative partial, but now all partials are or what is called elective. So here we see we have tackled both the hilum, we have taken down the kidney, and now it's just a matter of freeing the lateral attachments and taking down the kidney. So that is this video. And next, so radical nephrectomy sounds ominous, but actually it is easier. Sometimes we get stuck while doing simple nephrectomies. So simple nephrectomies are non-functioning kidneys, probably due to a stone, due to infection. And then these are the ones that are densely adherent and all that. So this was a particularly difficult case that I encountered due to a condition called XGPN, or something called xanthogranulomatous pyelonephritis. It's stone leading to dense adhesion. So here it was a laparoscopic right, so-called simple nephrectomy for XGPN. You get inside and you see this. The dense adhesions with liver, kidney, abdominal wall, everything is stuck. So then you slowly take down the adhesions above, then come to the inferior pole, try to separate it. Again, follow that principles of trying to get a window. So get an inferior window. So moment I see psoas muscle, I've lifted up the ureter, lower pole, I've seen the psoas muscle beyond the IVC. Then there was a lower pole artery. So we dissected out the lower pole artery, then we clip the lower pole artery. So once I see that there is a lower pole artery, I expect anomalies in this patient now. So this was such dense, so the CT had not shown anything. So now we see the right gonadal vein taking off from IVC. You can see the IVC, how it has been bared. And then you can see the takeoff of the gonadal vein. So I try to preserve the gonadal vein if possible. So only dissect above the gonadal vein to preserve the gonadal vein. Although there is not much evidence either way, whether it has any benefit, but if not required, then no need to sacrifice that. So gonadal vein is preserved. Again, I'm working laterally, inching my way up along the IVC to reach the hilum. So that is the idea. You can see the gonadal vein, the psoas muscle, the IVC, and the kidney above. So that is the picture. And then you can see a large lymph nodal mass sitting right on the IVC, right over the hilum. So this this is the IVC, and that is the lymph node sitting right over the hilum. So this was a bit tricky. So I already told you I had encountered a lower renal artery. So I know that I'm going to have some kind of anomalous vascular architecture. So then I slowly move up along the IVC, and I see the takeoff of a renal vein there. So you can see one renal vein. I slowly go up along the IVC, lifting up the lymph nodal mass, and I see the takeoff of the other renal vein there. So there are two renal veins there. So so all these were not apparent in the pre-ops CT, arteriogram, and phenogram because of the dense adhesion. So entire anatomy was not clear upfront. Then again, this is the upper window. So now my job was to somehow see the psoas muscle above the hilum. That is the liver I am lifting up, and adrenal, psoas, hilum, and kidney upper pole. So this, now I see whatever is there between the upper window and the lower window is the hilum that I need to tackle. So this is the IVC with the two renal veins. So again, I have not seen the artery. So I have to find the artery. One artery we saw below, so I need to find another artery. It was not possible, there a lot of tension. So I told I can sacrifice one vein. If there is a single vein, it is not advisable to sacrifice that vein before you tackle the artery, because then the renal engorgement will happen. So this was the renal artery which was dissected between the two veins. And then I just clipped once I got the renal artery. Once you clip the renal artery, then you're fairly certain the kidney mass also shrinks a bit, the rigidity goes away, and then you can handle the renal vein and renal artery. And then it was just a matter of clipping the upper renal vein and taking it out. Right, so this was the other difficult case. So here comes the role of intra-op ultrasound. So we have been using it quite liberally, and this was the paper that we had in 2023 in BJU on the role of, where we try to define what is the role of IOUS. So it doesn't help that much in a radical nephrectomy, but is definitely a boon in a difficult simple nephrectomy or a partial nephrectomy where you need to delineate the renal hilum, and if you are not sure where the artery is and where the vein is, so it really helps there. So this is another case where sometimes in such difficult scenarios we try to seek the artery in the inter-outer cable groove. So this was again a renal vein that was pregnant with a thrombus. There was a large thrombus sitting inside the renal vein. So I could not dissect the artery behind that big bulky IVC and renal vein. So I went to the other side. I dissected the duodenum and came to the opposite side to get the left renal vein. So you can see the left renal vein. Generally, the right renal artery takeoff from the aorta is seen just inferior to the origin of the left renal vein. So that's the IVC, and that is the origin of the left renal vein. So then I'm dissecting. I know that I'm going to find something there. I'm a bit careful, and actually, this yields. And generally, IVC is a tough structure. So my message is not to be awed by this IVC, and you can take it as a friend here and try to find out. So just IVC. So that is the renal artery. So that is the takeoff of the right renal artery from the aorta under that. So once I get that, I put a clip there, and then the procedure becomes easy after that. So I can clip it right there. So that is how we dissect it in the inter-outer cable groove. Right. So this is the last video that I'm going to share. It's a right RCC with a level 2 IVC thrombus. L2 thrombus is thrombus that has gone into the renal vein and gone up up to the up just below the hepatic vein origin. So not under the hepatic vein, not above the hepatic vein. Mostly, if it is above the hepatic vein, you need to get the cardiothoracic surgeons in, and mostly you will need to open the right atrium and take it out. But this was just below the hepatic veins. Sorry. No, it's not. Why is it not playing? Yeah, I think it's playing. Yeah. So here you can see a large thrombus in the IVC. So, and we get inside. It was a daunting task. I was mentally prepared that I'll have to open up this case. So we still give a trial of laparoscopy. So always, most of the cases, we start with lap. Even if we think it is inoperable, we start with lap. So inferior window, right psoas, IVC, right gonadal vein, that was easy to get. So then we clip the gonadal vein here because it was a huge mass. There was no chance of preserving it. Then again, working on the IVC and going up, working on the IVC. And then I found a large renal vein, but this was without a thrombus. Large renal vein with a branch, but there is no thrombus. So such a large thrombus, but it was not in this vein. So now I know that there must be another vein. So anyway, this was a renal vein, so that it tackled. After tackling it, again, so then I found a main renal vein with thrombus just behind it. So you can see the accessory renal vein, then there was another renal. Then I came to the opposite side, what I was telling you about inter-outer cable groove to get the left renal vein. So again, so dissect out the left renal vein. For this case, if I'm going to do a IVC thrombectomy, I need to tackle all the tributaries into the IVC. So I have the main renal vein. There was a renal artery just adjacent to the main renal vein. So that I found and I clipped it. Once I clip, the tumor rigidity size comes down. You can see the large IVC pregnant with thromba, accessory renal vein, and the liver. I need to go up, go above the tumor or thrombus in the IVC. So that area I defined. Then I came back and tackled this accessory renal vein. Otherwise, I was not getting any space. So to do anything, so this was tackled. And after that, went to the renal artery. One clip I had already applied earlier. Then the second and third clips go in, and then the renal artery is cut. And then I have the main. This is the part of IVC below the thrombus. So this plane also I need to dissect. So then I find this lumbar veins critical. You have to be very careful with lumbar veins. If they bleed, then they they will retract and it is very difficult to control them. So and dissect both the lumbars, then go to the left renal vein and dissect it out and get a SL loop across this. So plan was to control all the tributaries. So you need to be careful because the opposite kidney is dependent on this. So you need to be very careful when you're doing this. And then you get a vessel loop on the left. So again, I have tackled the lumbars on the IVC below the thrombus. So I get another vessel loop to control the IVC inflow from the lower limb. So we get another vessel loop there to control the IVC just below the thrombus. So these two are done. Then I go to the part of IVC above the thrombus. So this is very close to the hepatic veins. Need to be careful. The adrenal was coming in the way. So part of the adrenal that had not been dissected. So I dissect off the adrenal from the IVC, then take control of the adrenal vein there. A large adrenal vein was there. So that gets clipped and cut so that I get space to go around the suprathrombus IVC. So now I'm fairly sure I have all the tributaries in control. So this was a bit tricky. I didn't expect to find, but there was a large, there was a hepatic vein going to the liver. There was a small hepatic vein going into the liver there. So that also gets clipped. So this is directly originating from the IVC going there. So that gets clipped. And now I can go around that. So these were heart in the mouth events when you're doing this, a lot of adrenaline surge, anything can happen kind of thing. So open ray is always ready with you when you're doing this. So then now we get the bulldogs inside to clamp and control these tributaries. So all the three, the inferior one, the opposite renal vein, and then the suprathrombus infrahepatic IVC. So get another bulldog over there. Yeah. So once we have control on three, then comes the issue of opening up the IVC and delivering the thrombus. So then we make a ivotomy. So there's a incision on the thing. It is not bleeding much, probably because of the thrombus, also because of the control that we have on all the collaterals. So not much of bleeding and oozing is happening. So it generally delivers much easily. We have done other cases where but this was a large thrombus and it was a little bit adherent to the IVC wall, but there was no IVC wall. There was no IVC wall invasion. So we managed to get the thrombus not very elegantly, but still we remove the thrombus out and then take out the renal vein origin, and the kidney part is this is all IVC wall. You can see not much bleeding at all. So bleeding is very less. So because of the control. So then you take off the renal vein and now clean it as well as you can, and then start suturing the IVC, the cavotomy that has been done. So then you start closing the the large IVC opening or that you have made. Nowadays, with the advent of surgical, with the advent of the surgical robot, this is definitely easier, and a lot more surgeons, lot more robotics and surgeons are venturing into minimally invasive approach for renal vein thrombus and IVC thrombus. But with due diligence and patient dissection, I feel that even laparoscopically, this can be managed. So just go on and just before you close up the entire thing, we get a get an infant feeding tube inside to flush out all the small clots and air, and then this is the last step where we're suturing it up, suturing the IVC venocubotomy closed. This patient was, of course, T3B tumor. So we started him, this is about 1 year back. We started him an adjuvant, this immunotherapy. He's still doing okay, still is not having metastasis, and we are waiting for that ominous thing to happen. Yeah. Thank you. Thank you. Thank you, sir.
I think wonderful video, Prashant. The IVC thrombus is actually, we had to have steel balls to do it laparoscopically, because multiple times we have only like levels, up to level 0, we have done laparoscopically, even the right and left side we have done, but never we have attempted that, because maybe we thought that, okay, we can give a better result with, but this is a very good video. And as you said that the difficulty in the tumor delivery, tumor thrombus, sometimes it may be partially adherent. Like
Yes.
It may not be infiltrating the IVC.
Yeah, so
but it may
this is
partially
not the
adherent.
norm. So generally it comes out easily,
Comes out
but
easily.
yeah,
So
this
here
was
we can see it is like adherent to the
adherent to the IVC
renal
wall.
drain
Yeah.
by IVC, but at the same time it is not like we need to resect the IVC.
Yeah,
But it's
yeah.
a good courageous, like what do you call that? You need to have really steel balls to operate, but it's. But I think few approaches, like as you said, that when renal artery you are not able to get, we need to go to the intra-aortic
Intra-cable group, yes.
One more thing about the simple nephrectomy. Most of the time when we post in the OT, we post simple nephrectomy, which is just infection, but that becomes more difficult than the radical.
So simple nephrectomy is
it's a complex nephrectomy.
seldom simple.
It's
So
simple.
yeah.
Because most of the time it will be santhegranular spinonephritis or emphysematous spinonephritis, where the abscess would have like onto the psoas, it would have got stuck. Sometimes
Yes.
maybe one stuck to the colon also.
We had a very difficult case of an actinomycosis that was invading into the liver. So we got the surgical gastro guys in, and they did a hepatic resection also for that case. So
for us, most of the time it's very like we have extra thing because Kale is in the next OT.
yeah.
So we have any liver, anything, then we ask him to stand behind and then. I think.
Excellent video, really
Thank you.
nice.
Thank you.
And the last one was very, very good.
Yes.
Now, two questions I have. How does nephrectomies compare with laparoscopic nephrectomies compare with robotic nephrectomy? And what is the impact of this robotic nephrectomy on training students for laparoscopic nephrectomy?
Yeah, so excellent questions both. So let me answer this second question that I need to address, because a lot of students get enamored by the lure of a robot lying in the department. But I tell them the moment robot comes, your surgical exposure hands-on goes down, because you would never get to really practically do the robot. You'll only be assisting in a robotic surgery center. So that apart, where do we need a robot? So I strictly think in a urological practice for radical prostatectomy and a complex partial nephrectomy, these are the two indications to have a robot which will come handy and which will score over plain and simple laparoscopy. Another place is where we do a intracorporeal reconstruction or intracorporeal neobladder. You do a radical cystectomy, then you're creating a neobladder completely robotically, intracorporeally. Yes, so that may be another use. So these would be the three imperative indications for a robot. Yeah.
One more indication is where we like extension genital tuberculosis there, where the entire uterus is strictured and the bladder is a small thimble bladder. So where we use the ileum to replace the ureter and then augment the bladder.
Yeah. So any complex reconstruction you want to do, then probably robot would be.
One more advantage of robot, like this is from our experience, which we have learned. Like earlier we used to do, like we have our prostate levels are low in Jipmer because as it's a government hospital, patient comes little late to us. So, but we started with robotic cystectomy. That anatomy becomes clear. The anatomy of open surgery is different from the anatomy of a laparoscopic surgery.
I strictly feel that radical cystectomy or any minimal invasive radical cystectomy is a must, because in open it becomes very difficult to work in the depth. But here with the magnification and the illumination, so things become much easier when you're doing it laparoscopically.
The robotic also, like one advantage I feel is that we learn the anatomy and then you can extrapolate into laparoscopic also.
Yeah.
So now we stop doing lap cystectomy, robotic cystectomy, we are doing only lap cystectomy. But we slowly started getting whatever rejected from Chennai, prostates come.
Yeah.
So we do that. So
thank you.
Do you train all your students and nursing students in laparoscopy? Laparoscopy only, I see only advantage they have is that when they sit in the bedside, they get a lot of opportunity. Like sometimes scissors they need to use cut because we don't need to take an extra scissors to think. Sometimes we use the like they clips that they do the clipping, they do the like staplers they use.
So my
So-
training in my institute, so being here from Jipmer MS and Jipmer MCH, so Dr. Santosh used to be there. He used to say that the primary aim of the department is to train the residents. I kind of still follow that, and my residents do lap radical nephrectomy, cystectomy also before they finish. So they are like adequately trained. Thank you, boss. Thank you.
Thank you, sir. Thank you, Prashant, sir, for your excellent video collage. Thank you, chairpersons. I would request Dr. Chirag to present a moment of Dr. Prashant. Move on to the next session. Dr. Kirti Kumar Rathod from Professor Pediatric Surgery in AIIMS Jodhpur. Over to you, sir.
Good morning, all. It's a great pleasure to be here to present my work in front of my gurus, who are actually gurus of other gurus. So I did my MS from Jipmer, 2005 batch. So it's 25 years now when I joined. I had a lot of hairs those days, not a white beard. Most of you might not be recognizing me that easily. Jagdish sir, if you remember, I assisted you a Wilms tumor when I was first year on rotation posting in a baby. I still remember those cases. And now we are able to do these cases laparoscopically in small babies. Can you put on my... I was in unit 1 with AK sir and Kate sir. And though these two people are the foundation of whatever I'm doing and learned so far. So thank you, sir, again. The title of my topic is Tiny Patients, Tiny Incisions, Tiny Instruments, and Big Operations. So this is my experience of minimal neonatal surgery, which I've learned at multiple places and have optimized them to the level what I'm doing today. So as we all know, neonatal surgery itself is very difficult, and doing neonatal minimum surgery is even more difficult, but it is slowly gaining popularity. The challenges are the size of the patient, the physiology, and it is difficult for surgeons, of course. It is difficult for anesthetists. It is difficult for neonatologists as well. But we have to move on and start using the resources and the evolution which is happening in other countries. Why not we should do it here as well? So the initial challenges when we started doing it, what we face is our instruments were actually bigger than our patients. All of them sometimes. You have to stand very far from the patient. You can't see the patient. But luckily nowadays we are getting 3 mm small instruments. They're still long for 2 kgs or preterm babies, but still much better than what we had before. So I'm going to present my experience. This is just my experience from 2017 at AIIMS Jodhpur when I joined there. Started with hernias. I was doing MIS before joining AIIMS Jodhpur, but in AIIMS Jodhpur, we started with hernias and moved on to all the high-end cases, which I'll show. So far, done 87 cases, of which 59 are neonatal laparoscopy and 27 are neonatal thoracoscopy. The smallest baby was 1 day, and of course 30 day was the smallest weight was 1.8 kg. This is my duration of surgery, and the length of stay was depending from like hernia surgery can be 1 day, and the highest stay was 22 days. As I said, the most of my cases were hernia. They're around like 35 to 40%. Then of course pyloromyotomy. I started doing median sacral artery ligation in sacrococcygeal teratoma, which helps in decreasing the blood supply, so blood loss, and also the dissection of the tumor from above, ureterostomies, and congenital anomalies like due to atresia repairs, annular pancreas, midgut volvulus. Recently, last couple of years, I have done around Kasai portoenterostomies for biliary atresia, choroidal cyst, of course, In thoracoscopy, esophageal atresia repair, thoracic lobectomies, congenital diaphragmatic hernia repair, mediastinal cyst excisions, thoracic duct ligation, and lung biopsies. We of course had few complications. Had to do a redo pyloromyotomy once. 3 of the esophageal atresia patients leaked. Had to do a redo anastomosis with open approach, diversion once, and 1 patient was managed conservatively. I did a bronchial injury while excising a mediastinal cyst excision. I'll show the video of that. So these are my few videos, starting with congenital duodenal obstruction due to annular pancreas. So this was a newborn on 2 days old. So this is for the retraction of the liver. This is a baby around 2.5 kgs. I'm not able to forward the video, sorry. Excuse me. I have to forward some videos a bit. So this you can see I am trying to identify the obstructed part of the duodenum. This is the 3rd and the 4th collapse part of the duodenum, which is distal to the annular pancreas. Our instruments have also evolved over a period of time. So if you see in the other videos I'll show you, you will see more clarity and other finer instruments. So this is dissection performed around the collapsed duodenum. But as the annular pancreas was coming in, I decided to do a duodeno-jejunostomy in this patient. So you see, this is the enterotomy done in the jejunostomy, in the jejunum, just proximal jejunum. These are 3 mm instruments. This is a standard Kimura's duodenostomy or jejunostomy. And I started the anastomosis. So once we finish the posterior layer, I put a transanastomotic jejunal tube for feeding. It is very difficult to guide this laparoscopically. This is the tube I am talking about. And then the posterior layer is completed. Jejunostomy is placed. And then I finished the anterior anastomosis. This child also had Down syndrome, but was discharged successfully. Thoracoscopic repair of esophageal atresia and tracheostomal fistula. This is a rare variant where the lower pouch was overlying the upper pouch. The 1-day baby. This is the X-ray coiling of feeding tube in the neck. These are the variants. I'll skip this part. These were my ports. This is the actual patient in which the surgery was done. And this is a 5 mm camera and 3 mm thoracoscopic instruments. You can see the azygous vein. Behind that, we have the lower pouch of the. So generally, we'll find the fistula just next to the azygous vein. But however, in this particular case, the fistula was going quite higher up in the neck, and it was overlying over the upper esophageal pouch. It made my job a little difficult though. But that overlying pouch also helped me in holding the esophagus so that I don't damage the esophagus, which is used for anastomosis. So you see that esophagus over esophagus, there was no separate wall between the upper and the lower pouch. This is a dissection of the lower and the upper pouch. And I clipped the fistula with a clip, and this is the lower pouch, which is mobilized. This is the upper pouch mobilization. This is called a spaghetti maneuver, opening the upper pouch. And then anastomosis the upper pouch with the lower pouch thoracoscopic over a feeding tube. This is the completed anastomosis. If available, you can put a pleural patch on the anastomosis. Next case was malrotation with volvulus. So this case is also one of the very difficult cases. The anatomy we see, it's like all over the place. The gut is all over the place. There are multiple lads band. We don't know what is where. So derotation is difficult. So I start with mobilizing the lads band. After derotating, you see these are the lads band. Principle of surgery remains the same. You have to straighten the duodenum, widen the mesentery, do appendicectomy, and put bowel in the fetal position. Bowel walking at the end of the operation, and then we did widening of the colon and the thing, and then you do laparoscopic appendicectomy, and that's the end of the operation. This new thing which I started doing was medial sacral artery ligation in case of sacrococcygeal teratoma. I've done 6 cases so far. This also helps you in dissecting the abdominal part of the teratoma. So this was a female child. So uterine hitch was taken. Male child, you have to take an peritoneum of the bladder for dissection of the rectum. If this is the rectum you identify, and then we have to go retrorectal dissection. This time I didn't have 3 mm instruments, so I'm using 5 mm instruments. And this is what we have identified the median sacral artery. And then I clipped it, divided it. The operation from below becomes so easy that there is no blood at all in the tumor. It's one of the last videos. So this is a case of mid-external bronchial cyst. It was a 15-day-old child. You can see the cyst here in this X-ray. And this is the operation we started. I'm mobilizing the cyst. These are again 3 mm instruments. You see, I injured the left bronchus there. Now I'm doing the operation from the right side. The only lung which is ventilated in this baby is the left lung. And I injured that left lung. Now imagine the panic at the head end and about myself also. So there was no ventilation at all. But my anesthetist friend at the head end were so cooperative that they say, as of now, the patient is mobilized. If you can do whatever you can do as fast as possible, we'll let you do. So I was lucky enough that I was able to repair this bronchus, the left bronchus, which I injured thoracoscopically. You see the size of the instrument, it is 3 mm. The size of the bronchus is smaller than the instrument, it is 2 mm bronchus. This case was very well appreciated when I showed this in American pediatric surgery group, and it was presented as a special mention case in complications of pediatric surgery. And this child really did well. The lung was expanded post-operatively and was discharged quite early. So see, in emergency, I was not even able to find the same type of suture. So I got 2 Prolene, then I got 1 PDS, whatever you get. Because everyone is in panic. So okay, they're just giving you suture, whatever is available. This is one of the interesting case, but I was quite happy to pull it off this way. This is the end of the repair. Everyone's happy, cyst excised. This was all the courage of the head end people. I'll be honest, this is the immediate post-op X-ray, and then you see the lung is expanded both sides. This child really did well and gave us a lot of confidence. My last case, which I started doing now, is this one of the another most challenging surgeries, laparoscopic portoenterostomy for biliary atresia. This I am doing in ICG guidance. You see the liver is quite nodular and a lot of the dye is retained in the liver. This is done with ICG guidance. This is the difficult part, the dissection at the porta, where we have to dissect between the hepatic arteries and the portal veins. You see the fluorescence. Fluorescence at the portal plate is very obvious, which was not there before my dissection. You see the difference. This means that the dye is getting excreted and your anastomosis might work. So this is the start of the anastomosis. Now I let do the anterior part of the anastomosis done by my residents. And these are my patients on follow-up. Growing well, jaundice free, no scars. If this children needs future liver transplant, the surgeon will be very happy. There is no big incision, there is no scarring. There are only teeny tiny scars and a major operation was done. So as I said, this is challenging. It needs a lot of practice, patience, support from neonatologists, from anesthetists, from everyone, but it has several advantages. It has all the advantages of MIS. It has less bleeding, less wounds, infections, less size of the incision, less heat loss. It avoids the alterations in the neonatal physiologies, which happens with long open operations. Thank you very much. This is James Jodhpur.
Great presentation, Kirti. I think the challenge is using the small instruments. Actually, not adapted to neonatal medicine as such. That's also the size which you mentioned. The other thing which possibly mentioned in the small medicine passing, the anesthetist and the team in the they have to really support him to get things across.
Yes, sir.
Immediately do a quick thoracotomy and suture it.
I was absolutely, but the anesthetist said, patient is stable. If you can do it in like next 5, like till the patient is stable, you do it. So I said, because doing a thoracotomy will take at least 15 minutes, but this just put a suture inside and start doing it. So take everything out. Yeah. So taking all the instruments out and then remove the thoracoscopy instruments away from you and then do the thoracotomy, it will take a lot of time.
Remember, we had Dr. Savoji here who demonstrated, we had a mediastinal cyst with Dr. Savoji and 2 senior people doing the surgery. It was still difficult to take the cyst out with, took about 2.5 hours to do the dissection. Anyway, all kudos and credit. I think the other case which you showed, the TEF,
Yes.
where the upper pouch was really stuck and
Yes.
was going up into the neck.
Yes.
Did you have to dissect a lot to get the upper pouch?
The lower pouch was actually overlying the upper pouch. And then usually you will have those are separate. The fistula is opening in the trachea, but they were all stuck together. So it was a challenge to identify the fistula first. And then I used that common wall for my benefit so that I can handle that common wall and not handle the actual place where I have to do the anastomosis. So it was like I use it for my benefit, and that common wall was excised and then anastomosis was done. And unfortunately, it was my first case of thoracoscopic TF, and I got that case.
Challenge. But anyway, holding that wall and taking the sutures and leaving them in place, I think I'm sure it's a.
So I was not able to take the suture. So what I did is now I have only 3 mm ports and 1 5 mm port, and the clip applicator is 5 mm. So I use a 2.9 mm bronchoscope for that particular time through the 3 mm port. It was a bit dark, but then through my camera port, I use a 5 mm clip to clip the fistula. For only that small thing, I used 2.9 mm scope, then again shifted to 5 mm scope. So all these things, it should come in your mind spontaneously if you. I had a bronchoscope of 3 mm, so I used it, but it's very dark with that. For bronchoscopy or for subcutaneoscopic surgeries? Yeah, okay. Okay.
Best wishes for your future.
Thank you. Thank you.
Thank you, sir. I will request Dr. Jagdish to hand over momentum to Dr. Kirti.
Next, we have the lecture by Dr. Dilip Kumar Baliga, who was previously he was in the Directorate of Pondicherry Health. He will speak on Pied Pipers of Surgeons Village. Chairperson for this talk will be Dr. Jagadish, Dr. Unni Krishna and Nandakishore. They can sit in the front row and there. Here only, sir.
Good morning, everybody. I've been out of academics for more than 15 years now. So this talk is not on any new theories or techniques in surgery. So no slides. I can perceive a sigh of relief from my contemporaries because at our age, when the first slide comes, it takes a long time for us to decode the first abbreviation. By the time we have successfully decoded the abbreviation in the first slide, the 7th slide is already on. This talk is also not reminiscence of my experience as a surgeon in understaffed, suboptimally equipped, high volume government hospitals. I am alert to the fact that surgery now has far outgrown the times in which we worked, and my experiences will have no contemporary relevance or any utilitarian value. So I am going to talk on an overview of our profession, the profession of surgery, from my perspective. Then why this title, Pied Pipers of Surgeons' Will? The title has to be quite catchy to attract the attention of the audience. I learned it from Professor Satyaprakash. I don't know, my batchmates will remember. Way back in 1978, in the month of January, there was a tutorial for exam-going PGs, final year PGs of the whole of Madras University, conducted at CMC Vellore for 3 days. The whole gamut of theory lectures, clinics, and all. And the faculty was all the examiners of the Madras University in surgery at that time. The only person from Jipmer who was on the faculty panel was Professor Satyaprakash, and he was to give a theory topic at 8 a.m. in the morning. Usually the first class, it will be sparsely populated because we were all put up in the Vellore students' hostel. Naturally, people were having their breakfast and they won't turn up. But the topic of Dr. Satyaprakash that day was sponge cakes and sugar candy. That was the title of the talk. So the hall was full. Everybody wanted to know what that theory class was. For 1 hour, Professor Satyaprakash talked on the surgical anatomy of the penis, concentrating more on hypospadias and the importance of preserving the prepuce for future flaps. The downside of this title was that evening at dinner, one smart aleck MMC PG loudly inquired, "Hey, what is for dessert today?" And well-prepared colleagues of his shouted in unison, "Sponge cake and sugar candy from Pondi." You can imagine our red face. So let us have a look at this profession of surgery from humble beginnings. I'm talking about allopathic aspect of it. Humble beginnings as barber surgeons, assistants, who were doing only some tooth extractions, lancing of abscesses, or excision of a wart or something. They were secondary citizens in the field, like working under the instruction of a qualified, or at that time, a qualified physician. There was no formal teaching or training. It was learned through apprenticeship and was not a appreciable profession at that time. But by 18th century, a change occurred. The medical studies started incorporating surgery as a subject. This gave an opportunity, the benefit of a formal training, understanding of anatomy and pathology of human body. So surgery became a part of qualified, or rather established practitioners of medicine at that time, though there were not many takers, because any surgical exercise was fraught with excruciating pain, uncontrollable hemorrhage and shock, and even if the patient survived the surgery, succumbed later on to postoperative infection and sepsis. So it went on for some time like that. By the 18th century, a new thing happened. Gases were invented. Nitrous oxide came into picture. The dental surgeons now could confidently tell the patients, "Grin and bear it," while extracting the tooth. Ether, chloroform followed immediately, one after another, and many surgeons on both sides of the Atlantic started using the benefit of these gases to give a pain-free surgical procedure. Another important discovery at that time was use of aseptic handling of tissues and disinfection. This led to a gross reduction in the postoperative infection and mortality. The turn of the century, 20th century beginning, Landsteiner brought in blood grouping. Hitherto, unsafe blood transfusions became much more safer and were being used regularly since then. The First World War gave an opportunity to explore newer avenues of surgical therapies in trauma. More and more abdominal injuries, thoracic injuries were dealt with by the surgeons of that time with the help of anesthesia and blood transfusion, and a better understanding of opening up of these unexplored cavities became possible. By 1929, penicillin was discovered accidentally, and that was the beginning of a boom in the surgical enterprise. The Second World War, at the end of Second World War, surgery has been established as a profession of choice among the medical graduates. It gave them the courage and the boldness because they had an understanding of anatomy, physiology, and pathology now to attempt newer therapeutic solutions for many medical problems. This is the age of surgery as a liberal profession. From 1945 onwards, the surgeons start thinking independently of newer modalities of therapy, newer instrumentations, based on their knowledge, their skill sets, and the enterprise they had. So we started getting transplants from 1960 onwards, neurosurgery, cardiac surgery, cancer surgery, everything evolved in a big way. That doesn't mean an independent surgeon does not mean that there were no regulations. The regulations were not so much as surgeons, as a body of surgeons, but the regulations were built in the individual. The training itself imparted the ethics, the professional morals, communication skills, etc., and the responsibility of the decision-making of that individual surgeon was left to his own. This was a big responsibility to carry. I don't know, Jagdish is there, and few of my colleagues are there. During our postgraduate days, 4 principles were dropped into our heads every day, practically. One from different purposes. One is a surgeon is first a good doctor who can also have the training to operate. Always remember, a surgeon has to be a good doctor first, who has been trained to operate. The second one which was dropped into us is, which is Professor Ananthakrishna's favorite. If you have a hammer, everything looks like a nail. So before striking the hammer, make sure not once, twice, 3 times that it's not the nail. It is the nail rather. The third one is from Ardhashastra. Every problem, even if it's a physical one, has to be approached with Sama Bheda Dana Danda. Sama means, this is Chaudhry's favorite. Sama means you understand first what is the problem. Veda means in what way it is different from normal. Dana means can I compensate it in some way to get rid of that problem. If it cannot be done only, finally, the danda. The fourth one is approach every surgery as if it is your first one. There is nothing called a routine surgery. There is no minor surgery, major surgery. With every surgery, one has to be prepared as if it is his first surgery and alert to the fact that he may meet any eventuality. Every time I touch a scalpel, this is the one which resonates in my mind for whatever operation. The minute I pick up the scalpel, it resonates that this is your first surgery. But over the time, the surgeon started incorporating technology. As the technology developed, newer instrumentation, newer equipment, newer implants, as directed by the surgeons, started coming into the market. The surgeons dictated what they wanted. Technicians tried to devise it according to the choice. So artificial heart, valves, implants, meshes, all these started coming into the market. Something happened in the late 20th century, which completely changed the paradigm of the society. One is globalization and the market economy. With globalization and market economy, 4 major issues impacted our profession. One is industry. Now the industry started developing, refining more and more equipment, instruments, and other services, and started incorporating surgeons to use them and evaluate them. Instead of the thought process emanating from the surgeons, now it has reversed. The thought process of inventing, devising, refining of any equipment or surgical appliance started coming from the technology side, only to be used and appraised by the surgical fraternity. The funniest part of this is, I'll tell you an example. When the PPH stapler was introduced in early 90s, the Johnson & Johnson fellow came with this stapler. At the time, we were using linear stapler cutters and all in our hospital. So he came with this and said, I went through the brochure, I read the literature, how it is used and all that. They said, we'll give you, sir, why don't you try? I said, I'll try. Then immediately one man came and said, sir, I want to be inside the theater with you. I said, what for? He said, we have been instructed to be there to see that the surgeon deploys it in a proper way. Any improper deployment may lead to complications, which may bring bad name to the instrument. So we were instructed to stop the surgeon if he's doing something wrong and to tell him, no, this is not the way, and guide him how to do it. I looked at him and said, I'm very thankful your company is not manufacturing condoms. Anyway, he didn't come, I refused, and we were using like this. Then I read an article where in United States, it's a common practice. The hip implants many a times are being done by the technician who comes in, who has supplied the implant. He comes into the theater, and the surgeon who is doing it for the first time, he just observes how this fellow puts it in. So you can see how the shift has occurred with the entry of the industry into the field. The second one is IT industry. It became possible to gather, store a vast amount of data from multiple sources, and also to analyze it, compute it, and give certain derivatives out of the data. As a result of which, we started getting what, from the collective experience, we started getting what is known as EBM, the evidence-based medicine, be it for an investigation, for a treatment, what is the correct set of things one has to do. The third one is the government entered the picture. A lot of new acts were passed, keeping in mind the patient safety, public health concerns, consumer protection, hospital standards. There are nearly about 23 to 27 health acts in India today. The end result of this is, by the turn of 21st century, it has become impossible for any independent surgeon to start a hospital. The investment to comply with these laws and also to buy the high-end equipment and to maintain it is beyond the scope of any single individual. Hence the industry. Now it has become a business enterprise. Only the big business could enter. The business has entered who could establish these big hospitals, procure this expensive equipment. Naturally, when the big business has entered establishing healthcare services, they have brought in management professionals and marketing professionals. They run it as a business. This, instead of the supply meeting demand, a situation arose that a demand had to be created to meet the supply that is available now. Hence, you can see a lot of dilution in all the so-called indications for the use of all these high-tech investigations or high-end niche surgeries, which are good, but the indications are becoming diluted day by day. What has happened is today, an independent thinking surgeon who wants to make a decision, therapeutic decision, is no longer welcome. Or it is no longer possible. It is easier to follow the protocols for any given situation, any symptom, even no matter how sure you are of the diagnosis, follow the protocol, ask for the investigations. And based on the investigation, follow the gold standard treatment that is prescribed by the EBM at that point of time. You're safe. So what I see in our profession is, I'm not commenting adversely or anything. A time where the surgeon was thinking independently, making his own decisions based on his skills, his enterprise, how to do a procedure, how to handle a situation as far as the patient is concerned, has now changed to being dictated by extraneous factors what should be done. Individuality is sacrificed at the altar of expediency. There is no more challenge. In my days, it used to be a challenge to make a correct diagnosis, an abdominal mass. There was not much investigation. And once you're proven right, the exhilaration one felt. Nowadays, I don't know whether the present day surgeons will be able to feel that exhilaration of making a correct diagnosis because everything is obvious. Patient comes with the abdomen is no longer a Pandora's box. Today's surgeon goes in knowing fully well what is the anatomy, what is the pathology, is there any congenital anomaly, what is the direction of the blood vessels, where is the blood vessel. There is no Pandora's box unless he is operating on the wrong patient. That's the only situation where you'll be surprised. I really wonder. It's not a commentary on surgical training of today. It is a reflection on the society. The paradigm has really shifted. And if somebody asks me whether today I would like to take up this profession, I have very serious doubts about it. Very serious doubts about it. Thank you.
Open conventional vascular surgery in the endovascular era. It will be chaired by Dr. Jagdish.
And first thing first, thanks very much for Vishnu Prasad for inviting me for this meeting. I think the first time I'm, going to give a talk in Jipmer after passing out MBBS and MS in 1978. It's a privilege and intensely happy on this occasion. We have Dr. Dilip and Dr. Jagdish, our batchmates. The rest of the three people did not come. So I thought I'll take you to vascular and endovascular surgery, which is one of the youngest specialties. And I mean, in fact, as in other, so as usual, like all the other specialty, it is grown with a mix of science, art, and technology. So I shall dwell over the next 15 minutes of our experience with both endo as well as open surgery, and how we have to take the right patient-centric decision. What is the procedure best for the patient? I think I'm very happy here to be back on alma mater, and my gratefulness to all my teachers during MBBS and MS. Then, of course, Dr. Anandakrishnan was there, and Dr. Smiles also. They were our younger teachers, and we have had Satyaprakash sir, Dr. Sibal, and Dr. Chaudhary. I belong to the third unit. And a lot of things I learned from Jipmer teachers, how you dedicate your efforts to the patients and do the best for the patient. So I think Dilip and me were there in the third unit for almost 3 years full. So I remember them with gratitude, and they were the pillars, and they put down the principles of surgery ingrained into our minds. Now comes the older vascular surgeons, many of them foreigners there, you find the names. And Alexei Carrel got Nobel Prize for vascular surgery in 1904. And you have much bigger names, the person who did first aneurysm, Charles Dubos, French surgeon. Then, of course, coming to Professor Veera Reddy, he is the one who is a trailblazer in vascular surgery. He got training in the late 50s and established the first vascular unit in Madras Medical College in 60s. So I think he has been the legend in one way. Dr. Kulkarni was doing vascular surgery in Mumbai. And Professor Valitan, my mentor, he ignited the spark of vascular surgery after I undertook my CVTS and worked 3 years in the cardiac unit. And what his vision was really, and I really look back and remember him every day, whom we missed last July. He died at the ripe age of 91. What he did was, the unit was divided into 3: adult cardiology, pediatric cardiology, and vascular and thoracic. So that, although I wasn't very keen to go by that, but I think he said, this is the way to go. And I'm very grateful to him for giving me that decision at that point of time. The vascular system, all of us know. Now, my plan is to start from the carotid artery surgery, and many places I will not be going to the endovascular, which I do with an interventional radiologist. So what I do, endo open together, I have marked in yellow. Come down to the aortic arch, go on to the descending thoracic aorta, thoracoabdominal, and then the abdominal aorta and the peripheries. And we don't visit inside the brain, inside the pericardium, which means that we don't do cardiac surgery, don't do valves, don't do coronaries. But ascending aorta, often we do surgery. Now, as we all know, the best medical management has become very important in treating most of the diseases. In addition, it is add-on to endovascular and open surgeries. Sometimes it will be the management which is required for the patient. Specifics is problem. And another thing is that a combination of open and endovascular as hybrid has become very, very popular. Unlike the thoracoscopic and laparoscopic surgery, vascular surgery gives the route or pathway to all the vascular surgeries, endovascular surgeries to done transluminally. So that is the route, which is like the miss in thoracoscopic and laparoscopic surgeries. Now, coming to carotid surgery, most important is carotid endarterectomy. Then, of course, as I've written, aneurysms, carotid body tumor, and carotid bypasses, which is being done for occlusive disease as well as a stage 1 of hybrid aortic arch. It's a gold standard surgery. even 100,000 surgeries are being done in US. And of course, there's a good deal of carotid stenting as well, because that is it's a complementary procedure to open. Some patients are for endarterectomy, most patients for endarterectomy, but some patients, they require carotid stenting. Now, 70% symptomatic carotid disease in the form of transient ischemic attacks, or 80% or more on medical management remains or progresses higher, they require surgical intervention. That is after under G, of course, the plaque has been removed, and you say that the endarterectomized area and the arteriotomy vertically from ICA onto the CCA distal, the inera pruvi shunt is put in, and here we have put the vein patch mostly. 90% or more, it is vein patch. But just sometimes when there's varicosity or the veins are not prominent and this fibrous, we give Edacron patch or a Gore-Tex patch. So that's the difference. On your right side, you can see with just clamping and going ahead with the surgery, it's only half of systemic, which is not enough. Many times we may get away, but it's not enough. When you put in the shunt, about 200 cc per minute, blood will be going to the brain, the ipsilateral brain, and you have the subsystemic blood pressure there. That's 90% stenosis, that the green arrow showing, and that is the plaque in toto removed. And that is the result of surgery. You can see that the hairline continuity is transformed into a wide ICA, which is open with the vein patch. Here, yet another example. And this is the plaque removed in toto. You can see that that's a bovine pericardial patch we have put in for arteriotomy repair. In my own experience, we had 305. I don't think there has been any stroke for about 150 to 200 patients. Only in the first few patients we have had problem. Otherwise, we have not had stroke. And I was fortunate to do a 52 number in 2016. That is still a record at Sri Chitra, because almost one case a week. Often it is 2 cases a week because we don't operate. We don't get 52 working weeks like that. This as an example that how open surgery for carotid is still viewed as the first choice. This is 12 years after surgery, the vein patch, how the artery looks almost near normal. This is an example. On the top is the carotid artery aneurysm, and you can see that we have not excised, but we are given ascending aorta ICA bypass, and the patient's recovered. This is another aneurysm of the ICA, much deeper, almost 3-4 centimeters below base of skull. I had quite a time to repair this. I think I have the pointer. So this is the bifurcation. You have it at least 4-5 centimeters deeper. It was a struggle going and getting a direct repair. I could not put the shunt, but patient got away. Maybe the cross circulation was good. This is an example of carotid body tumor. You can see the splayed carotid bifurcation, a very vascular tumor, it's benign tumor, but as it grows, it may turn malignant. You can see that is the picture showing the big tumor there. And here we have cleared the carotid bifurcation. The splayed arteries are seen. Still, as you clear and get the ICA on out of this tumor, which is stuck peri-adventitially. So there's a problem. I've done about 35, 40 cases. One patient, there was a small hole I had to repair. But in one case, it was a real accident. It tore the ICA into 2. So we had to clamp and do a direct repair. We were not prepared with the shunt. Again, I think, luckily for us, there will be a good deal of compression by the tumor. So that ipsilateral blood supply may not be normal. And the patient did not have any problem and recovered. This is a patient that yellow arrow, this green, the blue arrow, you see, all 3 branches are occluded, and patient cannot even sit up or lie down because of this giddiness and she developed a stroke and recovered from there. When she came, you can see that all 3 vessels, this is called a flame sign. It's a typical Takayasu's disease, have done ascending aorta, right carotid bypass, and patient recovered thereafter. Then, of course, it was continuing. There was a small pseudoaneurysm happening because of Takayasu and steroid. Other side, I had to do a graft from here to here and then take care of it because both internal carotid artery revascularization is deadly because it will produce massive reperfusion edema and even continuous seizure or even death. Now coming down, you see this is a subclavian aneurysm repaired with a Dacron graft. This is a thoracic outlet syndrome with stenosis here. You can see the arching subclavian. We decompressed the subclavian, the thoracic outlet syndrome in the form of scalenus anticus division, cervical rib, and directly repaired the subclavian artery. Then coming down to the hybrid procedure for aortic arch. These are the 4 indications that you have an atherosclerotic aneurysm, Stanford B aortic dissection, residual after post Stanford A, because when the ascending aorta is repaired, the entire arch and DTA is not repaired. So that area becomes bulging and we have to do a hybrid. The aortic trauma, again, it's rare to go for hybrid arch. In one case, we had to do. Now, we have a series of 78, 71 cases I had done in Sri Chitra, 7 in the place SUT that I work these days. And of the total of 162 trans endovascular repair for thoracic aorta. Now, this is a large aneurysm here, you can see, and that is the luminogram. And this is the Stanford B dissection starting from the subclavian artery going right down to the bifurcation. And we have again these 3 options. You can have conventional surgery and total endovascular and hybrid. Actually, hybrid is the general appreciated and performed surgery world over because this open surgery calls for total circulatory arrest. Otherwise, there will be axillary antegrade cerebral perfusion. And total endovascular, you're working in the area of disease with thrombus. You can push clot and then patient can have the stroke. And the problem is that there are only hardly few takers for total endovascular. Whereas here, we are combining the carotid revascularization by bringing the grafts from ascending aorta to carotid so that they have an alternative replaced interposition graft. And the arch is relined by the stent graft. So the diseased area is covered. There's a new aorta, and the carotids and subclavians are getting blood supply. I'll be showing in other situations. So usually we do it staged unless it's an open or there's a severe problem with the patient. Here you can see we have a total supraortic debranching in about 35 and hemi debranching in about 40 cases. And 2, because of patient's conditions, we did not do debranching. We just took the chance of occluded the subclavian, put it elderly patient in rupture situation. So here you can see that all 3 branches are brachiocephalic branches are connected to the ascending aorta. Here in emergency, we have done a carotid even left intentionally occluded subclavian artery and put the stent graft and patient survived. So this is the 3 grafts we do. Either we take a inverted, bifurcated graft to both carotids from ascending aorta, or on take only a 10 mm and then add on the other grafts here. So for 3 vessels, we have right carotid, left carotid, and left subclavian. This one is a typical procedure, a bifurcated graft, an additional limb to subclavian, 2 stent grafts to cover from ascending aorta, the last 2 centimeters to the celiac axis. This one is a again intensely occluded subclavian. We have done an ascending aorta left carotid. This is the first patient I did in 2007. And he is still working in Middle East, and he is very happy. So I was not sure whether we should connect a carotid to carotid and get both carotid into trouble at 35 years. So I've done an ascending aorta to left carotid, but of late, we do only both carotids requirement. We do an ascending aortic graft. Otherwise, we do a carotid, which we have done several. Now, this is the example. After doing the revascularization of the carotid from ascending aorta or right carotid, this is the delivery system of the endograft, and that is the one which will be about 22 to 24 mm only when it is collapsed. And then that is the one through a stiff guide where it goes in, it opens out to the appropriate aortic sizes. We have sizes thoracic from 28 to 36, even 40. Abdominal aorta is much smaller, as we know. It will be 22 or 24 only. So this is just a picture of endovascular we do for thoracic. A few examples. A 78-year-old man come with hemothorax, just about okay hemodynamics. So if I have to go and repair this, and firstly, even the angiogram does not clearly show, but the distal aorta is not filling in this case. So we knew that there's a rupture somewhere. So we have to search for it. We can open chest only on circulatory arrest, which will be another 20, 30 years before we find. So what we did was we did a ascending aorta bicarotid, again left subclavian occluded intentionally, and then putting a 20 centimeter long stent graft. And this man survived for 5 years thereafter. We drained the hemothorax in a graded manner. This patient, which I already shown, pan supraortic debranching with 2 stents. This is the cover page of Journal of Vascular Surgery. And this patient, you can see the tear in the subclavian, post-subclavian. It is the Stanford B dissection. And he also came with hemothorax, the same complicated, the management issue given to us by the patient. So we did the carotid bypass and drained the hemothorax. He's coming for follow-up regularly. Now, this patient is again an example of malperfusion. Stanford B aortic dissection was being treated in Nagarkoil, our next district, and he started having abdominal pain when BP was controlled, and this was very severe, and an angiogram showed it was from the SMA was originating from false lumen. So I was forced to do a iliac artery SMA bypass and send him off for 3 months, and then did the on circulatory arrest, we did the replacement, reunited aorta there, that's a distal anastomosis. He's a youngish patient, 45 years, hypertensive. Coming to the upper DTA lesions, this is the coax segment which you excise. And once we excise this is only some 6-7 millimeter lumen. There will be cephalobrachial hypertension and low BP in the legs. So we have excised it and connected an interposition graft. This patient, you can see that this is a 2-in-1 angiogram. You can see aorta almost like interruption, and then the grafting from left subclavian artery to descending thoracic aorta. This was a 15-year past surgery, and this was accepted in the EJCTVS as, we used the Chitra graft for the polyester graft for the bypass. This is another complex case. You can see that this coarctation and aneurysm, very difficult case, but on circulatory arrest, we have treated both coarctation and the dissection in one go with a synthetic graft. This is a deadly situation for any surgeon anyway. A 44-year-old man had MI apparently in Dubai, but there was no features of MI. Then they left him. And 6 months later, when he had chest pain again, this was the picture. This is the coarctation and massive aneurysm, extensive aneurysm, just above the diaphragm. Now, this case, I thought it's too heavy for any surgery, and we cannot do endovascular also, too endovascular. All these intercostals will be blocked. This, again, you have to do too much of procedure. Money will be in the order of 12-13 lakhs. So I thought we will go back to Ramayana situation, Lord Sri Rama. Instead of going directly onto this, what I thought I'll avoid it, did the ascending aorta, abdominal aorta bypass. And this area was also dissected. The flap was there. I have to excise. So I wasn't sure how this will, how long it will work. We kept him on antihypertensive and waited for 1 year. Then this was looking good. So we did the ambulaxa closure of the coarctation. You can see that almost like a magic, the DTA from subclavian to almost above the diaphragm up to this level, it is missing. And he's alive. There's totally the DTA is thrombosed, and that is the last picture. You can see that this missing here, and he's okay. So sometimes indirect procedure also is handy and useful. Now coming to the thoracoabdominal aneurysm, these are the 5 types, and we have a series of 128 cases. Now, I think after my retirement, I dare not do because it needs a big team, big residency program, and complex procedure. Time is 6-8 hours. Fortunately, nobody has come. And I think if at all they come still on my name, they go to Sri Chitra. I have a very efficient and capable surgeon there out of 12 people whom we have first trained in MCH. He is able to handle it. So that is what the total number of operations, a male preponderant patient, young age for Takayasus. Some of the examples, this is the perfusion strategy we have made. The aorta, from aorta, this cannula will bring blood, and we have a connection here. It will be given to two inera prui shunts, and this will be to the siphon blood will go to the femoral artery, and we have two clamps at either end of the aneurysm. That is to go to celiac, SMA, and both renals. Now that is the one post subclavian aneurysm here, proximal aneurysm. You can see the roomy aneurysmal sac there. And that is you can see that this is cut out left renal artery on top of it. That inera prui is perfusing. And this is the completed procedure. And this is another, this actually, his name I remember, Murali, I did in 1997. He is the man who contributed to my confidence because he came with pain. He's been coming for the last 5 years. Then when he came, when I was alone, looking at the unit, the bone is eroded there. You can see that descending thoracic aorta. This is a plain non-contrast CT. You can see this is the luminogram. That is the thrombus, double contrast. The heart is pushed only 1/3 of the size of the aorta, and he wouldn't go home. He said his life is intolerable. So he forced me to operate the whole length of 18 mm graft going from post-subclavian to above bifurcation. Two vessels were open, left renal and SMA. And this is the picture 1 year after DSA and 10 years. I hear that he is alive. I have not seen him for 5 years after my superannuation. This patient is the ilio SMA bypass done for mesenteric angina as well as for mesenteric, when there is a malperfusion. This patient, interesting man, 65-year-old, is a retired chief engineer, came on a wheelchair. He says he can walk only 3 steps, and he has pain, subcritical ischemia of the lower limbs. He also had a small aneurysm juxtarenal, so it's a little danger of knocking out his kidneys in open theater. Either it is endovascular also. So I opted again a thoracic aorta bifemoral. 5 years after surgery, he is able to walk whatever kilometer he wants to. So sometimes this not attacking this area and going away from disease and giving grafting is also useful. There's a large abdominal aortic aneurysm there. And this subset of juxtarenal aortic aneurysm, only 10% of AAAs are juxtarenal. You can see that the renal arteries look like they are floating. So there's no way you can get a clamp. So here, looking at the adjuvants that we have, that sometimes we can divide the left renal vein, and in contradistinction to right renal vein, because left renal vein has got suprarenals going above, gonadus coming below, and one or two the intercostal veins draining. So it is, good amount of venous drainage possibilities. They're not immediately, maybe after 2-3 days. So there are reports to say that that can be divided when you are looking at a dangerous situation. Next, what is also in literature, that you can put an interrenal clamp with the space, because many times the renals are not in the same level. So I'll put an interrenal clamp. This will be perfused by the system, by the patient's own circulation. This we will put a renal infusion, what we give for the renal transplant. So, and that ultimately you get a 4-5 millimeter of area. After all, this is infrarenal grown upwards. So that is the postoperative volume rendered image. You can see that we have got a series of about 30. This is also published in Indian Journal of Vascular and Endovascular Surgery. Now, coming to the last subset, not last but one subset, this is the open procedure which is shown, and that you have to do the laparotomy. It's a big laparotomy. This one is the EVAR. We have a series of 21, And predominantly, we kept abdomen as option for open surgery. Unlike the literature and the latest people run into technology thinking almost 70 to 80% they are doing EVAR, but slowly now it's coming down because many of my friends, vascular surgeons in abroad, they are explanting 3 to 4 stent grafts and doing open after 5-10 years. So I think I'll just come to in my last slide. So here, this as aortic and iliac is a single limb that will be passed through retrogradely from femoral upwards. And second, on the left side, we have the other limb, and there's a small gate here, and will be fixed up. This surgery is a good surgery in extremely aged patient, system compromised patient, or unwilling patient. But generally, it is found that 10% rupture after about 7 to 8 years. So you have a much elder patient. So obviously the indication could have been open at that point of time. So it's still controversial, but people do understand open is still good procedure, and we have to have a selective indication for endovascular. This it's a rare situation. In infrarenal aneurysm, the inferior mesenteric is blocked, and in this patient had abdominal aortic as well as biiliac aneurysm. So now if you and internal iliac also on this side. If you lose IMA, both internal iliacs, it's a big problem. Bladder vascularity, colonic and rectosigmoid, you can end up with the ischemia of the colon. So this one, it's not a very common procedure, but this is a graft limb into the aorto right femoral limb. At times, we were forced to do when patients not in great shape. We do a crossover femoral using an ATEM. We had recently, last 6 months, I have 2 patients. They are doing well. In good risk patient, usually I don't like to do that because there is a small chance that you get into some problem with any of the graft, then is normal limb also in big trouble. So unless there is no other way, we don't do this crossover femoral, but is reserved for extreme conditions. This is in fact, in superficial femoral artery side, there are 22 types of stents, and every year they come up with new one. That is a kind of a conduit vessel, femoral artery, high propensity for occlusion. That is the stent seen. You can see that there's just enough a little irregular popliteal artery and 1 or 2 anterior tibial, and the peroneal is seen, posterior tibial is not seen. And then obviously he has to have a bypass. So done a femoropopliteal, we got just enough stem, and the patient is okay from critical limb ischemia, potential to go for an amputation. Peripheral procedures, aortofemoral, we have a series of 82. Femorodistal, little more, of course, 140 plus. Thoracic aortofemoral for rare indications of it, 12-1. So to conclude, these 2 procedures are not competitive, complementary. You choose the right procedure for the patient, and patient will decide which procedure is best for him. So generally, our attitude in Sri Chitra Institute and now in SUT has been choose the patient's requirement and the choice. Not that if I cannot do, if I cannot do something that I don't want to send for a referral. The right kind of patient-friendly and patient-centric treatment is offered with a combination of an interventional radiologist. Now, the vascular medicines are adjuvant and bridging as well as standalone. Sometimes they require only vascular medications, no need for surgery at that point of like a 50% coronary artery need not be stented, 50% femoral artery need not, a 50 or 60 asymptomatic carotid need not be stented. This, as alluded by Dr. Dilip, these are happening, but I think these are not good practices. So we have to have the inner discipline to decide what is best for the patient. And good medicines are their best medical management, really shrinks the plaque. It helps the patients continue, you control the risk factors, stop smoking, get hypertension control. These medications are good. And in our experience, abdomen is best for open, and thoracic, I think we can go for stent graft procedures. And a good risk patient, less than 70 years or 75, I think still there is a supreme chance for open procedure. So this is the new block of 9-story, 2 blocks are there, newly inaugurated at Sri Chitra. And this is the SUT hospital. Part of it is the king's brother used to live. He donated half of this is hospital. And this is the new building, 7-story, where now Ranjit Hari and we are working. And thank you very much for your kind attention. And I have a my own teacher, Dr. Anandakrishnan, listening to my talk. And this is a kind of I would say, a capsule version of what has gone on. And there's a lot more, but I have only kept on aorta and arterial. Thank you so much.
Thank you, sir. So any comments from the chairpersons?
I have nothing to say because I don't do any vascular surgery, but I deal with all the complications because all the amputations come to me. So yes, Unni was the only one of us 6 who went for super specialty. So in our batch, we had Santosh Pai, Permal Rajan, myself, Dilip, Lokur, and Munni. But Munni is the only one and he's done remarkably well, and I'm impressed. Varadarajan and Achuba Singh were the 1 year junior, they joined us later on. That's why I'm very Varadarajan and Achuba Singh, they joined 1 year after us, but they got exemption, they wrote the exam with me. But strictly 75 means these 6. Varadarajan and Achuba Singh joined in 76 and then wrote the exam with us. Munni will correct me.
Hello, sir. Very nice talk. I'm Sudan Nagarajan. I was 2000 batch, MS, and I left for the US for further training. I remember meeting Professor Anandakrishnan and Dr. Jagdish before that. And I don't know if you remember, sir, you mentioned to me that I was always interested in cardiac, and he mentioned to me, think about vascular because that's where the future is. So I ended up training in both because I couldn't take my love of cardiac surgery away, but I also wanted to learn endovascular and open vascular. What you said is absolutely true, but there are certain things that when we face in practice, it's very similar to PCI, like coronary stents. If you have a patient who comes to you with, let's say, 2-vessel blockage, if it's your family, you want PCI first, and you really don't want to subject them to a stenotomy and bypass. Same goes for aortic surgery as well. The culture in the US is still endovascular. So I'm not sure what I would want if I am 60 years old, healthy, and if I can still undergo an open surgery, I might as well end up choosing endovascular, even though I know that open is very durable. The reintervention rates are very high for endovascular with years. But if there's a surgeon who's good at explanting them, I would take my chances.
I think better you don't take that chance. I have only done 2 explantations and 1 patient died. Other patient developed some bowel problem. Fortunately, I could push him out to the primary, whoever put it in first. See, what happens is the infrarenal aneurysms treated by an EVAR, where the bare metal stents protrude in and around that viscerorenal segment. Okay, now you need to go for a hiatal clamp to pull it out. In that case, a lot of things can occur, a lot of thrombus, a lot of confusion, and then the renal vessels can be, they can be compromised. And people are getting proficient because a lot of them are getting explanted. Initially, I have explanted to some 10 years back. So we are very clear about it. See, in fact, I have also know the reason why in ER there's endoleak. See, thoracic aneurysm, when you put in, there is some amount of thrombus, and the stent graft is 10 to 20% oversizing. And with the thrombus, this graft will close the intercostals. Intercostals are not very big, except the Adam cubic at T10. Whereas in the infrarenal segment, you put the stent graft, aorto right renal stays very high up in the above the bifurcation. So and then you are adding a limb to the other area. I mean, you have a stem there, and then you put in the left limb. The problem here is half of aorta is under low pressure, and there's a roomy area. So any lumbar opening there, it will feed that area. And there is one cause called where there can be endotension without endoleak. And this can proceed downwards, it can buckle, and then there's a EVA2 trial, which I said at 8 years, 10% will rupture. EVAR1, EVAR2 also now.
They can get infected too.
Infection is comparatively rare, but only thing is operating room is not as sterile as cath lab, from my experience. That attention to asepsis is not there in a cath lab. The way they scrub, I've seen one cardiologist after scrubbing, pushing the door and going. So what is the point? He says only 1 or 2 fingers, but no, I'm just saying. So they don't have that feel. And my feeling is when I have done 360 procedures, but for that day, for that patient, it's my first. So I go like that only, and none of my previous patients will save me. So this is your own, and the burden of surveillance so much. Every 6 months, 1 year, you need a CT, 250 to 300 irradiations with X-ray, and you have kidney getting screwed up with contrast. Once we do open, if you have done a good job, patient get to Kannur or Bangalore or Madras, wherever, they call me, the limb pulses are felt, ultrasound is okay, I'm fine. So there's no need for follow-up. That is an extreme. But the other one is, it's like a, continuous worry. Continuous worry, and there is a sequelae now going. People are developing leukemia. And if at 58 years you put an EVAR and at 65 you are going to operate, so your first indication is wrong. And the patient is, this is happening with many procedures. What I feel, there is a free room in abdominal aorta below the main graft. So there's a low, there's no circulation. So that will invite any lumbars which open. All patients will not have open lumbars at that point. So that is one problem. And carotid stenting also, carotid endarterectomy, they are doing about 100,000. But the intervention, people are also going for, keyhole surgery. Can you do a small incision? Will you put big incision? That big incision, 8 centimeter, it won't be seen. It will be along the anterior or sternocleidomastoid. Many times I cannot differentiate whether I have done left or right. Patient will say this is the time. So I think scar and other things in Indian conditions, it's only a small worry, but life ahead, it's a big worry.
Sir, we are about to start the inauguration.
Sure. I have also finished.
Request Dr. Dilip or Balika to hand over a memento to Dr. Unikrishna. Thank you, chairpersons. I welcome you all back after the inauguration ceremony. We'll be next having the presentations from the Silver Jubilee Alumni. The first one will be by Dr. Muthukumara Swamy from Rela Institute. I would request Dr. Sudan, Dr. Ranganath, and Dr. Ranjit Vihari to chair the session.
Okay. So, good afternoon to my teachers and my dear colleagues. I'm very happy to be here to talk to you about my journey in this surgical field, which started in 2000 and going on still. My presentation is of not a very academic and just my introspection into my path to the surgical career. So I started, became a part of the member Jipmer family in 1994 when I joined MBBS and developed many relationships with, which are lasting still more than 25 to 30 years. And people have been with me since, some of them have been with me since school days. So, and yes, sir, that too. So, my strong liking to surgery, if my friends know that I never attended medicine posting in my first clinical year, I just attended surgical posting. If you remember, I don't know, Sonal was my SR, and there were 2 SRs in S1 unit who were very good. Shivam, along with Shivam, somebody else was there. I don't remember his name. They had a strong impression on me. So and then I was in the B batch, I rotated to S2, that is Sarah, Professor Smiles. And these after that, I didn't feel like attending any other posting. Honestly speaking, I didn't attend 1 month of my medicine. I passed through gynec because of Professor Asha. She was strict. So I made up my mind, and I am going to surgical career. When my entrance results came, I didn't have the courage to come and see. I got a ranking which was slightly behind our batch leader, Shankar Raman. Luckily, he got in the general quota, so we all could fit in into surgery. So my residency, I was lucky in the lucky draw, which Professor Anantakishan gave us. I took Unit 2 along with where is Ranganath, and I had great seniors who supported me, Venki and Rajesh, I can't forget, because I didn't have a vehicle to travel. So they will take my night calls for at least till I bought my vehicle. And then I had my mobile phone, funny, and some of the great SRs, Arul, Vinu, and Ravi. I might forget some people who had a great impression on me to pursue. Even the first month of my posting, I was all even think of quitting and then continuing with. I learned a lot of basic surgical skills, knowledge, how to see patients, where the clinical acumen, all which remain till today, started in my JS in 2000. Of course, we had a good parties on weekends, and Professor Sharath used to lead the parties. He's not, he couldn't come here. Sorry. And then I continued for a couple of years in surgery. I changed from Unit 2 to Unit 1, which is a very academic unit under Professor Anantakishan, where methodical workup of patients, clinical examinations, and teaching rounds were very well instilled on me. And when we speak, we need to speak correctly and precisely, and no nonsense was accepted. Next, I did a long posting in pediatric surgery where I saw Professor Jagdish's commitment to kids, working style, and he gave a lot of operating chances in children, which is useful to me after 20 years when I am in the pediatric liver transplantation. So overall, a lot of operating experience, learning, and a great family of this. If people remember who attended this farewell party of Professor Smiles, and I think all the important members of our surgical family are there, and varied people with varied skill sets and varied knowledge and varied working styles. And I passed through almost all the 4 units. I was an intern in S4 with Professor Srinivasan, PG with Professor Smiles, SR in S1, and another SRship, brief SRship in S3 with Pai and Dr. Jagdish. And then I did the pediatric surgery as well. So all the great pillars of our surgical family I had worked with. They may not have liked me, or maybe. So, but I had enjoyed all the postings with good and bad. So after a brief stint outside in trying to get my MCH and roaming around in Pondicherry, I came back to Jipmer as an assistant professor in 2010, I suppose. I worked under Professor Kate, where I had an independent hand to decide whatever I wanted to do. And I started my journey in thought of going into a specialized field of HBB surgery, which was very nascent in India. Didn't have many avenues. I sort of became a nomadic, trying to fit in somewhere, and slowly I started seeking ways to find out what it leads, what my life leads, and a lot of questions and no answers. So finally, I landed up in shows in France with Professor Bismuth. That was a lucky chance because I did couple of rotations in Doctors Without Borders, which gave me the insight into a very unexplored path in France where surgical skills are very good and the training programs are very good. So 2 stints in Doctors Without Borders in Africa, I used to pass to Paris, and then where I'll have a briefing and a debriefing and meet people who approach things. Then I slowly understood the system. And I used to discuss with Dr. Sharath, who gave me some contacts as well. But finally, it happened in 2011 when I started exploring Doctors Without Borders in 2006 to 8. So 4-5 years later, when due to lack of access to French healthcare system, French how to go about it, I didn't have any clue. So finally, I plunged into Henry B. Smith Institute with 4 rotations in Paris, and then I decided to continue further. So I lived there in Paris as a learned French, understood their people, and more importantly, I worked with pioneers in the field. This is Mr. Bismuth. He was 82 when I took this picture. He used to come to clinics every day, and he used to sit in office and see patients. Of course, he was not operating, but I could see the system he has established called Center Epidemiology Center, which is a private public system. So much more like Jipmer, it's a public hospital where they explore the limits of surgical skills and treatment plan. Where some of the Professor Shirky, if you are in HPP, you'll know him, used to say that they used to walk on blood when they started doing HPP surgery and transplants when they didn't understand. So the most knowledge gained was that during working with them, seeing them at the first hand, how they plan, how they think about how they always try to push the frontiers wherever they are and try to be excellent in their career. So then that excellence is achieved only by one thing I understood, that is innovation and research. So I did my PhD after that for 3 years and got my PhD in 2017. And then some of my work experience included a staff, which is the first staff I attended since beginning in the morning at 8 o'clock. Everybody should be there. Nobody else allowed into the room after 8. Then the operating theater experience, where sterility, patient safety, which are the things new to me, where they will do a checklist, where they will make ensure every product is traced with a traceability. And of course, how to work with many people of various descent, Chinese, Brazilian, Costa Rican, Japanese, and Afghan. This guy is from Egypt. He is now living in England. So some Spanish, Argentinian. So multiple people with varied talents, and you need to find peace with them and work with them, all trying to progress in their field. So I summarize. Overall, I like the French healthcare system, where it is socialized medicine, which should suit India, where corporatization like United States is happening. And as I highlighted, working with multiple people of varied talents, varied skills requires some sort of sacrifice and understanding the common goal of working for patient care, even though you may have differences. And the first time I was introduced to protocol-based management to achieve common minimum of patient safety, common minimum of results, where results are audited and discussed and tried to be prevented. And I can't speak about American system, but I feel French system has a good work-life balance, which is more important, which I am really going through now, because we are almost like American system where there is no work-life balance, especially in corporate hospitals, where I am working now, which is always trying to achieve success. So back to India, I got married when I was in France. So I had to end my nomadic life seeking peace with whatever I have. So no, sir. Then I was lucky to come and meet Professor Ella. I had met him when I was seeking to do HBB training in 2010, but he accepted me in 2017, and so I started working with him since 2018. It is I and unit, which there are 17. There were about 15 surgeons working with him, and everybody tries to outperform others with respect to patient care, surgical skills, aptitude, and intelligence. My stint with working with a multidisciplinary team helps avoid conflicts, also try to achieve your goal. So this is our team. Some of them are not there. I'm there in the back somewhere. So still continuing to work with them. What lies ahead, I have no clue. Whether to continue to achieve in surgical skill, surgical excellence, or become a leader, establish my own path, and with background experience, I don't know, or find a new path. So or a mix of all the three. And to conclude, I will not advise anybody. I think from my life in the surgery, I learned that we need to have a constant search to have a excellence, constant effort to push your limits. If we try concentrating, and even though you may not be very skilled or very talented, anything is possible if you persevere. So it is never too late. I started my HBB training when I was 35, 36, I think. So still going on, and I have not achieved my goal yet, I feel. Overall, everybody should have fun in what they do. Enjoy what you're doing. Whether you work or don't work, doesn't matter. So to end the quote with the poem, the naming, I started two roads diverged. I took the path one. I don't know which, if I had achieved what I had intended to. So still I'm in a path searching. So I don't know what I'm going to do. I hope it all matters. Thank you. I can't say anything more than this. I am where I am because of my surgical gurus, my senior colleagues who have given me time and energy, my juniors who have helped me even with many things, my patients and my family who have suffered a lot. Thank you.
Thank you, sir. Comments from the chairpersons?
Muthu is my batchmate, and nothing much to say because everybody's life and their paths are almost similar. I don't know with Professor Smiles, Chief, and all with us, what we look forward to doing and what we end up finally having done. We don't know.
Yeah.
And for example, I had a chance of being in Jipmer, but when I left, I had left for a very specific reason. But yesterday night, when we were discussing with our batchmates, what we miss in life is entirely philosophical. And this one day when I come here, what all we have lost by living a place like this, living the students, living a post which would have, given acclaim, a lot of students, like how we respect sir and chief and Jagdish sir and all. So it is difficult situation. People have moved abroad, like Shankar and Sudan, they're with us and now they are in another field. Each trying to aim for excellence or achieve something which still we feel we have not reached that stage. And
Maybe when you come for Golden Jubilee.
Yeah. And another thing is the Golden Jubilee is far away. We don't know. God's grace, we have to be all healthy and if it's
I
not
hope you are healthy.
anything else.
Well, Muthu has been a very close friend of mine since we were probably around 10 to 12 years of age, and I've been a very close observant of the path that he has taken. And I'm constantly inspired by his ability to meet challenges, forge a new path, given the obstacles that have come his way, and still find meaning in what he does. I think that is a great lesson for all of us to imbibe and continue to look forward.
Thank you, Shankar.
Yeah, I think, it's a little bit of philosophy mixed. My own personal look at is there is something called destiny. God from above decides. But then the other point is 15-year-old girl asks her grandfather, if you say destiny is going, it's already decided, my future, everything, then why should I work? So the grandfather says, or maybe the God says, destiny, yes, I decide, but there are places I have left as you like.
Yeah.
So that is left to you. So you keep working hard, be perseverant, you will come there. But sometimes everybody goes to confusion. I thought of resigning from Srijatra 3 times. But I think how foolish it should have been. Because I don't think any other place it could have started vascular surgery, started ECMO first time in the country, started our own indigenous craft, and have a reasonably good idea about what we should proceed with. Which way we should. Sorry? BCRO award, that is only Srijatra. That too, I got it after retiring. I was given 2 years extension.
Okay, sir.
The person selected from CMC, she had an accident. So I got first extension, I got that BCRO award, I got on March 27. Retirement is like the month you retire, April 7. So
April 30th, I decided, that is 10 minutes, I decided this is the best time and the music is good. So, don't wait for the way this sitting after retirement, 1 year, 2 years. So nobody, when director, all the people knows, no send off meeting, nothing. I just quit it because Ranjit also was calling. Okay, thank you.
Thank you, sir.
Muthu, I just want, I think, sir, 2, 3 nice points you raised. Because I was hoping that the whole meeting will be like this, but I was like confused. It has to be the torn between academic and philosophy. And it's somehow we all got trained. It's like almost I thought it's like a package made because during training you have the minimum like every computer is packed. And then when it is sold, it has to be like empty, but it has got all the ingredients. But when it's sold, each person, the data that gets stored in each computer is different. But when it's all of us move like that. And I'm still not clear. Whenever even a person asks success, achievement, these are very subjective. Personal.
Very subjective.
So,
It's too, it takes years to find out that it's very subjective.
I at the end of my life also, I will not find what is success and what is achievement because it's a destiny, it's a journey. And I feel as long as you enjoy the day, as long as you enjoy doing surgery,
I couldn't put my photos of enjoyment.
Enjoy what you're doing during that period. As long as you're happy doing it, I think
Yeah,
you should continue.
you should.
I
should.
don't
I
think
think
there is
it's
any success or achievement which it should be the goal because the goal should be to be doing what we are happily doing, and that's I think all of us are doing. Sir, we always want to.
Yeah, I just want to congratulate him because he had some problems, but in spite of that, he came out of that and he's now doing well and he's happy. I asked him today also. He's very happy today. That is the one thing I was.
Thank you, sir. All started from your blessings.
So that problem has come out. Very good.
Thank you, sir.
I have one comment.
Yeah.
Very, very impressive talk, very impressive journey. I think we all have journeys and each one is different. But I think the work is towards a common goal to be happy. Just a clarification, there is work-life balance in the US.
Yeah.
And it depends on where you want to be.
Yeah.
So
I said
I think Shankar knows it better than I do.
So, no, it's an impression we have. So that's why I wanted to contrast.
It's a new term that's cropped up in the last decade. I don't think there was much discussion about work-life balance in our generation of our teachers.
No.
But our common, I think Jipmer taught us how to be hungry because our mentors are still hungry and for making themselves better. So I think we inherently, we acquired it, just like that from our mentors with ease. I think that's what we have to be thankful for. We are chasing perfection, which we would never be able to achieve
unless you are.
as long as you are chasing it, you're going to be happy.
Yeah.
Thank you.
Thank you.
Ranganath walked away just like he used to do in the good old days. The goal cannot be defined. There is only one goal, that is perfection. And that goal is never achievable. But you have to travel towards that. Excellence is the path. What we try to do in the formative years is create a desire to improve. Not to create the end point of our training. That has never been the goal. To develop in you a desire to go out and then make a name for yourself. And that's why I wrote some years ago, those of you who are on the Facebook would have read, that when I meet all of you, I feel that I am surrounded by the redwood trees of California, because all of you have grown so much higher than what Smile and I and Jagdish reached in our times. And that's a matter of great pride for us. This from Robert Frost's poem, The Road Not Taken. I'm very fond of that. His horse feels bad. Why is this fellow going on this path? It doesn't lead anywhere. And it cannot speak, it turns to look at him and say, what are you doing? And he comes to that fork in the path in the woods. And he looks down one side and he looks down the other side, not much difference, but one had a little more of vegetation and all that, as if it was not disturbed. He knew if he follows that path which looked disturbed, it'll lead to a crowd and you'll be lost in a crowd. Therefore, he took the path which was undisturbed. And then he said that made all the difference. So I think the purpose in life that we have to develop in academics is the only wealth that you can never reduce is knowledge, which increases the more you share. All other wealth, if you share, the amount left with you is lost, but knowledge is not like that. So never feel that you have reached somewhere, because that is the stage when decline will start. And I was telling you about Ikigai today morning.
Yeah.
You must have, when you get up in the morning, purpose in life, that this is what I'm going to do. That is the solution to feeling well and feeling that you are still going along a path worth pursuing. So never bother about where it will lead. If you're happy doing what you're doing, if you're productive about in your daily life, if you can bring, our profession is like that. If you can bring happiness to some people or most of the people that you manage, that's enough. That path of excellence, perfection, we'll see later on. That's not the goal. But never feel uncertain whether I am taken the wrong path. Robert Frost never felt that.
Oh, okay.
He said that made all the difference.
All the difference. That's why I just changed a little bit.
Your bismuth has made all the difference to you.
Yeah.
Is it not?
Yes.
You ended up with bismuth. Many other people would not have gone to France because of the language and other issues and all that. So I think you have to be happy with the path taken. That's all. That doesn't matter. There's nothing like road not taken in my mind.
Okay, sir. Thank you, sir.
Thank you, sir. Now I would request Dr. Unikrishnan to present a memento to Dr. Muthukumara. Memento, please. Next in the Silver Jubilee Alumni presentation, we'll be having Ranganath. I would request Gomati Shankar, Dr. Muthukumara Swamy, Dr. Ranjit Vijayari, and Dr. 1 minute, please share the session.
I should have bargained with Dr. Vishnu Prasad to put my talk first. Muthu started off on such a somber note, I wasn't able to think whether it was a surgical session or a psychotherapy session. They will all get depressed. They'll think we are all going through acute midlife crisis. Yeah, Muthu, come on. Next time, Vishnu Prasad will not call us at all. Make them feel happy. Come on, make them feel happy. Make them feel the joy of surgery. Now, I wanted to start off with this, but most of it was described in detail by all of them. So I'll just put it here. There are hundreds of surgical residency training programs in India, all over the country. Most of them will do what the first person is doing. They'll hold your hand and train you how to walk on ice. A few of them will actually tell you how to climb a peak. But Jipmer, it'll make you climb the peak. And Jipmer surgical training, as far as when we were concerned, it'll make sure that you stay there on the peak, enjoy yourself, give a nice smile, have a donut and a cup of joy in casino, and then look for other peaks to conquer. That's the stereotypical Jipmer surgical training from when I was here. So this is another peak, totally off the beaten track. I had given a list of surgical topics, and Jipmer surgery department, as usual, picked up a topic which does not involve too much of surgery. This is a research project which I had done under the Multidisciplinary Research Unit project of the Department of Biotechnology and Health Research in Nizams. I am Ranganath. I am, all of you know, for Dr. Unikrishnan. I am a surgical oncologist working in the Nizam's Institute of Medical Sciences, Hyderabad. So the essential research question which we were looking at is, does the copy number alteration of the cyclin D1 gene have a prognostic impact in patients with oral squamous cell cancers? We did this study because we know there is a huge number of new patients of oral cancer coming to OPs across the country, be it general surgery, radiation oncology, surgical oncology. Most of these patients come with locally advanced or loco-regionally advanced disease. The primary modes of therapy, which include surgery, radiation, and chemotherapy, have sort of reached their limits in improving their quality of life and improving their survival. So there is a felt need for looking at different kinds of treatment to help improve the survival and the recurrence-free rates. We also know from studies in breast cancer and other cancers that this particular gene, cyclin D1 gene, and the cyclin D1 gene CDK4, CD6 complex, they basic function is to increase the proportion of tumor cells which go into the mitotic phase of the cell cycle. So you find ways of blocking them. First of all, you demonstrate that they are overexpressed in a particular cancer. And then if they are overexpressed, you find ways of blocking them. So you prevent the cancer cells from proliferating further. So it's already in use in breast cancer for a long time now, 5 years or so. There are Indian generics available, and they are available at very economical rates, 3,000, 4,000, 5,000 per month, right? So that's the basis behind doing this particular study. The aim of the study was to correlate the cyclin D1 gene copy number alteration, number one, with clinico-pathological prognostic factors already known, and also loco-regional recurrence in oral squamous cell cancers. Our objectives were many. The primary objective was to determine whether the cyclin D1 was in fact altered or not. The secondary objectives were to correlate it with the known pathological and clinical poor prognostic factors, to correlate it with tumor recurrence, and to see if we can use a simpler technique. Not all hospitals will have what we used, a polymerase chain reaction technique to look for genes. IHC every hospital has right now. So to see whether the IHC results correlate very well with the PCR results. It was a prospective observational study which we did between a period of 6 months, January to August, a small subset of oral cancer patients. The tumor tissue was taken for analysis of CCND1 gene by QF-PCR, and the patient's own blood was taken as control. So the tumor should demonstrate an upregulation of the CCND1 gene. Along with this, an immunohistochemical analysis of cyclin D1 and Ki67, which is an indicator of high mitosis, was also performed. Statistical analysis was done. Demographics, in general, most of the patients were male, as is common with oral cancers in India. 95% had some form of tobacco use. More than 60% had combined tobacco and alcohol use. The commonest symptoms were a non-healing painful ulcers. Some of them presented with trismus, difficulty in mouth opening and restriction of mouth opening, which is also a part of the disease profile in the Southeast Asian region because of submucous fibrosis. Most of the patients, as you can see, are in the pathological stage 3 and 4. More than 80% were 3 and 4. Now, when we did the quantitative PCR and correlated it with the clinical and other pathological factors, we found that the patients in which the cyclin D1 gene overexpression was there, it correlated with a high grade of the tumor. It also correlated with a significant, highly significant p-value with the local recurrence and very strongly with IHC. When we took local recurrence as the key variable and we correlated it with the other variables in multivariate analysis, positive margins tended towards significance. It did not reach 0.05 because of possibly the low numbers, but PCR positive cyclin D1 overexpression definitely had a p-value of 0.05. That's it. So what were our objectives and did we achieve? Now, the first objective, the primary objective, was to see whether cyclin D1 gene was overexpressed in oral squamous cancers. We found that yes, more than 42% of our small study cohort did indeed have an overexpression of the gene. Number two, the secondary objectives whether we were able to correlate this copy number alteration with the other things, with other clinical and pathological prognostic factors. Yes, we were able to correlate it with the high grade of the tumor and with local recurrence. Takes us to the third objective, which we did. Survival is still ongoing. The follow-up is still ongoing, but our recent audit of the data about 6 months back also shows that the survival also is tending towards significance. So definitely a cyclin D1 gene number is increased, and that correlates with local recurrence and survival. A strong correlation with immunohistochemistry and QFPCR was seen. So what did we infer from all this? These are all technical terms. So what did we infer from all this? So it has a statistically significant association with recurrence. So if you have an oral cancer which does not have any other poor or high risk factors with respect to clinical or pathological criteria, and if that particular tumor has a CCND1 gene overexpression, that patient, in spite of having a T1N0 or a T2N0, that patient will have a local recurrence. That is the first and the most important inference. Surgical margins, of course, we know this, but this was proven again in this study, that surgical margins have a very great importance on the chances of loco-regional recurrence. Margin-free resection is a sine qua non of treatment of oral cancers. Can we do a simpler test if I do not have QFPCR available in my hospital? If I do not have a person who is trained to do it or to interpret it, can I use some other method? IHC correlates very well. Sometimes the gene number increases, but the gene expression in terms of the proteomics will not be there. So you will not get an IHC positive. So you need, before you say that you can do IHC, you need to do this. Wherever the gene number is increased, the IHC also should be positive on the tumor cells. So if that correlation is there, then IHC can be used as a surrogate for QFPCR. It was published in the South Asian Journals of Cancer, and acknowledge all the patients who consented to be part of the study, the multidisciplinary research unit, part of Department of Health Research, ICMR, co-investigators, all the supporting doctors, my entire team, residents, staff, everybody. And this was just an attempt to change or to show the evolving nature of a surgeon. The surgeon in the first picture is what is traditionally thought of when you think of a surgeon. The surgeon in the second picture is what is going to happen now, what is happening now, and what is going to happen further. This is all the era of personalized therapy. When I took surgical oncology, it was thought to be a highly mutilating specialty. In fact, there were people who thought that surgical oncology is not a specialty at all because it is not organ specific. People operate from head to toe on all cancers. It is not a specialty. But then it is a disease-based specialty. And there are things which we learn in surgical oncology which probably help us treat the patient better. So we are progressing and evolving towards personalized therapy, and we are evolving towards what I would like to call a molecular surgeon. These are the giants on whose shoulders we have stood and on whose shoulders I'm standing right now, and I'm able to give a talk. Thank you. Thank you for a patient listening. Geneticist in the house was my co-investigator, so that came in the co-investigator. Incidentally, I missed one dinner because I showed the presentation to her and she asked the same question.
Thank you, sir. Request chairpersons to give their comments.
Thank you, sir. Thank you for the wonderful presentation. Did you look at the subsites, sir? Like tongue, buccal mucosa, was there any difference in the expression in subsites, sir?
No, this was a small cohort. So majority of our patients, as usual, belong to the oral tongue. Out of 63, about 37 was oral tongue, and the rest were buccal mucosa and alveolus. So it didn't make much of a difference. We tried doing it statistically, but we couldn't derive anything out of it. So we decided to go ahead with analyzing the group as a whole, because idea was that the insulting factor, the causating factor, will be the same for the oral cavity subsite. So, but we restricted ourselves to the oral cavity. We didn't go into the oropharynx or into the hypopharynx.
Good work. Genetics is going to stay in the future. I am looking into the genetics as I've discussed for the in transplant as well. I have a question with respect to this study. How many patients the gene mutation positive at positive margins.
That was, I showed you that.
There was an overlap of
There was an overlap, but not in more than 8 or 9 patients. So in those patients, we were not able to say that this is the margin positivity has led to the recurrence and this is the factor which has contributed. But there were a group of patients where
If you remove that,
nothing
I think the significance will be lost.
possible. We tried doing that.
Thank you.
Patients who were probably initially cyclin negative.
Yeah.
When they have a recurrent and metastatic disease, that tumor might turn to be cyclin
We
positive.
need to look at that. That's the next idea. That's the idea for the next research project. Because same thing happens in breast. You may have a set of molecular phenotype in a breast cancer at presentation, but invariably when the patient comes with a metastasis, you are supposed to, it is mandatory to biopsy the recurrence or the metastasis to prove that it has not converted into a different form. Usually it de-differentiates.
Yes.
Thank you, sir.
I have time, I think, just I had 20 minutes on the schedule. So I would like to take just 5 minutes. I told them also, I would like to give a couple of books to Sir, Chief and Dr. Jagdish, if they don't mind. Sir, I think you will like it. You can open it. Oh, no, it's not written by me. I read it when I was a child, and it was one of the reasons they were moving towards surgical option. I know, that's why I said, I hope you have. Thank you so much. I read Cancer, Cocaine and Courage. The story of William Harrison, the person who started surgical discrimination. But it's not a good very difficult surgery. Difficult to get the very knowledge of what it is. I guess, sir, if there's biography or watching, I'll say biography.
Thank you, sir. Next, we have Dr. Arivadagan. And I would request the chairpersons, Dr. Muthukumara Swami, Dr. Ranjit Vijayhari, and Dr. Ranganathan. Please chair.
Actually, after listening for the last 30 minutes, I'm not even sure whether I need slides to talk. I would have been happier without these slides. There are a lot of slides that I'm not even, I mean, I'll be happy if we don't have to show them. Anyways, it's a mixed feeling being here. Like many of our batchmates, we're all homegrown boys, brought up, lived in Pondicherry, and moved out for various reasons. And anytime, any day, this place is home. We have grown here, and for me, my son was also born here. My wife studied here, so wherever we go, we never feel that we have lost this touch. In neurosurgery training, my chief used to say, "Your umbilical cord is still not cut. Behave yourself." So that was for my next institute where I went. But as far as I'm concerned, my umbilical cord still stays here because this is where we were first born. Though we moved out, I think, like what Shankar and others we were talking, whatever specialty we go, whatever specialty we have chosen, the basement, the foundation was laid to us here. For a tall building like Burj Khalifa or whatever, you see what is seen outside, but no one sees what has been buried in, and that's the foundation. The strongest strength that all of us have got, which have been laid by our teachers, is the foundation which is here. We have built upon it with various support from various people. We have become different kind of trees. Like sir said, we have not grown into a group of redwood trees. I mean, some are tall, some are short, some are bushy. But then all of us are happy the way we have grown. That's what I'm telling. All of us, that's what I said. We haven't grown to be a uniform trees. No, but what I mean to say is our foundation has been very clear. We were told how to behave as human being, as a good doctor, as an ethical person, and we have grown in a different ways. But nevertheless, our umbilical cord is still here. So these are the two institutes I have been blessed to be. Started in Jipmer, 1994, 10 years of Jipmer life. Then I moved to another institute which is in Bangalore, not far away. I joined residency of neurosurgery in 2003, and I still continue to be there. In between, I came to Pondicherry back for a short stint of 3 months because I wasn't able to get married staying there. I won't get leave. My parents used to scold that you have to come. Unless you come, nobody will give you a girl to get married. So I came here for 4 months, got married, and went back again. So that was more than working. It was a reason to, like Muthu said, to I mean, we had to come back again home to get married. We were not able to get things done while working outside. And I'm at Nimans, Bangalore. I'm talking of networks, but these are some networks which have formed here again, and these have been for life. You can see, like from our MBBS days, why these are important even now today. These are our, like we say, to call a friend for emergency. These are our crisis calls. I can call at any of them for any reason at any point of time without hesitation, and I'm very clear that no one will say no in this group. Or for that matter, I keep talking when we see our Jipma. No, I keep telling them we are an Illuminati group because we are pervasive. We are in different specialties all over the country and world. Anywhere you need a help, medical, non-medical, the first thing is who is a Jipmaret in that place, and make a call. You know that that person will not refuse your call for any help. That is something which is ingrained in us, medical or non-medical, whichever country, whichever state. You know that same way. You know that when you get a call from a Jipmaret whom you do not know, you know that you have to respond and answer. That is something which has stuck. I'm sure this is there with every institute. We are from Jipmer, so we believe in that. And this is our batch. When I search for these photos, I realized we belong to a era of residency where there were no phones, no cameras. Only Muttu and Sudan had. This is courtesy Sudan. Sudan was that time beyond our generation, who had a small camera who could get all those photos. And I think Joshi had. So very few photos. And so this was our starting point. Now we are very happy that we are doing well and happy with in different this ones. And of course, blessings. We are always, and like I said, I'm very sure that we are always blessed. We know that wherever we are, we know that the blessings of our teachers remain, which is unconditional, unlimited, and unending. There is no doubt in our minds. I trained in S4 with Dr. Srinivasan and Dr. Kadambari. When I searched, I was feeling really bad that I didn't have any photos with them. Like you said, you told of S2 parties and S3 parties. Unfortunately, I think there were not many S4 parties. We hardly had parties in our unit. So no photos at the corollary. But I'm sure that their blessings are always with us at any point of time. So now I'll get back to topics. A lot of slides, I'll just skip them as much as possible. My idea was to talk when this was raised. I wanted to see in neurosurgery what I can talk, and I chose this because I do this kind of surgeries. This, even in neurosurgery, it is not a very common one, and I like this because this is one surgery which is not commonly being aware even in medical community, and this is done in patients who are significantly crippled because of epilepsy, and surgery brings in a lot of relief to them. With if you look at the outcomes percentages, nearly 70% of them can be completely out of seizure. And seizure is such a stigma in our society still, and even functionally disabling. So I'll skip. If you look at numbers, the prevalence in India is 0.3 to 1%. That is, every 3 out of 1,000 people in India have epilepsy, and it's higher in rural period. And this is important because it's not very well known. Among all those patients who have epilepsy, 1/3 of them do not respond to medicines. What 2/3 will respond to medicines and they are treated with medicines. Among the third who do not respond to medicines, 10% of them can be actually surgically remediable candidates, which means 10% of patients with epilepsy, if they are properly evaluated, worked up, can actually have a better life after a surgery. It's a question of doing a investigation and treating them. If you look at the, like we talked about supply demand in the morning, so you understood that there are easily about 1 lakh people who can get better in India with surgery. And if you look at the number of centers who offer this surgery, it's about 18 or 19 all over the India, more concentrated in South India than North India. Why it is so? Because of awareness. Second is it needs workup, dedicated team, and unless your investigations and dedicated workup is not done, your surgery is going to fail. Is this some new surgery? No, not at all. If you look at this surgery was way back in 1890s. Victor Horsley, like many surgeries, many general surgery, Victor Horsley did the first surgery for tumor. Then it was very much popularized during World Wars because of scar epilepsy. People realized that if you can resect, if you can remove that part, then it can result in control of seizures. Then in 1950s, 1930s, after all this development, in 1970s, when medicines came, when with the like in any other specialty, when medicines came which can control surgery, which can control seizures, the surgery fell through. Same applies for psychosurgery and many surgery. Wherever medicine started working, people thought surgery was not necessary and stopped. But nevertheless, there is a small group of patients who will benefit from surgery. And then now with all these new developments, MRI and electrophysiology, EEG, and all those techniques, we are able to identify the group of people who will be able to respond to surgery after if they have been declared as non-controlled with medicines. There are different types of surgeries. My talk is, I'm just going to say why it helps, why it works is we identify in the patients who do not respond to medicines. They are declared as drug-resistant epilepsy. And in that 10% of them, if we do proper workup, the main objective is to identify a part of the brain or a focus which is causing the seizure. If that part of the brain can be safely removed, then it can result in control of seizures. As good as there is an irritant, you remove the irritant, the problem stops. So that is a basic premise in which it works. But the irritant may be of different format, different cause. It can be tumor, it can be infection, it can be scar. In many cases, it can be dysplasia. The child, as the child is born or during the in utero, a part of the brain does not develop well, which we call it as dysplasia, where it's a normal cortical organization which has become disorganized, and that dysplastic tissue is very, very epileptogenic. So you identify that and you operate and remove, and they will never respond to medicines. We know that if you see a scan and patient has even small seizures, we know that during the course of few years, they will become drug resistant. And if you operate and remove that part, then patient can be having a seizure-free long life. That is what is important. They have a very good quality of life if you can remove their seizures from their life. So we do various types of surgeries. The surgery is defined by the focus. We resect when it is small. When it is very large, involving large areas of brain, we disconnect that part of the brain so that it's like removing the bad or a rotten tomato from a basket. You remove that, then at least the remaining part will remain. So it's a disconnection. We ablate when the lesion is, the irritant or epileptogenic focus is in the deep in the brain where open surgery is not safer. And last is we modulate when we cannot identify a single area. When there are 2-3 areas where you cannot remove, then we do neuromodulation where we stimulate the brain with generators so that the epileptogenic activity is reversed. So all these surgical techniques are done, and of course I will not go into detail because these are I will try to keep it simple. There are different techniques named for different procedures, but what is important to understand is some of them will give us seizure freedom, meaning if you can resect a focal lesion, then you know that you can give a complete seizure freedom, a very good chance. Where it is very diffuse, you know that it may not give a freedom, but at least you'll be able to reduce the seizure load. So even if a person who gets a seizure 5 times a day, you make it once a week, it's a good thing for him. You make a generalized seizure, convert into a small, simple seizure, which is controlled. It's a quality of life improves. They do a lot of change in their way they live. And again, most of them, if you look at it, they're all very young people. This, as you know, it's not like Parkinson's, which come or old age, which comes in the disease which comes in old age. These children or these patients who are, most of them are in young age or in their reproductive age. So you make a difference in their life, they can actually benefit or they can contribute better to the society. I'm again not going to details. The philosophy is you identify by various investigations the epileptogenic zone that is defined as the finite minimal area of the brain, which when removed can result in control of seizure or cessation of seizure. So there are various studies which are done. So idea is to identify that. There is another philosophy which is now, this again is not old, this is for more than 78 years. In France, like Muthu said, the concept is different. The European thinking, Indian thinking, American thinking is different, where the American literature and science was going towards identifying the foci. So two different philosophy. One philosophy says you identify a small area of the brain, you remove that. That is a focus-based thought process. Whereas in Europe, in France, Jean Talleyrand, Bangkok, they were thinking of network. It is not the focus. Maybe the focus starts, but what it causes a network within the brain, because brain is so much interconnected that even if you remove that small focus, because of the organization of the network, you may still need to have seizures. So they talked about a principal focus, but there are secondary zones, tertiary zones, which are already formed by the time you start treating. You need to address the networks also. Of course, I think probably the reality is somewhere in between, but we need to understand that. So like I said, when we treat a patient, our goal is to identify the area of the brain which when removed can cause seizures, can cause cessation of seizures. Second is to decide whether we have any red flags before advising surgery, because every surgeon wants to make sure that at the end of surgery, we give a better quality of life or a better outcome for the patient. And third, when we remove that part of the brain, whether it is going to add additional morbidity to the patient. So these three things are the cardinal questions. And there are many investigations which are done. I will again not go into that. We have evidence. This is one of the very few randomized control studies which were done in neurosurgery, where they studied. One of the most common condition which causes drug-resistant epilepsy, which are amenable for surgery, is a hippocampal sclerosis. I will just keep it simple. The hippocampus of a person gets glyosed, and if that is there, they don't respond to medicines. What is described is that you operate and remove that. This was all done in 100 years ago by Penfield and all that. You remove that part of the temporal lobe and hippocampus, and then seizure stops. So the study was done to prove that surgery is better than medicine. And then as you can see, the number need to treat was only 3, meaning the number of patients following surgery with seizure control is nearly 60%, versus those who are continued on best medical care was 5%. So this was one of the very few randomized control trials done in neurosurgery, which showed that surgery is better than medicine in a drug-resistant epilepsy for this particular cause. I'll just show a few cases just to make this is a 17-year-old man who had just to give an example, hippocampus sclerosis. This is how it looks. This is a brain in coronal section. This is how a normal hippocampus looks in the MRI. And this is how a sclerotic gliotic hippocampus looks. It is hyperintense and there is atrophy. You can see this ventricle is slightly dilated. So this is how we pick up from MRI. And then patient premises patient has a drug-resistant epilepsy. MRI shows this region, which is like a scar in the brain. And then we do EEG, video EEG, and then identify that the activity comes actually from the right temporal lobe. And once we have this MRI video EEG concordance, we operate. These patients, even if you continue on medicines for decades, they will not have seizure control. Like I showed in the RCT, the chance of medicine controlling this was 3 to 5%, not more than that. So this is what we do. We operate and we remove the area which is marked in green, that part of the temporal lobe we remove. And then this oblong structure is a hippocampus, we remove that. So this is how the histopathology, or this is how the gross specimen looks. This is how normal hippocampus looks. These are autopsy specimens. This is how a normal hippocampus looks on section. And this is how the sclerosed hippocampus looks after the section. You can see the normal morphology is lost, gray-white is lost, it is shrunken, it is shriveled. And once you remove this part of the brain, the patient can achieve a good seizure freedom. So That is just an example. I showed that because that is the most common situation where we need to do surgery. Of course, there are many other conditions where there are focal lesions in the brain which causes seizures which are uncontrolled. We don't operate them for tumor because they don't grow. Like for example, there's a small tumor here in the left temporal lobe and there's another small tumor here in a different patient. There's a small lesion in the frontal lobe. These tumors are very very grade 1, I mean very low, slow growing lesions, but they can cause drug-resistant epilepsy. We operate and remove that, then patient gets seizure freedom. So these are all conditions which are amenable for surgery. Like these are examples for first one, disrupting, resect the lesion, results in control of seizures. And I think this is what I was telling regarding dysplasia. All these are dysplasias. These are patients with normal brain, no other condition. At the time of their growth or at the time of their birth, some part of the brain has not developed as normal. You can see comparing to the on the other side left brain, this part is dysplastic. This dysplasia can be as small as like this or as big as this. So based on the area of involvement, we'll decide whether it can be resected or it can be disconnected. And during this surgery, like I said, the third premise, like we all were taught primum non nocere. In your quest to remove the brain, you should also be sure that you don't cause an additional damage. For example, in this young boy, 20-year-old boy, he has a lesion which is this dysplasia is sitting exactly in the part of the brain what we call as leg motor cortex. So you remove this, that patient is going to have deficit. This child, I saw him from 11 years of age. I was also not confident to remove. His father was also, after many years, when it became uncontrolled, they decided what we did fMRI, which showed exactly that his motor cortex is on the dysplasia, diffusion tensor imaging. Then what we did is, what I did is we implanted his brain. We did initially a craniotomy, put electrodes on this was again a hope to see whether the seizure is exactly coming from there or somewhere else. So we have this technique called where we do craniotomy. These are subdural grids which are placed on the brain, and each numbered area is a contact. So we can record electrical activity from that particular contact, and then we do surgery, put the electrode, close the craniotomy, bring the patient to EEG lab and record the activity for 2 to 3 days. During that time, patient will be allowed to have seizure. You then identify which contact or which area of the brain actually causes seizures. And it's a two-way street. You can identify which area causes seizures. And also, because of those contacts, we can stimulate each and every contact by giving a small current and then map the function, which part of the brain results in what function. So this is how there's a depth electrode which goes into the brain. So you can identify this particular, if you stimulate this contact, it results in movement of thigh, adduction, abduction. So you can identify which is epileptogenic. You can also map which is the functional area, then decide if you remove whether it will cause deficit. So this patient underwent surgery. This is like, you can like I said, each and every point can be mapped by giving a small current. This patient underwent surgery. He developed a minimal foot weakness. He walks with a dragging feet, but his seizures are stopped. He's happy. So this is what I said. When we operate and remove, resect, the caveat comes is resect with safety. We use a lot of techniques. I will not go into detail. Just to say that we need to operate sometimes keeping the patient awake, and we stimulate. This is a young girl, 26-year-old girl, again, who had a lesion in the right motor cortex. So what we do this very commonly in our practice. Patients who have lesions, either tumor or any lesion in the electron cortex, we do surgery awake under local anesthesia. Patient is awake, not intubated, only on oxygen by mask. And then the surgery is done. First, we map the brain with the electrode, identify the motor cortex, various techniques. We call it phase reversal. And then we stimulate the brain with a bipolar current, and then identify that so this shows us that when the current is given, bipolar current is given, it shows us the activity coming from the brain to the hand, and also the movement of the finger. These are spontaneous movements because of the current. We can identify the movement of fingers and feet, and that you map the functional zone. So this is when you stimulate, you can see that the hand is moving. And during surgery, during removal also, that if the patient is developing any deficit or not. So you can resect, and you can control your surgical removal based on whether patient develops a deficit or not. And this gives at least me a lot of confidence while operating to make sure that patient does not have a new problem. Of course, there are sometimes lesions which are very deep. This is a small hematoma in the hypothalamus. So this is one of the most epileptogenic reasons. So when patient has, then we operate, we come through the brain and then try and then remove that. And these are, like I said, the lesions can be as small as few millimeters to as big as involving whole of brain. The second concept is when it's too large. The second concept of is to disrupt when it disconnect when the focus is too large. There are different surgeries that we do. When it is bilateral diffuse, we do what is called as corpus callosotomy. Like we cut the whole of corpus callosum and disconnect both hemispheres. So patient has atonic seizures where the child falls 10 or 50, 20 times a day in a house, and as they all come with like our Indian man-made helmets, because they have so many cuts and scars. You do the surgery, we disconnect the whole corpus callosum, their falls will stop. So, and it may really makes a difference in the quality of life. They may still have some partial seizures, but this surgery helps them and gives a good quality. And when a whole hemisphere is involved, suppose the right hemisphere is diseased due to various causes, stroke or infection, we disconnect the right hemisphere and the left hemisphere takes over. And this is again something I never understood. I mean, it's a nature. We all see when patient has a stroke, you have a small area of stroke, patient completes become hemiplegic. Whereas this hemispherotomy technique I do quite often is when this just take the green lines. The green line is a line of incision that we make the cuts. The whole idea is the whole cortex of a particular hemisphere is disconnected from the basal ganglia and the deep nuclei. But even if after you do that, the patients may be hemiplegic for a first 1 week, 2 weeks, but with good physiotherapy, they come back after 3 months completely walking. The only thing that the patients will not be able to do is the distal movements. We now know, of course, it's known for many decades in this kind of surgery. The cortical function, even if the whole cortex is lost, a person loses only the fine movements. Finger movements is lost and the toe movements are lost, but the basal ganglia takes over and they're able to do and go ahead with their daily life. This is just an example of a large dysplasia of a left side brain, and this too large that we cannot resect. And you can see that white line that runs along in the MRI is a line of disconnection. So all this brain, the parietal lobe and the occipital lobe and the temporal lobe is disconnected from the frontal lobe, because the problem is the irritant zone is posterior in the parietal lobe. Once we disconnect this part of the brain, the remaining brains continues to work normally, and these patients do very well. This is what I was talking about, very well familiarized in Europe. When we don't get answers with all the investigations, we know that it's coming from a particular part of the brain. And this is what we do now is we put electrodes inside the brain. We put multiple electrodes. If we think that it's coming from the, let's say, left frontal and temporal brain, then when MRI is not very clear, MRI is normal, we put multiple electrodes inside the brain and record the activity. These are like, for example, this is like, I think this patient had 8 electrodes inside the brain. We thought it is coming from temporal or frontal or insula, and then record this electrical activity for 4 or 5 days and identify which is epileptogenic zone. And then once, if we are able to identify, then if it is resectable safely, we remove them. The third is ablate. When we find pathology which are very deep and which cannot be removed safely, then there are new techniques which are there. The whole idea, the whole common philosophy is to burn that particular lesion and then result in seizure control. This is where the first technique is radiosurgery, where you burn them using radiation. You give a very focused high dose radiation to that particular part of the brain. Like you can see 20 gray, 24 gray, very 50 gray for a particular region. You burn that part of the brain using radiation. The radiation effect takes about 3 to 6 months. And then once that part is burnt, it results in seizure control. Second technique is laser interstitial therapy. Again, it's the same. You make a small hole, identify the region, pass an electrode into that region, and using laser increase the thermal. The brain cells die when the temperature goes above 70 degrees. It causes reversible damage at 40 degrees, but once the temperature goes above 70 degrees, then it causes irreversible cell death. So the idea is to take the temperature to that and result in focal lesion. This technology is not yet available in India. It's commonly used in US. This is a focused ultrasound. Again, it's ultrasound energy focused by navigation and technique to a same place, results in increase in heat, thermal energy. And what they do in MRI is they do thermal imaging, where During the procedure, you can actually assess or understand what is the temperature in that particular part of the brain by your MRI techniques. So you know if you reach that particular MRI, if you reach that particular temperature, then you can stop the treatment and come out. So this was a third technique which is being used. Recently introduced in India. I think it's there for a few years. The only machine which is there, I think, is in Coimbatore, and more machines are coming. The last is modulate. When the problem is too diffuse and bilateral, where we cannot resect, there are many techniques. One is we do vagal nerve stimulation. We put an electrode in the left vagus and then connect it to the generator. And whenever seizure comes, this generator gives another electrical current, which disrupts the epileptogenic activity and then brings down the action. Been there for a long time. Results are about 50-60%. That's why it has not taken up very well. Second is deep brain stimulation. There are certain areas of the brain. The philosophy is the same. There is an epileptic activity which is happening, which is abnormal. You go and stimulate a part of the brain which breaks the network, which breaks the circuit and resets it and results in control of seizures. There are different areas of brain which are being studied and are being used to cause control of seizures. Third is a responsive neurostimulation. This again is as of now available only, I think, in US and Europe. I'm not sure if it's available in Europe, not yet come to India, where again a generator is placed on that part of the brain. Suppose you have, like I showed, a motor cortex. If lesion is sitting exactly on the motor cortex, you know you remove that, patient will develop deficit. You don't want to remove that. You put this generator or the electrode, stimulating electrode on the brain and connect to generator. Whenever there is a seizure or onset of seizure, this gives a small current which breaks the circuit of seizures and stops it. So patient still has the part of the brain, does not develop a deficit, but then will be able to control the seizure with this technique. I think I'll end here. So these are, we work as a group, nothing is individual. These are some of the results which are published from demands for various pathologies, MTS and focal cortical dysplasia, colossotomy, hemispherotomy, as well as posterior coordinate techniques. The point to understand is these surgical techniques will result anywhere from 60 to 70% seizure freedom in properly evaluated patients. And these are the patients who will not have control of seizures with medicines. There is the chances of control of seizure medicine is around anywhere from 0 to 5%. So this surgery has been useful. It's now being brought up quite, it's being more and more taken up across the country, and it will be of useful. So this is our team. The team consists of neurosurgeons, neurologists, psychologists, radiologists, pathologists, and psychiatrists. So we all work together to make sure that we choose the right patient, because only if the patient is chosen correct, then the outcome will be good. Many of them are trained in Sijit. Thank you very much.
Very exciting work and results, and very dramatic and painful for the people, relatives, family to go through even one episode. So to extend that, you have made it clear, interactable with medicines is the indication that I agree. And the fifth slide you showed, Dr. K. Radhakrishnan is the director, chief of neurology, and he has had 650 epilepsy surgery in 2005.
Now Srichitra is at 2000, sir. I think they've crossed 2000 surgeries.
Now they are keeping it up. So earlier we were thinking, why remove the part of the brain? But now, when then they educated us, but there's a very steady program going. Anyway, thank you. I mean, even I've never sat through a neurosurgery presentation in my life. So thank you for doing that.
Thank you. No, I try to keep it as simple and as possible.
So when you say seizure free after surgery, do you add on anti-epileptics also?
No.
How many of these patients post-surgery will require a reduced dose of anti-epileptic medicines, or are they all free from seizures and free from medication?
I showed you the outcome. There are different outcome scales. It again depends on the pathology, depends on the patient. When we say seizure freedom, we take it as Engel 1A, which means no seizures. And then once the patient, there are 1A, 1B, if the patients may have only aura, but not a full-blown seizures. We take 1A as a criteria. If we take that, the best treatment outcome will be somewhere around 70%. Again, they are all called 5-year and 10-year, because these people can have late recurrences. Coming to medicine, the neurologist will evaluate every 6 months, 1 year. We do not stop or we do not change any medicines for 1 year after surgery. Here, the outcome of surgery is known after a year only. I tell every patient, after surgery, don't think that we are done, stop medicines. Surgery, we will tell. And even if they're happy, I will be happy only after 1 year. If the patient has not had a seizure for 1 year, then we can say they are a good candidate. The neurologist will start reducing medicine one by one. And about 30% of them, they may stop medicine completely. In another 20-30%, they may be on a single drug. This again, I told you, in women, 50% women, no, it's very important when they are in a reproductive age, because these antiepileptics can be a significant deterrent during the pregnancy. So we, depending on pathology, we bring down the medicine. If we can bring it to a single drug for a small dose and they are happy, we can stop. We can stop. Problem is, like all of us know, problem is with our follow-up. If we stop the medicine, patients happy, they'll never come. Then they tend to recur, then it's a problem. So neurologists are always apprehensive of that fact. So they always keep a single drug on a small dose so that you at least maintain the seizure freedom. If a patient needs an additional drug, then we don't call them as seizure control at all.
Hari, I have a basic question. Very nice that you have taken a field where not many surgeons are interested.
No, okay. I will
They are
ask.
interested then. Okay. What is drug-resistant epilepsy? Because I see patients when they come, they are on 2 medicines, sometimes 3 medicines, and they rotate it actually. Some neurologist. How to understand the medication?
Okay, there is a ILA. ILA is International League Against Epilepsy. The definition is very clear, but what you're telling is what we see in real world. If you go by definition of drug-resistant epilepsy, it says a patient who has not who is getting at least 1 episode of seizure per month on 2 relevant anti-epileptic drugs. Sometimes, say patient, again, type of seizure, generalized seizure will have a separate group of drugs. Complex seizure will have complex part will separate group. If a person is treated on 2 anti-epileptic relevant drugs, and despite that, if they continue to get seizures, 1 per month, it's taken as a drug-resistant epilepsy.
Next question is surgical. How do you see margins in brain? I have done enough. So it's so confusing.
This is, I'm not sure, because I would answer this in a neurosurgical, this one. But what we taught, no, when you move from general surgery to neurosurgery, again, our teachers have told, when you move from general surgery to neurosurgery, we are first told to unlearn and then learn. Lot of general surgical concepts that we learned gets unlearned. Because like you said clearly, brain does not give you choice for margins. You don't have scope for margins. But I'm not, for this particular specialty is different. If we are talking about tumors, we always were taught when you are operating on a tumor, your plane should be 1 plane beyond the involvement. If the tumor is involving muscle, you have to go to fascia. So we are always taught surgery, you have to go around the lesion. Even oncology, I'm sure, no entry into the lesion. You have to go around the lesion and take it out so that you prevent spillage. Brain does not give us that luxury. So when we operate the tumor, we are always taught you have a tumor, you enter the tumor, you decompress from within, and when you reach the margin, you stop. Huh? No, the margin again depends on the tumor. There are tumors which push the brain, where the margin and the brain interface is clear. There are tumors which arise from inside the brain. There are no margins. Meaning it's again, if the tumor is arisen from an area of the brain which we can relatively excise, then we'll go around it. If it is sitting on an area which is eloquent, like a motor cortex or a language area, we will be more conservative and then treat it with other types of therapy like radio or a chemotherapy. So it is a balance between your surgical resection and the quality of life. That is like in any specialties, the quality of life has to be given equal, if not more importance than your resection, but because other parts can be taken care. Your answer to this epilepsy, when it comes epilepsy, the margin is based on electrophysiology. Like even though I showed us the dysplasia, which is a small area, I will resect that area and then I will do electrophysiology around the brain. If I continue to get seizure activity, I'll remove that part of the brain if it is feasible. So the concept differs. Even within neurosurgery, neuro-oncology resection is different from a surgery for epilepsy. Because if I remove the lesion, if the patient continues to get seizure, for a surgeon, you are happy. Scan shows no lesion. But patient doesn't care. He says, I had seizure before, I'm having seizure now. So what difference have we made? So when we operate for epilepsy, our goal is not just removal of lesion. Our goal is to remove the part of the brain which is causing the seizure, which can be beyond the actual area which is seen in MRI. So that's a different thinking that is required when we do this surgery for epilepsy. No, we don't do. No, frontal lobectomy, no, sir. It's again, if there's a lesion, we try to remove the lesion. Though I keep calling eloquent and non-eloquent, we now understand every part of the brain has some eloquence. So we try to avoid removing a part of the brain without a reason.
Arivargan,
Ah.
when you, in your speech, when you were mentioning about the ablative methods,
Yes.
RFA and other few methods, you told that is now not available with us, it is there in the US. Do you think in the near future, these ablative methods will replace surgery? At least neurosurgery, this part where you're going to go in a deep area and disrupt much more.
It is possible. I won't say it may completely eliminate. It's a question of evolution. We have to accept what is coming. If, for example, the temporal lobectomy I showed, that has been we are doing it for more than 100 years. So we remove the temporal lobe, anterior temporal lobe, and remove the hippocampus. 15 years ago, the gamma knife, the radiosurgery, they did a RCT. Why open and remove? We will just give radiosurgery. We give radiation to the hippocampus and burn it, and then see. And then when they studied the results were not as good as surgery. The seizure control was 70%, 75% with surgery, whereas radiosurgery was resulting in 50%. But the morbidity was high. See, no treatment is, I mean, this audience, we don't have to emphasize. We are taught no surgery is without risks. Even if whether you ablate or whether you burn with radiation or ultrasound, that is going to cause a damage there. Only thing is you don't open. So if the side effects are more and it did not match the existing standard of care, they fizzled away. In fact, radiosurgery came in a good fashion, like we will give gamma knife. It didn't pick up because it did not stand up to the outcome that a surgeon can achieve. So I'm not telling that, and like in US, many of these lesions, they are now ablating because it's easier. You don't need a big, same philosophy. You don't need a craniotomy. You make a small hole, pass electrode inside the brain and burn it. But we need to see in long term whether it will achieve results which are equivalent to what you're achieving by a surgical removal. Because at the end of the day, in surgery, you remove. Whereas in other techniques, you burn and the lesion is still there. And sometimes we know that the scar also can result in seizures. So it's a two-way, this one. So we will not be averse to accepting the new techniques, but they have to be weighed with the other additional treatments available.
One more question. Professor G.K. Gopalakrishnan is there. He is also alumni of our own department and also alumnus of your own alma mater now, NIMHANS. Did you get motivation from GK any point of time? And second is, in such things, do we share? That is, now you are in demands and he is here. Many of time I see that there is not much happening between departments for some reason or other. Do you collaborate on academic research? Do you collaborate on techniques? Do you collaborate on things like this, which is not very common thing? Do they do? What is their experience? Do you transfer or share information? What is your experience?
I will answer both of it. The first one I didn't want to dwell, but since you asked, I'll come to that last. As far as now, I think in Jipmer, Satyaprabhu is doing. Satyaprabhu is trained from Chitra. So I think Jipmer already has all the, he's from Nimans, Satyaprabhu is from Chitra. So well trained. All these are, this is taken as an example, but there now, even in every specialty, there are subspecialties where you have to put in time. This kind of programs will flourish when a coordinated team works. It's not one person's work. So once that team is set, it will go. I think already same surgeries are being done at Jipmer. Some of them will need additional technology. When they get it, they will start doing it. So as far as sharing of information, that happens continuously. You know that this is not need for that. Regarding inspiring for neurosurgery, you're asking. That
scientific information is asked. Sharing of scientific
yes. That also happens. I think we were a breed of people who were predetermined that we are going to go neurosurgery. Yes.
What business is Elon Musk having putting implants and patches, and when do you see augmented humans walking around with electrodes speaking from the head?
That is that I don't. I mean, see, we as a doctors, we want to see what patients can benefit. They are entrepreneurs. They are trying to identify products which can sell. So there's a basic difference in philosophy. We, all of us are aware, so many products are pushed upon us like this is good, this is good. So it needs prudence for us to choose. Many times, like, this is a very good instrument. We can ask, does it make a difference in, I was, for a few weeks ago, I was for another conference in UK. There was a big talk going on why robotic surgery has not picked up in India. The person who's presenting is not from India. The data that is being analyzed is not from India. Not India, lower and middle income countries. So why robotic surgery, especially in the neurosurgery setup, why it is not being taken up? I stood up and said, see, we see whether it's worth for us. We have finite or infinite number of wealth. We see whether what we put in that, does it make a difference to our life? I think in Tamil also it's there. If the one proverb is that even if you put in even if you're going to put something or throw something in the river, you measure and put. So like that, we know that when we spend something, whether it gives us good dividend in form of healthcare and from patient care. So I have nothing to comment about Elon Musk. They are entrepreneurs. We are physicians.
Hari, great talk, great talk. I mean, it's really hard to do a convincing job for a patient where you don't see a lesion. It's really hard. It's amazing work. Is there any age cutoff? Like, when you assess a patient, do you have an age cutoff or functional status or frailty or anything like
No,
that?
like again, see, though I made a single as a single topic, the base is drug-resistant epilepsy, but the pathologies are very varied. So you get a kind of conditions which are very common in children, and you get a kind of conditions which are common in adults. We generally don't see patients who are above 50s because as seizure, they are very common in very young age. So most of them are children and young adults. And the pathologists will differ, that the treatment or the procedure will differ based on the condition.
Thank you, sir. I would
Thank you very
request
much.
Dr. Smile to hand over a memento to Dr. Adivara. Smiles. We have a next presentation by Dr. Shankar Raman on the topic setting up a rectal cancer program. I would request the chairpersons, Dr. Vaitheswaran, Dr. Ranjit, Dr. Rajkumar, and Dr. Magnus Jairaj. Please share the session.
Well, good afternoon. Following Arivaragan has always been a tough ask, especially going back to 25 years ago, doing the case presentations. I was always compared to how Arivaragan did it, and it still continues. But I also believe that we saved the best for the last, and I'm the last of this session. Again, going back to 25 years, I happened to get the gold medal, so there's that. As Dr. Baliga said, I have a ton of alphabet soup. They'll heal better. So as Dr. Baliga said, there is a ton of alphabet soup behind my name. But as you can see, Jipmer is always in the background. And all of what I have achieved is thanks to the seeds that our mentors sowed and watered, and the environment that nurtured us to enable us to be where we are. So I did my undergraduate and postgraduate degrees here, and I worked as a senior resident for about a year and a half, and then moved to England to do my MRCS, then got my American Board of Surgery and colorectal surgery in 2011 and 2013. Thank you, Sam. So I did my American Board of Surgery and colorectal surgery in 2011 and 2013. And to this date, some of the happiest years of my life were from 2000 to 2004, when I was at the department here, where my academic thirst and quench for was adequately quenched, balanced by the surgical challenge. When I went to England for about a year and a half, I was bored because we worked about 40 hours a week, and I just didn't feel that I had the enough of surgical training. And then when I moved to the US, it was just a slog for about 100 to 120 hours a week with the cases that we had. I was overworked for the first few years in the US, and still reflecting on Jipmer, some of the happiest years were from 2000 to 2004. And I'm very grateful to our mentors here who provided us with the education as well as the satisfaction. So going to rectal cancer, pivoting here, the global burden of colorectal cancer is nearly about 2 million new cases and 1 million deaths in the year 2020. And then it is estimated to increase by 2040 to 3.2 million new cases. And it is one of amongst the top 3 leading causes of cancer death in 104 countries. And within the United States, we see nearly 40,000 rectal cancer patients a year. And the treatment of rectal cancer is very complex. A lot of these patients are treated in low volume centers because of the geographical diversity and the size of the country. The guidelines are very poorly followed, and the outcomes are variable depending on who they see, when they see, and what treatment they get. So all these has an impact on mortality, on recurrence, and results in permanent stomas many times when this could have been avoided. I feel that rectal cancer is a condition where you really get one good shot at fixing it. And these are trends over the last 20 years or 25 years, both within the younger age group and the mortality. We see that the incidence is increasing within the younger age group. The mortality took a dip over the middle years, but then has started going up again. So within the United States, not many centers are experienced in taking care of rectal cancer. About 70% of hospitals treat fewer than 20 rectal cancer patients a year, and predominantly care for these patients is provided in smaller hospitals. And only about 30% of hospitals are considered high volume, which is more than 20 cases a year. And only about 6% of hospitals treat more than 50 rectal cancer patients a year. Patients don't want to travel more than 50 to 100 miles. And even that is a substantial ask on them, especially if you add in the challenges of giving chemotherapy, radiation for 5.5 weeks, followed by surgery. We all know within the field of colorectal surgery and surgical oncology that circumferential resection margin is an important factor that determines the outcome in rectal cancer. There are a slew of studies on the left here that show with both neoadjuvant therapy and with no neoadjuvant therapy, the impact of circumferential resection margin, which is the closest measured distance from the outermost edge of the tumor or involved lymph node to the mesorectal fascia. If it's 1 millimeter or less, it is considered to be involved. And it's a very powerful prognostic factor, which has impact on local and distant recurrence as well as survival. And it's a very convenient and immediate quality measure for surgical technique and pre-treatment decision-making. But how are the US hospitals performing on this measure? Not great. I draw your attention to this. Only about nearly 17% of hospitals have positive circumferential resection margins. So this is National Cancer Database over the years of 2010 to 2011 with rectal cancer patients from stage 1 to 3. Nearly 17,000 patients with 17% of them having a positive circumferential margin. So the current state of rectal cancer surgery in the US, patients are treated by non-specialists, predominantly by general surgeons in low volume hospitals. Rates for permanent colostomy are variable and excessive. There is no good adherence to evidence-based guidelines for use of neoadjuvant therapy. High rate of positive circumferential resection margin, which is a surrogate marker for oncological outcomes. And outcomes are really likely to be inferior to European countries that have instituted national programs to improve the quality of rectal cancer. And it is in this space, the Commission on Cancer, which is an arm of the American College of Surgeons, started a new program called the National Accreditation Program for Rectal Cancer. And that's the crux of the talk here. We are a community teaching hospital with a general surgery residency. It's a 5-year categorical program. We graduate 4 chief residents every year. We have nearly 650 beds. Another small hospital about 10 miles has about 150 beds. So somewhere in the vicinity of nearly 800 beds with bed occupancy rate consistently in the 95 to 100%. We are accredited by the Commission on Cancer, We're also certified by the National Accreditation Program for Breast Cancer. And our annual volume for rectal cancer is somewhere north of 40 cases and can go up to 50 cases per year. So it is considered to be a fairly high volume center within the US. And that's Iowa, that red space. It is in the Midwest. It is considered a rural state because of the US Census Bureau. And there is a wide variation in rectal cancer delivery with no standardized protocol for rectal cancer. We see about 1,500 rectal cancer cases a year within the state. So before we started the program, patients with rectal cancer saw colorectal surgeons at various points in their treatment. They would get diagnosed, get started on treatment, and then get referred to us, versus some would see us first, some later. And most colorectal cancers were operated by general surgeons, except in the metro areas. Because like I said, it's a rural state, and there are numerous smaller hospitals where general surgeons do crux of the case without adequate training or understanding of rectal cancer pathology or the TME plane. Like most places, Metro Des Moines, where I live, is dominated by two large health systems. And within the ecosystem of where I work, there are employed physicians in these specialties that are employed through the hospital or the medical group. And then there are physicians in private practice who we interact with, but we don't have any real leverage over. And what did we have? We had a cancer center, but not a real dedicated building. We had a robust framework with multidisciplinary tumor boards with well-established cancer conference. In addition, we had breast, lung, head and neck cancer tumor boards. And we had a multidisciplinary tumor board every Tuesday for general, which included GI and colorectal. We had a very receptive administration that provided us with the support for making the change. And we had dedicated physicians and advanced practice clinicians who attended these conferences and also provided, in addition to the primary care doctors. So we enrolled in the Optimizing Rectal Cancer Consortium in 2014. This is through the American Society of Colon and Rectal Surgery. And we kept following these updates. And then in 2016, we decided that we would want to start a rectal cancer program, but we didn't have a coordinator to put the pieces together to follow the patients through the journey. So this is the process mapping for us, starting with pathology. Once the patients got diagnosed in pathology, they would go to the cancer registry. Then subsequently, the rectal cancer program coordinator or the office nurse would get the information, and then they would see colorectal surgery first. So making sure that these patients saw colorectal surgery first was a very crucial element, because we could control the process from here on out, so that we could make sure that they get the adequate workup, including the rectal cancer protocol, MRI. So before we started the program, I did a lot of endorectal ultrasounds to stage the rectal cancer. But once we started the program, we switched over to MRI, which is much more standardized and eliminates operator inter-observer variability. So after that, patients get medical and radiation oncology evaluation, and subsequently they have a tumor board discussion. So this is what the process map looks like. And every patient gets discussed at the tumor board before they start treatment, which might be palliative care. Patient is not a good candidate for any definitive therapy. They might be candidates for palliative care, but a team of us looks at every patient, every pathology report, every MRI, and we decide what would be the best outcome for moving forward, because we have well-published data that shows that having a multidisciplinary approach makes a difference in how decisions are made and treatment is delivered. So if you look at the program recipe for starting a rectal cancer, you need to have a very strong why. You need to have a very valid reason to start a program with a very strong administrative support. Unlike what Arivaragan and Ranganath, as well as Muthu have said, you need a team. It is not a one-man show, but it's really a team's performance. And the team includes all of these. We have the surgeons, we have the radiologists, we have the pathologists, medical radiation oncology, we have a coordinator. In addition, we also have others. I have named only the genetic counselor, the physiotherapist, but we also have a social worker. We have an integrative oncology therapist. We have we have dietitians. We have a slew of other people. All these people form the team. It's not a one-man show anymore. You need to, our recipe started with a vision, and we needed to have alignment. Bringing all these very team members together was crucial, Because like I said, I don't have any real leverage. I am the rectal cancer program director, but there are private practice docs who work with us, and I don't have any real leverage over what they do. So talking about the vision, creating the vision, sharing it with them, and talking about our success stories helps them bring in, fall in line with where the program goes. That is very, very crucial. And we still continue to talk about what we have done well and what we have not done well, because I feel that patients or physicians don't really need compensation, especially in the financial component. It's about understanding the work, appreciating the work, celebrating the work, and identifying opportunities for improvement. It's not about criticizing someone who may not have read an MRI well, but rather looking at the MRI, looking at the pathology and saying, why did we miss? What did we miss? What can we do to prevent this going forward? That I think is crucial. And we also have a quality improvement tied into this. We look at our results. We look at what are our opportunities for improvement. And now with the Commission on Cancer, it is mandated that every program does a rectal cancer QI project every year. So we need to work on this and show that we are improving. So what we achieved was a very streamlined, comprehensive patient care. We became the 5th program in the country. No one has heard of, not many people have heard of Iowa before, but we became the 5th in the country to receive accreditation. We were the first non-pilot program in the country to receive rectal cancer accreditation. We got a very, very great team. And personally, numerous lessons in emotional intelligence and team management for me. This is when we got accredited, this was the list of accredited rectal cancer programs. Now the list has grown to more than 100. You see Cleveland Clinic there, and then there are two branches of Cleveland Clinic with Florida Institute, and then John Muir, and then Mercy where we are at. And that's our accreditation certificate from the rectal cancer program from the Commission on Cancer. And subsequently, I undertook a study through the National Accreditation Program, analyzing the patterns of compliance, where we reviewed 25 programs from 2018 to 2020 and seeing how they did with accreditation. There was a wide variation, like I showed you. There were some programs with 14 cancers per year and some having more than 200 cases per year. And some of the standards are very difficult to meet. Analyzing and discussing every patient before they start treatment, you need to show 100% compliance, and that's very difficult. You need to do it in a way where you meet the criteria, but you also don't delay treatment. So sometimes we'll have to pull in the meetings, we'll have to get the physicians together because we want to get started on treatment. And when I'm traveling, if I've attended some of these meetings, even from out of the country, or just remotely log in and join these meetings so that we can keep the treatment moving forward without delaying treatment. And then this is, a proud moment for me. The optimal resources for rectal cancer care just came out. It goes into effect next year. And I'm lucky to be part of the team that puts forward the compliance standards that will measure all the programs that are now part of the NAPRC. And these are some of our intraoperative photographs. I don't do a whole lot of open operations, but these are photos from an intraoperative radiation therapy that we've used for rectal cancer. This was about a year and a half ago. And this is our team. That's me looking at the frozen section margins at the time of surgery. So I take the specimen to pathology, and that's our pathologist on the left, and that's a radiation oncologist on the right, and in the middle. And we are all looking at the margin together to assess how we are going to radiate, if we are going to radiate, and how we are going to plan the treatment. Which probes to use, how we are going to protect the adjacent organs, and all that happens in real time as the patient is under anesthesia. So it takes a team to do meaningful work. It's not just all about you. You really need a team, and you need to build a team. All surgeons are leaders. You don't necessarily have to have a title to lead. By dint of your training, by dint of where you are, and by what you have accomplished, you are a leader, and never forget that. And always focus on the long-term success. Short-term goals, they don't really matter. Long-term outcomes are what truly matter. It's a marathon and not a sprint. And never stop learning. I recall what I learned from Jipmer was that, when I left Jipmer, I realized that what I've learned was just a fistful of knowledge. In Tamil, they say, "Kattrathu kaiman nalavu, kalladhathu ulagalavu." So never stop learning, and it's a lifelong process. And these are the memories that we built. It was a fantastic evening last night, and I'm giving full credit to Ranjit Hari for convincing me to come here for 48 hours to India to be here, and for Professor Anantha Krishnan for instigating this, where Ranjit Hari, made the phone calls. But it was a very, very sweet and treasured moment for me. I'll never forget last night's dinner. We picked up from where we left 20 years ago, and it was truly one of the remarkable evenings in my life. And that's my other team. That's my wife and 2 kids, without whom I wouldn't be here today, who let me do the cool things that I do, both at work and outside of work. That's me at the base camp of Mount Everest from a few months ago. And I'll stop there and thank you for this honor. It's truly been a blessing to be a part of it.
Shankar, very, very nice presentation, and I'm very, very happy that you have created a program yourself. It's another thing to be in MD Anderson or All India Institute and then run a program. And I traveled the same boat as you saw my center, and it's been very difficult to make people understand and bring them together. And then I hope our program is as good as yours. And rectal cancer as such, for people who are not treating rectal cancer, it tests every aspect of you, that your knowledge of imaging, your knowledge of pathology, your knowledge of medical oncology, your knowledge of radiation oncology. And Ranganath will agree, in the last 10 to 15 years, we have traveled quite a bit and we are almost there. And most of our treatments are now standardized and all patients go through MDT. We do have Tuesday and Friday MDTs, and no patient is started treatment without MDT for rectal cancer. So good, keep it up.
Thank you. I was at your facility at your invitation yesterday, and was very impressed by what you have put together. And I have no doubts that the quality of outcomes that you deliver is no way less than what some of the major institutions around the world are doing. So I'm happy that I got the chance to see at firsthand the work that you're doing.
Thank you so much. Thanks, Shankar.
One of the principles that I think about and I fall back on is grow where you're planted. You don't necessarily have to be at some of the top tier institutes to do remarkable work. If you can figure out a vision within the constraints of the ecosystem where you're at, people will fall in line. And you just need to be their cheerleader most of the time, and occasionally the disciplinarian. And a lot of this is just change management, about just convincing people, because some of these, some of the standards, I have to tell these guys, hey, you need to meet the attendance standards. They have to attend certain number of meetings a year. So it's not easy. Whether I like the standards or not, it doesn't matter. I just have to follow them. So it's just about showing the vision. Tell them, you have come so far. We got this. We can keep going forward. And we went through another accreditation 3 years ago, and a 3-year cycle. So we are due for another accreditation later this year. And I do a lot of time, personal time on weekends that is just uncompensated work financially, because it's a labor of love. And that's why we are here. That's why we do what we do.
Do you do overseas accreditation?
I do. I do evaluate other programs. I'm a reviewer for the rectal cancer, the NAPRC. So I get to see firsthand what other programs are doing, which gives me the opportunity to see what process improvements I need to make at my own place, because some of them have best practices. So it's truly an opportunity for learning, but also give them the feedback that we have learned so that they can get better as well.
TME in patients who obese male patients, transcendental TME.
We do. Colorectal cancer by its demographics is male heavy specialty, or a male heavy disease. And in Iowa parlance or Midwest parlance, one Iowa unit is about 250 pounds, which translates to somewhere north of 100 kilograms. A lot of these patients, because of rectal cancer, obesity is one of the risk factors for rectal cancer, in addition to processed diet, as well as lack of physical activity. So the people that I see and I commonly operate on have a BMI of somewhere north of 35 kilograms per meter square. And a lot of them fall in the morbidly obese group with 40 to 50 kilograms per meter square. So one of the, I didn't talk about this, but the robotic approach has tremendously been helpful for me in doing the operation so that I don't have to break my joints or get a rotator cuff repair or whatever, because it's just super hard to do this, as like everyone knows, to work in the deep pelvis after neoadjuvant chemoradiation.
So one of the problem I encountered during robotic low anterior resection is, since we don't have the table associated with the current Da Vinci Xi, we need to dock it twice. Do you have the supportive table, or what is the picture like?
So I worked on multiple generations of the Da Vinci. I started with S and then SI and then
We have Xi.
and now with XI. And I do have a table that is docked or that is connected to the robot via Bluetooth. I do have a table, but
So single docking.
Yeah, but for many years we worked with a table that was not connected to the robot, so I cannot change the position. So I'll have to put them in the steepest position right from the get-go, so that I can get the operation done quickly rather than stopping the operation, undocking and then redocking. I feel that a surgical momentum, getting the case done quickly under anesthesia, especially for these patients, with good anesthesia support, you can get them done with less impact on their cardiopulmonary outcomes rather than docking and undocking and then prolonging the time under anesthesia.
Thank you, sir. Thank you, sir.
Shankar, I was with Shankar for 3 years. So the same, the sharpness, the precision and all, I was so happy you're going along life and establishing programs. So I, like Dr. Vishnu told, there may be several options for you to interact with our people who, for example, we don't have so much complicated equipment, no robo. So struggling with processes and maybe some time because we have to reach the level of equipment which blessed people like you have in US. So wish you all the best and have a wonderful future. Now, after that 3 years of interaction, Shankar suddenly he went off our radar. I used to be more in contact with Vaiti and others here. But this has been a wonderful opportunity when Chief told regarding that coming. I told these opportunities we have to come together because philosophically we may not be there, health may prevent, travel, other difficulties may come. So you have to come, no other option. So so that is how we could make it happen. And when I saw that photograph and when we had photographs with Chief and Smile Sir today, I somehow, sixth sense, I hope and pray that we have several meetings like this in future. So never hesitate to come like you come like you come for your own people, it's like
you are my own people.
Exactly like that. So I have to come. I came. So thank you for coming and making this a wonderful time. All of us.
Pleasure. Thank you.
Thank you. I would request Dr. Ananthakrishnan to present a memento to Dr. Shankar.
I think there's some delay. Meanwhile, Dr. Rajesh will speak on robotic hepatectomy for liver tumors. So we will take up the Shrikant's lecture after the lunch break, I think. Now, Dr. Rajesh will speak. So the chairperson for this is Dr. Vaidishwaran Magnus. Dr. Magnus is there around? And Shaktivel.
Pride moment for me to come back to my alma mater and then feel a Lilliput in front of all my gurus, stalwarts, and my colleagues as well. And I'm proud to see all my colleagues as well as my seniors standing tall in their respective fields. So when I was trying to find an analogy of this experience in Jipmer, I would say that this reminds me of Newton's law. This is basically I was reading with my younger daughter, and then this law of inertia came in. So this is what Jipmer has done. Jipmer has created that inertia effect in our life as a surgeon, both professionally as well as personally. The force in which it has pushed us. The definition of inertia says that it is a tendency to resist any change. I think over the period, what we have learned is it has made the force in which we are pushed out into this world, it has made us to feel like resist any unwanted, unethical, and to stick to the patient care. I think I would, and if I find any of the characters similar to this in my during my experience, and when I ask them, where are you from? They say Jipmer. I think this is, I think everybody will be having the similar feeling. And I thank Dr. Vishnu Prasad sir for this opportunity. I'm from Professor Anand Kishan time, and I work under Dr. Jagdish and Dr. Sharath later. So going to the, okay. So I would start this, like, I heard about people talking about robotic surgery, and in India it is in its early levels and this thing. But considering liver transplantation, there is one saying that when you know better, you do better. I think this is what has helped as a surgeon, like in India. The number of transplants, okay, the slides are ready. Can I operate? Yeah. So this is a precious moment for me coming back to Jipmer during the Blalok Theatre renovation. This thing. And I sincerely thank all my gurus, my colleagues, and Kalaiarasan for me all the time, both professionally and personally, and during this journey in robotic surgery. And obviously, my prof, Muhammad Raila, for the opportunity that has given me. And this is the picture of my first open donor hepatectomy. I got specialized in liver surgery, especially in donor, and then moved on to robotic. So India is a hub for transplant, no doubt, but the amount of, it's more the technical expertise that is available here as well as the financial advantage. The number of transplants done in India is so much. And as I said, when you know better, you do better. So the number of cases that you do and the experience that you get in liver surgeries, how to do it safer, you push your limits beyond in achieving surgical excellence. And donor hepatectomy is one field where you have to, because they are not a patient, they are coming to donate. And the best that you can give them is to have a pain-free surgery and then to have a minimum scar. And this demand actually pushed the minimally invasive surgery, in fact, for us to go more into this minimally invasive surgery. So this journey of us going into donor hepatectomies robotically has helped us to move to the other liver surgeries, I would say. So initially, this is our OT setup. We had a Da Vinci Xi system, and then now we have another Da Vinci system. And this is our patient position. And we have published few papers on this, our pediatric liver transplant. First, we started off with the left lateral minor hepatectomies in robotic and then move to major. Our experience stands now at around, we have done 379 robotic donor hepatectomies. The major is right lobe is 196. And we also embarked on doing recipient surgeries as well, which only 2 of them completed. And robotic HPB surgeries, obviously, it's the experience helps in that. The port positions and the instrumentation used, one thing about robotic is it is financially demanding, but the advantage it gives over laparoscopy, especially in complex surgeries like liver, is immense, no doubt. Stable camera, 10x magnification, endorist movement, and the caudocranial view that it gives compared to the anteroposterior, that is of immense help, especially when you do a liver surgery, which a big or solid organ sitting at the top. So financially, what we have done over the years is we have tried to stick to very few instruments so that the cost, because every instrument count is for a particular surgery. It's for for example, 30,000 almost an average of these instruments per surgery. So the cost is high. So we try to keep it to the minimum as much as possible. And what we learned in donor surgeries are there are few steps, especially the ICG, use of integrated ICG for biliary system delineation, as well as the finer dissection is much, much better in robotic compared to open. There are a lot, even now, when I meet a lot of people, they still have the feeling that they have a resisting feeling that open is the gold standard. Never I argued that open is the gold standard, but there are few areas definitely robotic has an advantage, and better to not have the resistance and then go along with the innovations. So let me go to the, so this is where, so donor hepatectomy is the one, there was a demand and we got pulled into this robotic. But now the technology is pushing us to embark on other complex HPV surgeries. And this is where we landed up in doing one robotic perihilar cholangiocarcinomas, which are considered one of the complex liver surgeries by open standard itself. So, but the advantage we felt during the donor hepatectomies of this with using robot, this is one of the first case that we, yeah, this is a video. So this is a 60-year-old gentleman who presented with jaundice and diagnosed to have a perihilar cholangiocarcinoma with high bilirubin. He had a preoperative biliary drainage. There are 2 PTBTs there. And this is the port position. Usually the robots, they are long arms, so you can have the ports a bit lower. So after the diagnostic laparoscopy, make sure that there is no evidence of any spread. This is more or less, it's a right hepatectomy, and it is equal to a right donor hepatectomy. So the steps, most of the steps are, we were used to the steps of the right donor hepatectomies here. The PTBD tubes have been cut off, and then the right lobe of the liver is mobilized. Instrumentation, the view, the stable camera, and the instrumentation, and when and there, like whenever it is required, it is better that we actually suture. We try to simulate most of the open techniques rather than using energy devices. And here, because of the ICG usually will be very well visualized in the CBT, but because of the stents being there, the ICG was not very clear here. So here the lower CBD has been cut off, and then the stent for frozen section. So usually in a perihilar cholangiocarcinoma, the mass, the anatomical location of the tumor and its proximity to the portal vein as well as the artery, usually there is an involvement. But in this case, there's no direct involvement of the vessels. In fact, that is the reason we selected it for robotic. So the lower CBD, which is cut, once a frozen section is negative, we have sutured that. And then the portal structures to the right lobe, which were planned to be removed. So they are looped, isolated and looped. Usually this is not how a HALA will be, but this is a straightforward case. So we use staplers for the portal vein. And then once the artery, the inflow is taken off, the remnant duct, that is the left hepatic duct, is cut off and then sent for frozen. So once that is done, we mobilize the rest of the cava, because obviously in a hilar cholangiocarcinoma, we have to take the caudate lobe off. So the cava is completely mobilized off the liver. And here, after the mobilization, the right hepatic vein, the space between the right hepatic vein and the middle hepatic vein, use the hanging maneuver. So this is for marking the transection line. So we adopt, in liver parenchymal transection, there are different ways of doing the transection. One is doing with the harmonic, and the most common method is using the accuser. And we still find that using the accuser is the best one. But in robot, because of the arms being there, it is very difficult to do the get the accuser in from the bedside. So what we have done is we have taken off one of the arms so that to ease the bedside surgeon to come to the field and then get the QSIN. So here the caudate lobe, once a right hepatectomy, the Cantley's line, you have done the transection. The caudate lobe is also, this is the Spigelian lobe. So it is also taken off from the cava. This visualization here is not as good as when you do open. Actually, this is one step where, because of the caudocranial visualization of the cava, it is much easier through robot compared to open itself. This is the this is a constant vein that is draining from the Spigelian lobe to the cava, which usually bleeds. But you have an excellent visualization from the caudocranial view. Once the thing is like we fire the right hepatic vein at the end to get the specimen, that is the right lobe with the caudate completely disconnected from the remnant liver, that is the left lobe. So once this is done, the rule loop, what we felt about this robot in rule loop preparation is it is difficult to do infracolic than supracolic because of the port positions. But luckily we got it done. So once a side-to-side anastomosis and the rule loop is prepared, we got the specimen out. Because the specimen is large, we used Fenton still. And when we took it out, we gave a full wash and made sure that because the bile spillage, infected bile and all will be there. So we gave a good wash before we started off with the anastomosis. So the roll-up that was brought out through the transcolic and supracolic area, we did it with the PIO, proline sutures. Proline, the reason is usually we use a Absol suture, PDS, but this is the initial period, and then the handling of the suture with the robot instruments, we felt proline may better resist more the injury because of handling from the robotic instruments. So this is the posterior layer being done, and then we had to put a stent across to complete our anterior anastomosis. This is one of the early stages where we are doing the biliary anastomosis. One thing we found is definitely it is doable with HALA. Robotic surgeries can come into complex HPV surgeries. One is, most important thing is the instrumentation, clamps when you do a vascular anastomosis. I think these are things that needs more refining to get it more and more into the HPV area. Lymphadenectomy is one part where I felt robot has a advantage, because one is not alone the visualization and the dissection of the lymph node, also the lymphatics, you can tackle it better to avoid lymph leaks, especially cases where the portal pressure goes up. Like here the remnant liver is small. Definitely there is a portal pressure that is going to go up. The lymph leak will be more. So in these scenarios, better magnification helps us to deal with the lymphatics also during the time of surgery. So the top layer we're done with interrupted. So about robot in India, definitely it has come. In fact, I would say people are traveling from US and Europe to learn robot here. This is not, actually I was surprised, but definitely people are liver transplantation, especially donor hepatectomy. We have observers like almost like last 1 year, we have almost like 10 observers from US coming down here, getting the experience of robotic donor hepatectomies. So I would say that India is very much ahead in liver transplantation and minimally invasive donor hepatectomy. Thank you.
Very good presentation, Rajesh. And for the sake of others, I have to tell I knew Rajesh when he joined as MS. After that, there was a gap. Then he joined as a fellow in within Dela's team, and I was a consultant in Global. He is one of the most hardworking persons that I've seen, and extraordinary amount of dedication. And I've seen your growth, and you are doing work that is equal to anybody in US or Japan. So we have to congratulate you on that. And it's another thing that you have great teachers, but not everybody achieves that greatness, even if they have great teachers. And Kalai is another guy. Two of my juniors whom I'm always proud of, and I always tell positive things is Rajesh and Kalai.
Thank you
And
so
I
much.
keep learning from both of you.
Sir, thank you so much. Thank you so much. Kalai is very, I would say that he's one soul who is selfless all the time. And I learn a lot, not professionally, but personally. He's one person, I admire him a lot. Luckily, he's not here so that I can talk. Yeah. So I always, and anytime, any time in this, and I had to, like, I had a bad time, and then I called him. He was in the airport checking in, and then he stopped there consoling me, and then got into the flight. I'm very, very grateful to him. I'm very proud to have him as my friend. Thank you.
I had a recent experience when our team at AIMS Bhubaneswar, they're planning to start liver transplant, and the team went to Rela Institute and they met Rajesh. Then they came back and we met one Dr. Rajesh is very good in robotic donor hepatectomy, and then I told yes, he's a junior. So that is a very proud moment that I felt about.
Thank you, sir. Thank you so much. Thank you so much.
Thank you.
Excellent talk, Dr. Rajesh. I mean, on a personal note, I learned a lot from you right from the time I was a resident at Stanley, and you used to come to help us for our transplant. And now every time, whenever I get free, I come to your center to learn, and I continue to learn and look forward to learn more from your center, your entire team. And the thing is that the skill set of the entire team is the same. Everybody is good in every complex liver section. And regarding this robotic liver section, one question is like you get most of the liver section comes to your complex liver section, which anybody don't want to touch. So what do you feel the subset of patient in which the robo gives an advantage than compared to a lab or an open liver section?
I think basically we got to understand the anatomical and the technical aspect with a good amount of experience in donors. So normal anatomy, we got a good experience. And then when we push ourselves into the complex HPV surgeries, we know the safe limit, when to convert, when to not. That's the first priority. And then when we started going in, we felt even recipients, cirrhotic patients, we started doing robotics in cirrhotic patients with a lot of portal hypertension. We have a good control. We had a good control on the whole thing, like with a better understanding of the instrumentation. So there is a learning curve. Once you have a safety thing sorted out, I think you can push into many complex HPV surgeries. The only problem I have is pushing robot in all the fields. The specimen that you're taking out is so big. At the end, you have to put a big incision and then take it out. So, and our open surgeries, earlier we used to put a long reversal incision to do a complex HPV surgeries. Now we are doing most of the surgeries in the midline. So ultimately, it is like doing a midline surgery alone for open itself. Then why to push for robot? This is where our struggle now is. Like when you are able to take a big specimen out, very well use that and then do the complete the surgery itself. So I think it's a balance. I think we need to take it.
That this hepatic recipient is only a fat and
No. No, actually recipient, we are doing it. And then the reason why we embarked on it is the surgical stress we feel is less with robot. But the problem is the transition, the amount of the time taken to do the reperfusion. So it is a graft that is donated by a volunteer, and then you should have all respect for that. So that step to take it to avoid less injury to the graft and then to have the same outcome on the recipient is what we are trying to. Indocyanine green. So in open, like in a normal open donor hepatectomy, we don't use ICGs. Obviously, because of the complexity in getting the near infrared light visualized to get the ICG delineated. So it's open surgeries, it's very difficult. First, In open surgeries, we use intraoperative cholangiogram to get the bile duct. In a 2D fluoroscopy, you mark a site and then cut the duct. That's what you do in open. But when in robot, you have an ICG there with the integrated ICG, the stable vision, you can see the confluence dynamically and then cut it. That is a big advantage. Laparoscopically, the integration is there, but the stable vision is not there. Robot, that stable vision is there.
Denude ducts and then see it, because it obviously cannot see through a tissue, no?
So when you dissect off the layers, so the depth of penetration of this ICG is 5 to 8 mm. When you dissect off the tissues, then you will be able to go closer and then you can visualize the duct confluence very well. You have to clear the tissues off.
You mean to say that if you had a visualization system in the open, that would give it a...
It is there, but it is very, very cumbersome to get it. The image you get it in minimal invasive, you can't replicate it in open. It's difficult as of now.
And one more question, segmental resections, have you tried segment 7, 8? Those are going to be the biggest advantage in robo.
Yeah, a few days back, we did a segment 7 resection for a HCC in robot, but those are difficult. But advantages, you can mobilize it robotically. The liver can be mobilized well. It's a cirrhotic liver, and we could do the dissection. But instrumentations, how we use harmonic, all these things, we are on the learning curve for that.
So we tried doing the right hepatectomy few times. The one problem was hooking the right hepatic vein. There was one problem once we had faced. And second or third time, there was a problem of bleeding of the tributaries joining the middle hepatic vein.
Yeah.
So how do you overcome this situation? This is the practical problem I faced.
Oh, it's basically a learning curve. So a cava, when you start, if you, for example, you wanted to mobilize the right lobe, we initial few cases, we mobilized only the lower half of the cava. We didn't try to complete the caval dissection of from the liver initially, because first thing we have to be very easy. It's suturing, robotic suturing. In case if there is a bleeding, how you control it. So once you have an experience in suturing all these things, then we went ahead dealing with large infrahepatic veins and this. But looping the RHV, I don't think it's a problem. In fact, with robot with the caudocranial view, you should be able to do that with it. And one thing we found that during caval mobilization, the hemolocks, even though laparoscopically a lot of people are using hemolocks, we find that if you are putting a hemolock and then the same plane, you have to bring in an instrument back and forth again during the rest of your surgeries, the chance of it slipping off is quite high. So we try to avoid hemolocks during those instances, and then we either suture or we put small clips. We have some other ways of securing it rather than to use the hemolocks.
In that since it was anterior approach, we couldn't take control of the right hepatic vein, and obviously the tumor was very big. And what happened when we just cutting the tumor, there was some capsula on the right side. And since hepatic vein was not taken control, we had already cut the right hepatic artery and the right portal vein. There was bleeding from because of the capsula. Because of that case which I discussed with you. So we had to convert because of that capsular tear and excessive bleeding.
Large tumors anterior approach is the recommended one, if you are not able to loop the right hepatic vein. But people always feel that when you take the right portal vein and the right hepatic artery, then there won't be much bleeding from the hepatic vein. No, the hilum is still intact. If the hilum is still intact, there can be a good amount of crossover supply from the left artery to the right side, and still there can be. So unless until you divide the hilum duct, you will still have an inflow into the right side. Yeah.
Yeah, that's it. Impossible.
Yes. Sure, sir. I'd be pleased to. Thank you. Thank you, sir.
Now I would request Dr. Vishnu Prasad to present a memento to Dr. Rajesh.
Hey, Shrikant.
Hi. Who is this?
Ravi.
Yeah, Ravi, are you?
Yeah, he's online, I think. Shrikant,
Yes,
Dr.
no,
Ravi is online.
Let
Thank
me get my video on.
No, I can't. I just got the screen, Ravi. I can't see anything else.
Oh, you can't see. Okay. So
No, I'm trying not to mess about because.
that's okay. Yeah. All these online ones are so tricky, isn't it? Vishnu, when is mine? Is it after Shrikant?
Yeah, after Shrikant.
Okay.
After
Okay.
Shrikant.
What are you
Sorry for
speaking
the delay.
Yeah. I'm talking on ex vivo and anti-situm resection.
Okay, then. Liver resections. Yeah.
Yeah.
Are you doing a few of them now? Means,
Yeah, we have done. I mean, numbers have picked up recently, actually. So we seem to be. I think we used to a few, and then you start doing a bit more, no?
and then you get more referrals also.
Yeah.
Like Peter Lodge did a few 20 years ago in Leeds, and then.
Yeah.
We had a case two weeks ago where it's a perhaps a colorectal metastasis. Histology showed metastatic adenocarcinoma, but the primary was not seen either in a PET scan or endoscopy, and had 3 months of chemo, and it was abutting the cave above the right hepatic vein. So we did in cardiac theaters in case you had to do a bypass, but actually it peeled off, I think, and there was a 5 millimeter margin on histology.
Okay.
We just wasted the time of a cardiac surgeon. So,
We had one on the children's side, actually, a 10-year-old, 10 days ago. He's still in the hospital. We did ex vivo, the large endothelial sarcoma. So I mean, she already ruptured the tumor 4 weeks prior to surgery. So I don't know, the outcome long term is not going to be great, but managed to resect it.
no, this one ended up becoming like a standard resection with a bit of diaphragm. But we did cardiac theaters in case you had to resect the cave. So.
Are you going for the August meeting?
Which one is this?
I think this is one in Dublin, I think.
I'm not. What about you?
No, I'm not going either. Actually, it's coming soon. I think maybe beginning of April. I think. No, I'm not going for that. Actually, no.
I think we are on a public screen, so I don't want to talk about it. But all these programs, like registrar teaching these days. Unfortunately, I must say. The level of, suppose, No, I'm not going. I'm thinking of going eastward because it's in London.
Oh, okay.
Yeah.
I'm going for the ILTS meeting in Seoul, actually, June, end of June.
Liver Transplant Society, is it?
No, the Lap Liver Society one.
Oh, lap livers. It's kind of, has it incorporated robotics in the discussion now?
Yeah, they have. Yeah, so they have changed the name as well now accordingly. So it includes.
Suddenly, because of all the money that Intuiti is putting into meetings.
No.
Don't talk about laparoscopy. It's only robotic or open. That's it.
It is actually. Yeah.
Have you got access to robot now in QE or?
No, not from HPV side actually. No, we are planning to get one this summer, but till we see it, we can't rely on it.
Yeah, we have it in Oxford. I must say, I don't think it's helped patients much.
That's my belief as well, actually.
Yeah, because what you end up doing is you take a whole day for Whipples when you could actually do 2 cases. You're choosing a simple, straightforward case, which you'll always let a registrar do.
Yeah.
Taking like, and livers, I don't think they managed to show much advantages over. What is this? At least for colorectal mets, maybe for life, obviously, we don't have experience. You're doing what cases historically were done laparoscopically, robotically. Who is doing them with you? Are you getting one of the transplant surgeons also to join in with you, Ravi? Or hello?
Oh yeah, no, we get one of the HPV. Just two of us do it. Depends whoever is there. No, so,
Yeah, no. In case you have to take the complete tumor out and do all the
so
reconstruction.
if you're doing a XYO, then yeah, we get the transplant guys to do the reimplantation.
Makes sense because they do it regularly.
Yeah, exactly. But I think for anti-cytum, we are.
What do you mean by anti-cytum? Yeah,
We keep the inflow, but detach the hepatocaval confluence.
Okay.
Outflow.
Yeah. In fact, we had a sarcoma a year and a half ago, which is going high, and we don't do sarcoma ourselves. But the difficult sarcomas, the sarcoma surgeon asked us to do them. But this case, I just asked the to refer it on to Birmingham because it was going well north of what is this hepatic veins.
Okay.
In case it required any complex reconstruction, it makes sense to be done in a liver transplant center.
Yeah.
Dr. Shrikant, we will start at 3. People are coming one by one up to
Yeah,
9.
let me know. I'm not changing my screen, Vishnu, in
Okay.
case I lose it.
Yeah, another 2 minutes. Just 2
I'm
minutes.
really sorry. But I got the whole afternoon. I'm not in a hurry. No? I'm sorry about what happened earlier. Yeah.
Okay.
I'm doing it from Bangalore, Ravi. No?
Oh, okay. Are you there now?
Yeah, I'm catching the flight tonight. So I came to visit my mom and dad.
Okay.
Yeah. I'm in my brother-in-law's house.
Oh, okay.
I couldn't do it on my own computer, so I then just shared the presentation.
Ravi, hello, Vaidishwaran here.
Hey, Vaidi, how are you?
I'm fine. How are you?
I'm very good, thank you.
Srikanth, I don't know whether he remembers me.
Why are you working now?
Now there is a small cancer center in Chennai. So I
Yeah.
head the cancer center, Sringeri Sharda Equitas Hospital.
Yeah, fantastic.
But I keep hearing about you from one of my close colleagues who used to work in Apollo along with me, Kumar Gobella.
Yeah, Kumar, Kumar was a gynecologist, isn't it?
Yes.
What's he doing now?
He's a gynae oncologist in Apollo Proton Center.
Apollo Proton, yeah.
Yes.
No,
So I keep hearing about the good work that you do in Oxford.
you're doing excellent work too in India. Technically, I think there are areas where surgeons in India are ahead. Like living down a liver transplant is a good example. Even robotic surgery I think what you're able to do is build on volumes, isn't it? And better access.
Yes, volumes are good.
And also better access to theater so you're operating
Yes.
4 days a week, so you'll technically be more proficient. So,
So nice knowing that two of my seniors are doing so well in the UK. Ravi, I'm always in touch, but I've never got in touch with you. Nice.
Nice to speak to you. Do you remember Puneet Plaha? No?
Yeah, Puneet, I know very well.
Puneet is
He's
also
also
in Oxford. He is a neurosurgeon. He's doing very well. He leads the neuro-oncology, and he's also, leading on some clinical trials, NIHR clinical trials, which is a hard thing to do for a full-time clinician, getting funding and running RCTs. So he's doing very well too. So both of us are from S3. So
yes.
we are working from the same hospital. Which unit did you train in?
S4. I trained in S4.
S4, yeah. Ravi was from S1. He's from the privileged unit.
Next, we have an online presentation by Dr. Shrikant Reddy on small bowel transplant. I would request the chairpersons, Dr. Vishnu Prasad, Dr. Rajesh, and Dr. Shaktivel to chair the session.
So Dr. Shrikant Reddy was alumni from our department, and after his training year, he had gone abroad to UK, and he was trained in the transplantation field, and currently is a consultant in Oxford NHS Trust. So welcome, Dr. Shrikant. You can start, I think. It's a lecture online. So Shrikant, you can go ahead with your lecture.
Thank you very much, Vishnu, for giving me the opportunity. And of course, I don't have the screen, but it's a privilege to speak in front of Dr. Jagdish, Prof. AK, and Prof. Smiles. And I don't know whether Dr. Srinivasan is still there. They were the three bosses when we trained. So I work in Oxford Transplant Center. I'm a HPV and transplant surgeon. There's also under S3 connection between Oxford and Jipmer, Puneet Plaha, who was my classmate with, and who also trained with Dr. Jagdish, also works in Oxford. He's a neurosurgeon. First, I'll speak a little bit about intestinal transplantation. I'm not going to try to capture everything. And I'll also speak a little bit about Oxford. What are the contributions, original contributions that Oxford has made to intestinal transplantation? So the first transplant was done in Minnesota in 1964, but for approximately 3 decades, there was no success. And the first successful series was from David Grant. I think David Grant recently retired from Canada, where he published a series of successful intestinal transplants, which he published in Lancet. It is still a low volume disease. I think that's good news, mainly because the indications for intestinal transplant are a lot less. So the burden of intestinal failure is a lot less compared to kidney failure, means where because of diabetes, there are a lot more kidney transplants done. In Oxford, we do perhaps 4 or 5 intestinal transplants every year, but we do 250 kidney transplants and between 60 to 70 pancreas transplants every year. So this is actually a bar graph showing that actually the number of intestinal transplants done worldwide are currently less than 200. Majority of them are done in United States. In UK, roughly 20 to 25 are performed. And I know now that you're also doing some in India now, means both isolated small bowel and multiviscerals. So what are the indications for intestinal transplant? There are a range of indications. One is if you got short gut due to a number of reasons. That could be because you lost your gut due to mesenteric vascular ischemia, such as SMR, SMV thrombosis, or if you're in a Western society, you also have a burden of inflammatory bowel disease. I think there was a talk by a colorectal surgeon earlier. So a small number of patients with Crohn's could end up with intestinal failure, or you could have full length of bowel, but actually a functional motility disorder where actually the gut doesn't absorb. So if you have intestinal failure, of course, being on parenteral nutrition is a good option for these patients, especially if the patient is very compliant with parenteral nutrition, has a very good technique in using the line, then the infection rates for the lines are extremely low. So I see in patients 25, 30 years on home parenteral nutrition who have an excellent quality of life and who don't want to consider intestinal transplantation. So, and of course, you got some where the indications are more urgent, and such as if you're unlucky enough to develop liver disease, or if you're developing recurrent line thrombosis and then you're running out of central venous access, or if your line usage technique is not very good, and if you're getting recurrent line infections, then your indication could be more urgent than actually a previous indication of not having enough gut, but being on PN, where actually staying on PN is as good an option as having a transplant in terms of long-term life expectancy if the patient is well adjusted to PN. And of course, there are some rare indications. If you have diffuse portal mesenteric thrombosis, we don't do liver transplants in Oxford, so I don't have much experience with multivisceral transplants, but in UK or Cambridge is perhaps the most successful and active European center for multivisceral transplants. One area where Oxford has pioneered and which I'm going to show a few slides of our own experience, which we published, is for locally unresectable tumors such as pseudomyxoma, desmoids, and neuroendocrine tumors. And of course, I think there are a small number of patients where you can't establish portal inflow for liver transplants. So when they do require a retransplant, sometimes you might have a full multivisceral block that is there available while the surgeon does an explant of the liver and sees whether you can get away with a liver transplant. But if you can't, then a multivisceral transplant can be a backup option. So I think one of the reasons why intestinal transplant is actually a lot more challenging than other transplants is actually the lymphoid load that comes with the transplant. And of course, it causes, you get a lot more ischemia reperfusion injury. Means as surgeons, we're getting very good. Means of course, certainly in terms of, I had the opportunity to see Pranjal Modi, surgeon in Gujarat. He came and did 3 robotic kidney transplants as demonstration cases in Oxford. So same thing with living donor liver transplant. I saw Kota Venugopal and Mohammed Rela do a few living donor liver transplants. So technically, of course, surgeons both in India and abroad have become more proficient. But of course, with bowel, because of the lymphoid load, you got a much greater ischemia reperfusion injury. And of course, you also have a higher density of antigen presenting cells. The bowel has almost the same amount of lymphoid tissue as the bone marrow. And of course, all this leads to a higher risk of rejection. And also, the surgery can sometimes be challenging. This is a patient who had pseudomyxoma, has been on the waiting list. And on the day he came for transplant, he had an albumin of 8, hemoglobin of 7, treatment dose of deltapyrin and aspirin. And I just didn't have the heart to say no. But fortunately, he didn't need a transplant. When we actually did the explant with the team in Basingstoke, I'm going to speak a little bit about their experience. We managed to free up more than 100 centimeters of small bowel and the pancreaticoduodenal complex and the stomach. So he didn't need an intestinal transplant. And I think these slides are a couple of years old. 5 years down the line, he is well. He has got isolated recurrence in the left diaphragm, which they're watching. So sometimes the surgery can be a lot more challenging, certainly a lot more challenging than kidney and pancreas transplant, and perhaps as challenging as the difficult liver transplants. So in terms of the operative technique itself, of course, the aorta is the usual inflow, unless you're doing it for motility disorders or unresectable tumors, where when you're doing an isolated small bowel, you can actually do an arterial inflow through the superior mesenteric artery. And the venous drainage can be, if it's a full multivisceral or modified multivisceral, it can be the portal venous system, or it can be the inferior vena cava. So there are a range of surgical options. Of course, you can do an isolated small bowel, or you can have a liver and intestine. And I'm sorry, I don't know why one of the slides of modified multivisceral where you leave the liver behind, but transplant the stomach, the pancreaticoduodenal complex, and the small bowel. And also, I think one of the things that this slide doesn't show is it's also common now. If the recipient doesn't have their own native colon, which you cannot bring into play, to transplant with some colon, usually the right colon, because you don't have to reconstruct the inferior mesenteric vessels. And of course, I'm not a colorectal surgeon, but this is one of the few operations which I get to do where most of the colorectal surgeons have not heard of in Oxford, which is a Bishop-Cook technique, where actually you transplant the small bowel and join the colon of the recipient to the transplant small bowel. And that is for 2 reasons. One is, of course, you, you get some fluid absorption because some of the fluid goes into the colon, but it also has access to endoscopy to look at the small bowel, because half the patients get rejection in the first year after transplantation. So you got easy access to endoscopy where you can actually look at the bowel and actually both visually inspect and get biopsies. And the other challenge in some patients is if you have had multiple laparotomies, you can have, I think all of us are general surgeons in this room. As you know, once you lose the bowel, the abdominal muscle and the fascia contracts to the size of the contents. And when you do a transplant, suddenly you're struggling to fit in the contents of the bowel into the abdomen. And you might have to resort to 2 techniques. The commonest technique is the skin is more flexible, whereas the muzzle is not. So you can get the fascia, the rectus fascia, where you take out the muzzle but have the anterior and posterior rectus sheaths. It acts like a biological mesh, and actually neovascularization happens within the first few days. Or in a small number of patients, you can do a full thickness vascularized abdominal wall transplant. It is actually a technique that the plastic surgeons are very well versed with, where they raise the flap with inferior epigastric vessels, and then the anastomose the inferior epigastric vessels on both sides, and that it's essentially a free flap. But the fascia, rectus fascia, is actually simpler and easier to use and perhaps less risky if you have sufficient skin that stretches and you can get closure on top of the fascia. This is again a picture of where the fascia is being sutured to the donor fascia is being sutured to the rectus sheath of the recipient, and the skin is elastic and it can be pulled across with a bit of mobilization. I think perhaps the person who has contributed the most is Karim Abu El Magad. He was a surgeon in Pittsburgh, who initially worked with Starzl and then became an expert in intestinal transplantation in his own right. He has done the most number of transplants and demonstrated that actually in a high volume unit you can improve. One is the results improve in time, and also you also have 90% of the patients having nutritional autonomy, that is weaning off parenteral nutrition and going on to the enteral nutrition, which is one of the main goals of the operation, and have a good long-term survival, 75% 10-year survival, perhaps not as good as liver transplant, but still pretty good, and 60% 15-year survival. This is again an European study showing that actually quality of life can improve after intestinal transplant in appropriately selected patients. So in terms of immunosuppression, that's as we discussed, surgery can be hard, but as surgeons, we got better at it, both in terms of patient selection and doing the operations. Immunosuppression is, of course, an important aspect of all transplants, especially intestinal transplants, because there is a high risk of rejection. And there's also high risk of infectious diseases, lymphomas, and graft versus host disease. Unlike liver transplant, it's very common to give induction. So there's a range of inductions. One is ATG is perhaps the commonest worldwide, anti-thymocyte globulin, which was actually initially pioneered in Minnesota. Basiliximab, which is an anti-IL-2 antibody. And of course, what we use in Oxford is Campath, which essentially stands for Cambridge pathology, where the antibody is invented. And Peter Friend, my boss, who is retired now, that was his research project using Campath as a immunosuppressive agent in transplantation. So he brought that knowledge and the drug across from Cambridge. Of course, maintenance is similar to other organs, tacrolimus, mycophenolate, and steroids. In patients who are prone to nephrotoxicity, you can introduce sirolimus, mTOR inhibitors. And of course, if you have rejection, you treat with high-dose steroids and ATG to try to reverse rejection. So, of course, rugby is a popular sport in UK, so it's popular to talk about rugby or football rather than cricket or badminton in India. So the bowel, as you know, has got a very large surface area and has also got 100 trillion bacteria. And of course, when you get rejection, you get, unlike most organs, you either get an infection or rejection, usually. Bowel, when you get rejection, unfortunately, you lose your mucosal integrity, and then it also causes bacterial translocation, causing both an infection and rejection at the same time. So it manifests in the form of bowel dysfunction, diarrhea, and of course, if the rejection is bad, you might also get blood in the stools, and of course, there's also systemic inflammatory response in the form of fever, patient feeling rotten, and leukocytosis. If you have a mild, you could have a mild rejection where you could just have inflamed mucosa, or when you have an exfoliative rejection, the whole mucosa has completely sloughed off. And rejection, unlike in kidney transplant, is more dangerous than bowel transplant. It's one of the causes of death in bowel transplant. So it's a bit of a balancing act, as we know, in terms of rejection in immunosuppression. It's not a perfect mathematical science where if you say that, look, we hit a number of 5 and then that's a perfect number you can stay at. So if you're under immunosuppressed, you're prone to rejection of graft versus host disease. And if you're over immunosuppressed, of course, these patients are more prone to attack toxicity, leading to kidney failure. And up to 10% of the patients get lymphomas. So it's a bit of a balancing act. And this is, I think, a useful picture to look at. Means the safe therapeutic window that you have is the widest for liver transplant. Of course, a lot of immunosuppression was pioneered in Cambridge, including the utilization of cyclosporin, sirolimus, and campathin. So Roy Kahn is to say that patients did their own experiments where they stopped and that actually tolerance is possible. And the therapeutic window is much narrower for intestinal transplant. So that's why these patients are much more prone to problems after transplantation, unlike liver transplantation. And this is just another slide showing what are the range of complications that you see. Up to 20% of the patients can get kidney failure after intestinal transplantation. 10 to 20% of the patients can get a lymphoma. And they're also much more prone to opportunistic infections such as CMV or EBV. I'm going to talk a little bit about Oxford's own contributions to intestinal transplantation. This is one of the slides, I think, for those of you who are transplant surgeons. You might recognize that one of them is Roy Kahn, who was professor of surgery in Cambridge. And that is Peter Morris, who started kidney transplant in Oxford. Peter Morris was a very good sportsman. He was an Australian. And in the interviews, it was said that he asked only 3 questions. Did you play cricket? Can you play tennis? Do you ski? And if you said no to all 3, you never got a job in Oxford. But Peter Morris was a brilliant scientist. So he pioneered a lot of aspects of HLA and tissue typing. Initially, he worked with Paul Terasaki in Virginia and took that skills to Australia. And then he was hired as the head of the Department of Surgery in Oxford. And he established a lot of these principles that are relevant to kidney transplantation. And in terms of intestinal transplant, unlike liver transplant, the tissue typing and HLA, those aspects are that are applicable to kidney transplant are applicable to intestinal transplant, and even more so. So I just put in I think a slide which is hard to read. Some of the publications from Peter on HLA and tissue typing in 60s and 70s when he pioneered this techniques, and that's a annual tennis match competition between Oxford and Cambridge surgical departments, which was an important fixture in the surgical calendar for both departments. And of course, the person who helped start intestinal transplantation in Oxford was Peter Friend. He has YMO in Boston. I think for those of you who are liver transplanters, you'll recognize that there's an Organox machine. So I did 3 years of PhD with Peter before, where we established that normothermic preservation of livers is superior to conventional cold preservation. And that's when, after that 3 years of showing that it works, Peter spun out a company and produced a commercial device. So this is some of the members in the Oxford Transplant Center. And the thing about Peter is that actually he's a person who is always willing to take calculated risks on behalf of the patients. So surgery only developed because of surgeons like Roy Kahn and Peter, who are always prepared to push the boundaries and take risks. Both, of course, the patients took the most risks, but also the surgeons who had to put in their reputations online to advance the field of surgery. And I think the person who did the most for starting the intestinal transplant program in Oxford is Anil Vaidya. I think now he's a surgeon in Chennai. We have performed approximately 60 intestinal transplants over the last 15 years. And I'll speak a little bit about areas which Oxford has pioneered. So I think one of the areas we pioneered was driven by a patient. He was an international rugby player who wrote a book, Stephen Prescott, who had a nasty condition called pseudomyxoma peritoni, and he had a fungating disease, and he couldn't have conventional cytoreductive surgery. So this is a slide of one of the patients we operate on, where you have a fungating disease and the abdomen, where you got the jelly occupying all the abutting all the viscera, where it is not possible to do conventional surgery. So this is how it looks for these patients. These slides were actually donated to me by the Basingstoke team. I think some of you might have heard of Bill Heel. Bill Heel was the surgeon who pioneered the total mesorectal excision. I know we heard about robotic surgery, which is fantastic. But the person who did the most for rectal surgery is Bill Heel, because he showed that but doing good surgery with TME, you could reduce the local recurrence rate from over 20% to less than 5%. So it's one of the few surgical techniques which had a huge impact on oncological outcomes for patients. So it just shows that I think the Basingstoke team are pioneers. It's a small hospital, not very far from Oxford. It's a bit like having Cuddalore, means having a hospital in Cuddalore, but there are two areas that they're led in the world. One is rectal surgery, where they established total mesorectal excision. So they did more than any other center in the world for rectal surgery. And the second area where they're pioneered is pseudomyxoma. They've done more operations now than even Sugar Baker. I believe Sugar Baker has stopped operating. So we always do this in collaboration with them, where for patients where they can't do conventional surgery, you do maximal tumor debulking. This is Brendan and Tom Cecil. I think some of you might know both of them. They're two pioneers in peritoneal malignancy surgery, where we do the operations jointly, where Tom and Brendan actually lead on maximal tumor debulking. This is a patient who was transplanted 10 years ago, where we left the liver behind, but the rest of the abdominal viscera, you can see the ureters, the bladder, and the liver, but the rest of the abdominal viscera has been removed. And that's a picture of the very large tumor, Tom and Brendan, a photograph that we took. In the past, we used to do a routine abdominal wall graft. Means Hank is a brilliant, again, a world-renowned plastic surgeon. So where a few months down the line, it's all healed up, well-healed abdominal wall graft. I think that's one of the benefits of doing intestinal transplant. It's a rare disease. Means I don't think you're going to save many lives, but I kind of I find that I get to work with some of the best surgeons in the world on a rare disease. So that kind of it's a learning opportunity for me to be operating with other consultant surgeons. And we published our experience in Annals of Surgery a couple of years ago, where we showed that in carefully selected patients, you can have acceptable outcomes up to over 50% 5-year survival. It's not, I think it's not as good as intestinal transplant or kidney transplant, but I'm also a pancreatic cancer surgeon. So we know that actually when you do pancreatic cancer surgery, after Whipple's, we know that only a third of the patient, 2/3 of the patients can actually get chemotherapy, and 20% of the patients are inoperable at surgery. So the patients that you schedule for surgery, you're getting only 20-25% 5-year survival after having surgery and full FOLFIRINOX chemotherapy. So I think compared to other cancer surgery, the results are acceptable, perhaps not as good as for other transplant organ transplants. The other area Oxford has pioneered, mainly by Hank and Anil initially, is if you one of the difficulties that you have is diagnosing rejection. Some patients can be living in a different country, so they might not have good access to pathology or endoscopy. So if you actually transplanted a bit of a sentinel flap, this is a forearm radial flap, from the same donor, then in case you get a rash in the flap, then that could be under marker for rejection. This is an area where Hank is pioneering, and he's now set up a randomized controlled trial in lung transplant. We've done more than 10 cases, but we got to show that it actually is for an advantage for patients. The lung trial hopefully will demonstrate if there's an advantage, and what is the numbers needed to treat in terms of benefit to the recipients. So quality of life, of course, if you have appropriately selected patients, you get improved quality of life. Mainly if patients have got large tumors, which is causing a lot of pain. Phil Allen, who is one of our gastroenterologists, formally collected the data using EQ, 5D, and SF36 forms, and demonstrated that quality of life actually is improved after intestinal transplantation compared to being on the waiting list. So this is, of course, pictures are always are easier to appreciate rather than numbers. So this is actually one of our patients, Adam Alderson. He is now a public motivational speaker himself, so there's no confidentiality here, where a photo of him with Tom and Brendan, and he's what we call a tree surgeon. He cuts trees, and he went back to being a tree surgeon after having intestinal transplantation. So recurrences are common, means we have seen recurrences in the spine. That's a FDG with photograph, and we have also seen recurrences in abdominal wall. And we've seen a range of complications. We had 4 deaths in 20 patients were transplanted. We had enterocutaneous fistulas. We always tell the patients, look, You need to know all the complications before you decide that this is what you want. So one of the things I wanted to touch on is, of course, most of my talk has been on deceased donor transplantation, but I know that there are a few living donor liver transplants being done worldwide now, mainly in China and a few in Chicago. We're not done any in Oxford. So I think out of almost 4,200 intestinal transplants done worldwide, less than 80 are living donors, and the outcomes are similar to deceased donors in terms of living donor transplantation. I think a few have been done in India. I heard them, though I've not seen any publications related to it. So in summary, intestinal transplant is an effective therapy in well-selected patients. Outcomes are improving. And in terms of future, I think evolving surgical techniques, mainly in terms of patient selection, newer immunosuppression strategies. So one of the areas of research, the new chair of transplantation actually is an expert in cell therapy. So using cell therapy to reduce immunosuppression or transplantation with less immunosuppression or no immunosuppression. That's the area where Oxford, we decided, because the last 20 years we focused on machine perfusion, which has resulted in organox. So, and then we also have a kidney device coming in. And the next area we're going to focus on is cell therapy. And of course, early detection. So I think hopefully we'll reach a stage where we can say for the patients who are on dialysis now, if there is a donor, you talk about keto transplantation, you don't stay on dialysis. We want to reach a situation where if you're on parenteral nutrition, intestinal transplantation needs to be the first choice rather than patients staying on parenteral nutrition. So is it worth it? Means for me as a surgeon, it's an operation 4 or 5 times a year. It's not very common, so you get called when you're not on call. It feels like a hard slog, but it's like seeing a hard rugby try being scored. Means it all feels worth it when your patient does well after transplantation. And more importantly, I get to hang out with the brilliant surgeons such as Tom and Brendan and Hank and Peter. It's not often you operate with your consultant colleagues. So it's a learning opportunity for me as a surgeon. So kind of the current feels like this, a bit of precarious for intestinal transplantation whenever patients are transplanted. But hopefully the future will be a bit like this. For myself, it's a bit like my children when they're tiny. I used to take them to the local woods where you want them to actually grow as confident people who become net contributors to the society. So you want them to take a few risks. But eventually, hopefully, they will be in a stable situation. I think that's the end of the show. End of the talk, sorry. Any questions, Vishnu?
Thank you very much, Srikanth. So there's some questions from Rajesh and Shakti.
Excellent talk, Dr. Srikanth. I'm Rajesh from Rayla Institute. When I go through the literatures on liver transplant and other transplants, I see your name there, and I'm very happy that I could talk to you today. Many publications of you, very high impact factor journals. Thank you and congratulations. So regarding this topic on intestinal transplant, we have experience with living donor isolated small bowel transplants. And recently, Dr. Anil Vaidya, Professor Anil Vaidya did a neonatal small bowel transplant as well in our hospital. So we find that in a living donor, the cold ischemia time, as well as the antigenic, the small bowel length, like limited one with less antigenic load, the reperfusion injury seems to be less. This is what I heard from the surgeons as well when you do a deceased donor. Do you feel that the difference is there between living donor and deceased donor in the isolated small bowel?
I can't talk from experience because we're not done any living donors. But I think, I think you brought out both the relevant points, isn't it? One is the cold ischemia. By reducing the cold ischemia, you reduce the cytokine response after surgery. So we try to keep the cold ischemia short, means ourselves. So unlike, we're not a liver transplant center, we are a kidney pancreas transplant center in Oxford. So usually you always inspect the organ when it comes to your center and then send for the recipient. But that's not the case for intestinal transplant. We send one of the consultants out for procurement. And when you get a call saying that the organ looks okay, then you start the recipient operations. A bit like for heart transplants, by the time the heart comes into your center, you're ready to get the heart out and put the new heart in to try to reduce the cold ischemia. So I think it makes sense. I can't talk about I can't give a comparative experience because we don't do liver transplants, living donor intestinal transplants, mainly because there isn't a need for it. There's enough deceased donors in UK to be able to do a deceased donor transplantation. But it makes sense. I think you brought out both the relevant points. And one of the things that they've done in Leuven is one of the surgeons that we have appointed, Emilio, trained in Leuven. Leuven is a center of excellence in Europe, and so where they use anti-TNF alpha antibody that has been developed mainly for Crohn's disease, means IBD, means that was again developed in Cambridge actually, in London and Cambridge, means like infliximab, means those of who are your colorectal surgeons, and if there's any gastroenterologist, you'll be familiar with it. So it reduces TNF alpha effects. So they're shown they tend to have infliximab in their protocol at the time of transplantation.
May I ask another question?
Yes,
Like we have experience, like our experience in liver transplant, we find that with the technical advancement, better immunosuppression, and many of the post-op care, most of the indications for liver transplant, the success rate actually can be easily gone up more than 90%. But one indication is the portomesenteric thrombosis, where the portal flow to the graft, whatever modifications we do, we take it from the renal vein, whatever, still the success rate is around 75 to 80%. And this is where obviously the multivisceral transplantation role comes in. Do you still feel that it is better to push liver transplant alone with better inflow techniques, or it's better to go for a multivisceral? What is your take on that?
I think that's a very good question. So in Cambridge, what they do is when you have difficult liver transplants like this, those patients get referred to Cambridge, where there is an anticipated difficulty in establishing inflow to the liver. So what they do is Andrew Butler, who is the lead surgeon there. So what he does is he tries his best to do a liver transplant actually, and if he fails, then he does a liver small bowel. Actually, he leaves the pancreaticoduodenal complex, mainly because we know that liver transplant outcomes are much better if you're looking at 1 year, 5 year, 10-year outcomes. It's one is like doing a liver transplant post-op follow-up is like flying an aeroplane. The other one is like flying a space shuttle. The risks are always greater for your recipient. Even if you successfully get the patients past surgery, that's only one aspect of success. Success is 5 years, 10 years, 20 years. So what he does is Andrew does his best to do a liver, and if he fails, then he does a liver small bowel. But he's able to do that with the knowledge that he's got a block. And it's also the other way around. He tells there are some patients who get referred thinking that actually, you know what, there's no way you can do a, what is this? Those patients are not on PN, and there's no way that actually you can do a small, sorry, the liver is actually marginal. It might or might not do well after a transplantation. So you might need a liver small bowel. But what he does is he puts the liver on organox and has another recipient on standby and does the bowel transplant. If the lactate and everything doesn't go up and patient is not going into, you know that in times of stress, the liver can fail. The patient is doing all right when they're not stressed. You're a liver transplant surgeon, whereas I'm not. So if the patient tolerates the reperfusion injury fine and the lactate is not going up, then of course, then they can close up and use the liver for a different recipient. So Cambridge is a bit of a center of excellence for those difficult liver transplants. And what they do is they try to actually get away either without a multivisceral or without a liver wherever they can, depending on the situation.
Thank you. Nice to know all these modifications.
Yeah,
Thank you.
yeah. Some of them are not my personal experiences because we have joint meetings with Cambridge. So.
Okay, thank you, Sheshika. Can you please stop sharing your screen so that person can? Thank you very much. Next 2 lectures are online. If you want to stay back, otherwise, it is left to you. Next lecture will be Dr. Ravi from Birmingham. So, who's the?
So I would request Dr. Rajesh, Dr. Shaktivel, and Dr. Muthukumara Swamy sir has left. So you can share the sessions. Hello. So are we audible?
Yes, I can hear. Thank you.
Thank you.
Good afternoon, everyone. I'm Ravi Marudanagam. I'm one of the consultant HPB surgeons at Queen Elizabeth Hospital in Birmingham, and I also work at the Children's Hospital in Birmingham. I'll just try and share my screen. Just bear with me a second. Can you see the screen now?
Yeah.
Okay, so I'm going to focus on anti-situm and ex vivo liver resections. They're not big numbers, so they are very complex procedures. So we've developed a portfolio of these complex cases over the last few years, especially post-COVID. So the bulk of the discussion today will be on anti-situm resection. I'm going to focus mainly on the technical aspects of it rather than full experience. And I'll briefly touch upon the ex vivo resection. So what do they mean, anti-situm and ex vivo? So essentially, anti-situm has got different names. Some people call it ex situ in vivo liver resection. But essentially, it means you are dividing the hepatic venous outflow, but you're keeping the inflow to the liver intact. While in ex vivo, you're taking the entire liver out, and then whatever resection you need to do, you do it outside the outside the body, and then reimplant the liver back into circulation. So that's a pictorial depiction of anti-situm and ex vivo. As you can see on the left side, you can see the clamps on the cava above and below, and you can see the clamp on the hepatic artery and portal vein. So you do a complete vascular exclusion essentially. Then you detach the hepatic venous outflow to do whatever resection you need to do, and then reimplant back. While in the ex vivo, as I mentioned, you just completely take the liver out and then resect and reimplant the liver back in. So when do we do anti-situm resection and when do you do ex vivo resection? So anti-situm is mainly for small or medium-sized tumors, which are at the hepatocaval confluence. You can see a couple of pictures on the right side. So you want the tumor to be predominantly on one side and still in contact with the contralateral hepatocaval confluence. So for example, in the top picture, you can see the left and the middle hepatic vein are involved, and then it is in contact with the right hepatic vein and the cava. And the bottom picture, it's exactly the other way. Your right and middle and left are in contact. So you still need some length of your vein to reconstruct. So you can't have all three veins to a long segment involvement. Then it becomes extremely challenging to do. An anti-situm is preferably for a small or a medium-sized tumor. So you still have the space to rotate the liver and then do the resection while the inflow is still intact. So there are a couple of types of anti-situm resection where you do with caval resection or without caval resection. With caval resection is technically slightly easier compared to preserving the cava. So as you can see on the picture on the right side, so that shows if you're going to resect the cava and reconstruct with the graft and then reimplant back onto the graft, or just preserve the cava and then reimplant the hepatic vein onto the cava. So the basic principles of anti-situm resection is complete total vascular exclusion. So you clamp the suprahepatic and the infrahepatic cava, preferably above the renal vein, but sometimes it may not be feasible. And then you also clamp the inflow, the hepatic artery and the portal vein. So then you establish a vena-venous bypass. So we prefer to use the SMV, very rarely the portal vein. Some people use the inferior mesenteric vein as well, but the caliber, we find it much smaller. So we use the SMV for the portal bypass, and we use the left femoral vein for the lower limb bypass. But again, if you have length of the cava, you can do directly from the infrarenal cava as well. And then back into circulation through the internal jugular vein, so which the anesthetists have the central line anyway, so that's much easier. So using a cardiopulmonary bypass. So we do get the cardiac team involved, so they run the perfusion for us when we do these procedures. Then perfuse the liver using hypothermic HTK solution and also do surface cooling of the liver to preserve it. And then you do the resection and then reconstruct the hepatic venous caval confluence. So this is again pictorial depiction of that. So the stages are very clear. So you have to first get total vascular exclusion. So clamp above the cava, clamp in the cava above the liver, clamp below the liver on the cava, portal vein, and the hepatic artery. So then you maintain the perfusion through, this is the SMV. So we don't directly cannulate the SMV because we don't want to injure the endothelium. So we put a side graft onto the SMV because we are a transplant center, we have cadaveric grafts available. So we group match it and then put a side graft to the SMV. So, and then from the left femoral vein, so these two go back into the pump and to the internal jugular vein. So in the meantime, cannulate the portal vein onto the side which is going to be preserved and then perfuse with cold HTK and then obviously surface cooling of the liver as well. So this is one of the cases we did very early on. I'm not sure whether you can appreciate the tumor there. So it is involving the left and the middle vein and the anterior wall of the cava and the anterior wall of the right hepatic vein. So as you can see, the right hepatic vein reconstitutes quite well after a short segment. So that's one we were planning to do. Left extended hepatectomy with cuff of right hepatic vein resection and cuff of caval resection, and then reimplant the right lobe with reconstruction of the right hepatic vein. So we always do functional SPECT scan with mebrofinate in all these cases to make sure the future liver remnant is adequate. So you can see the red one is the one which is going to be left behind. As you can see, the volume is adequate, the functional volume and the functional capacity is good as well, more than 5. So we'd expect it to be at least 2.69. Then it's safe to proceed with low risk of post-hepatectomy liver failure. So it's good to know the principles of anti-cytum resection, but it's very important to have a clear strategy because we need to know which step needs to be carried out when. We don't want to get confused and mess up the different orders of the sequence of the events. So the first thing is to isolate. I'm going to show you a video after this, but these are the steps essentially you'll be following for an anti-cytum resection. So isolate the suprahepatic cava. Always divide the diaphragmatic vein. It gives you adequate length, so it gives you another a centimeter and a half of suprahepatic cava. So if not, you may have to open the chest. But most of the times, for a small, medium-sized tumor, you are able to get adequate length of the suprahepatic cava. Then mobilize the liver completely and divide the retrohepatic, short hepatic veins. And then isolate the inferior vena cava, preferably above the left renal vein if you can. If not, sometimes you will have to reimplant the left renal vein. Then come back to the hilum, divide. So in this case, we are planning for a left hepatectomy. So divide the left hepatic artery and divide the left portal vein, but leave a stump at the confluence so that you can use that stump to cannulate the right portal vein. Again, you don't want to be cannulating the right portal vein straight. You don't want to damage the endothelium and increase the risk of thrombosis. So use a stump to cannulate the right portal vein. The same way with the veno-venous bypass, use a side graft onto the superior mesenteric vein and then cannulate the left femoral vein. So left femoral vein, we do the conventional Seldinger technique to get a cannula into the left vein. So then you can start the transaction. So you don't have to start the veno-venous bypass yet. So you can start the transaction because you are devascularized one side. So it's like conventional in situ liver resection. So carry on with the transaction till you come close to the tumor at the top. So once you're close, then you can do a complete vascular exclusion. Just clamp the cava above and below the portal vein, then start the cold perfusion and the veno-venous bypass. So once it is in place, then you complete the rest of the transaction and excise the part of the right vein, a cuff of the cava, and the complete middle and the left hepatic vein. Then reconstruct the right hepatic vein and the cava, and then you can release the clamps and restore circulation. Let me see if this video plays. Can you see the video? Are you able to see the video? I can't hear you.
Yeah, we are able to see the video.
Okay. So we're trying to get, so that's the inferior diaphragmatic vein divided, and you've got a good length of the suprahepatic cava. So that gives you at least a couple of centimeters. The intraoperative ultrasound to confirm the findings. So again, I'm not sure how much you can appreciate there on the quality of the picture. So it does involve the middle and the left confluence, and it is touching, it's in contact with the anterior wall of the right hepatic vein and the cava.
This is transesophageal echocardiography.
No, this is directly on the liver.
Okay, okay.
Yeah. And so now we are on the retrohepatic, short hepatic veins. We are dividing all that to isolate the intrahepatic IVC. And then now we're coming to the hilar dissection. So the plan is to divide the left artery and vein. This is one of the first videos we have done. So our technique has changed and evolved since then. So here you will see we're isolating the whole pedicle, but now we isolate separately the artery and the portal vein. Then getting the SMV to put a side graft on for the bypass. That is suturing a cadaveric iliac vein graft, group matched to the patient. But again, it's not going to stay in, but a cuff of it will be left at the end when we staple it off. So we got a Y cannula. So one goes into the SMV through this graft, as you can see. So the tubings are all heparinized. So we don't heparinize the patient separately. And then the left femoral vein access through a Seldinger technique. So this is cutting the portal vein to insert the cannula. But as I said, now we use the stump on the other side to cannulate through that side. And then you start the transaction. So you can see now the venovenous bypass is still not on. So then we are ready with the clamp. The intrahepatic cava is clamped, then the suprahepatic cava is clamped as we come to the top end. So now it's running on the venovenous bypass. So even though there's no bleeding, it's very important to meticulously identify the small vessels and tie it. That's surface cooling of the liver. Then we go into the top end. Sorry. So that's the right hepatic vein. So taking a cuff of the right hepatic vein along with the tumor on the left side. So then the left side is coming out so that the cuff of the cava, the left side is completely separated now. So reconstruct the right hepatic vein. So we use again a cadaveric graft, group matched. So you can either use a tube graft because on the caval side, the defect was longer. So we used a flat graft and reconstructed it. So as you can see, the whole of the cava is longer. So now it's reimplanted onto the cava. So complete the rest of the transaction on the left side and everything is divided and the specimen is out. So the remaining rent on the left side is closed. Then you start the reperfusion. So you see everything suddenly all bleeding all over the place, but it can be controlled fairly soon after that because there's not much of, because of the venovenous bypass, you don't get much of a ischemic reperfusion injury here. So the graft is divided, then put hemostatic agents on the cut surface of the liver. So that's about the anti-cytum. I'll briefly touch upon ex vivo. It's not a very commonly performed operation, but it's good to have the skill of doing the ex vivo in the armamentarium of the HPB surgeon. So if there's a need, you could do that. So this is predominantly done for massive tumors involving the hepatovenous confluence. So either colorectal or sometimes cable tumors, cable leiomyosarcoma involving the liver and the hepatovenous hepatocaval confluence, or even adrenocortical tumors or right renal tumors, RCCs. So the ex vivo is a better option. Ex vivo is slightly technically easier in the sense you take the whole liver out, so you do everything outside. But the biggest problem in the ex vivo is the space. So tumors are massive. So to get control of the suprahepatic cava can be extremely challenging. So ex vivo can be done two ways, either with a veno-venous bypass, similar to anti-cytum, or the advantage here is you can reconstruct the cava with a cadaveric graft and do a portocaval shunt. So then you don't need a bypass. So your systemic circulation is restored and your portal venous circulation is restored as well. So that way you can avoid the complications of the veno-venous bypass. So here I don't have a video, but I'll show you the still photos we have taken because it was quite a stressful condition, so we couldn't get a video on time. So this is the large tumor involving the hepatovenous confluence. So this involved predominantly the superior segments, segment 7, 8, and 4A of the liver with all the 3 hepatic veins. The liver is extremely congested because of the outflow obstruction, and the tumor was pushing the diaphragm, and it was difficult to get to the suprahepatic cava. In such situations, we keep the cardiothoracic surgeons as a standby. If necessary, they can open the chest and get the control of the cava below the heart. So the steps of the procedure are, so you have 2 teams of surgeons. So one prepares the iliac vein graft and the backbench to replace the cava. So the caval caliber is almost double the size of your iliac vein. So what we do is take 2 iliac vein grafts and then staple it, reverse it inside out, staple it, and then reverse it back. So then you have the staple lines outside, you have a good caliber iliac vein. Or you can use a synthetic graft as well. But only one case we used a synthetic graft. In all the other ones where we resected the cava, we were fortunate to have cadaveric vein grafts. So then mobilize the liver, then exactly similar to the anti-cytum, you clamp the cava above, total vascular exclusion, take the liver out, and then one team reconstructs the cava, doing a portocaval shunt, while the other team resects the tumor in the backbench. So then reimplant the liver. So the biggest downside of ex vivo is you are faced with all the potential complications of your inflow reconstruction. So you are predisposing to the hepatic artery thrombosis, you've got a normal sized bile duct, you've got long-term complications with biliary strictures and bile leaks. So that's a case where we mobilize the liver, the first photo, then the liver is being explanted, and you can see the photo below, the cava was reconstructed, the cadaveric graft, and you can see the portocaval shunt. So sometimes it may not be feasible to directly implant the portal vein onto the caval graft. So you may need another small iliac vein graft to reimplant onto the cava. So the liver is being perfused with HTK and it's kept in a cold fluid, and then you do the transaction. So this was a colorectal tumor. So as you can see, the margins are still close, but as you know, the vascular R1s have got the same outcome as an R0 resection in colorectal liver metastasis. So then the liver is resected and then we reconstruct the vein outside, and then it's reimplanted. So that's briefly about ex vivo. So to conclude, these procedures are very rarely performed complex operations, so should be carried out in centers where they do a high volume complex liver resections and also liver transplantation, so that you have easy access to the vessels. And especially with the ex vivo, the skill of implantation is much easier if there is a routine transplant work going on. Thank you. Any questions?
Thank you, Dr. Ravi. Excellent video. It's a very complex operation and then very nicely demonstrated. So I'm from Rela Institute. We do a lot of living donor transplants. And then with the experience of living donor transplant, we find that doing ex-situ is more a simplified form, actually, when you compare to an anti-cytum. So with your experience, if a patient comes to you with a hepatocaval mass, and then you have the option both of anti-cytum as well as ex vivo, would you choose anticytum based on the tumor size, or intraoperatively you see a lot of congestion, you don't want to do a transection, better you do ex situ? What is your predominant determining factor in choosing between anticytum and ex vivo?
Thanks, Rajesh, for the question. Yeah, because as I mentioned, I mean, we don't do living donor yet. I mean, we were doing before. We are going to restart the program soon. So our experience is predominantly on cadaveric liver transplant in Birmingham. So our decision is predominantly do an anticytum. We prefer to do it. The reason being, as I mentioned, to avoid all the complications of inflow reconstruction. The decision to do whether anticytum or ex vivo, again, is purely based on the size of the tumor. If you can get adequate space on the top, we prefer an anticytum. If it's going to be a huge tumor, then you're going to struggle with the space to resect in situ, then we would take it ex situ. I did a 10-year-old girl 2 weeks ago. She's still an inpatient for endothelial sarcoma. So, but unfortunately, she had a tumor rupture 4 or 5 weeks prior to surgery. So she had sort of disseminated disease, but all confined to the right upper quadrant. So we ended up doing ex vivo because just we didn't have a space, and we had to get the cardiac surgeons to get control of the cava in the chest. So such patients where there's absolutely no space, there's no option of doing an anticytum. But very small tumors, especially neuroendocrine or colorectal mets or small HCCs in a normal background liver, which is involving the confluence medium size, if space is not a huge issue, but only the caval confluence involvement is an issue, then we would still prefer to go for an anticytum.
So may I ask, so let's say you have a small tumor and then it is involving almost all 3 veins, but you decided on anticytum. You're opening the patient, you find that the whole liver is congested and you can't do a transection. So what is the time limit that you have it for anticytum? With fully congested liver, you still go ahead preferring to do an anticytum?
We would, as long as within, because we will still have the cardiopulmonary bypass all set up ready. So converting to an ex vivo won't be a huge issue at the time anyway, if we need to do it. So if it becomes a problem and if it starts bleeding and things are trying to go out of control, then we would definitely convert to an ex vivo. Having said that, we didn't have the need to do that so far. But there is always the first one, so it may happen. But converting an anticytum to ex vivo, we could do that if needed, yes.
Thank you.
Hello, Professor Ravi. I'm Dr. Shaktivel. I'm one of the junior consultant in Jipmer now in Department of Surgical Gastro. I was in King's actually for 3 years. I heard a lot about you, but wanted to come to your center, but I mean, unfortunately, didn't have that things didn't happen well. So excellent video actually on anticytum resection. The thing is, when you do an anticytum resection, you always be prepared with the thoracotomy incision, or you will be able to manage with the Mercedes or a right trapdoor incision. The other question is, yeah, one by one I'll go. Yeah.
So if we had to open the chest, we had to be prepared well in advance. So we prefer to have them and then not necessary to open if that's feasible. Even if there's a slightest chance that we might need control from the top end, we need to get the cardiac guys in on time as a standby, because it's almost impossible to get them as an emergency. So based on the size of the tumor, as I said, most of the time we can predict. We haven't had the need to call the cardiac guys as an emergency so far. But if you think the chances of XY was likely, then definitely they are there and they are aware they'll be there. So yes, we didn't have the need so far.
Yeah, and the other thing in the video you showed one anticytum resection with the caval preservation. Suppose if you are taking like a caval replacement, if you are planning anticytum, will you do a portocaval shunt in that case, or you will rely only on the veno-venous bypass?
So if you're doing an anticytum and a caval resection, it becomes tricky to do a portocaval shunt because you're taking the cuff of the cava very high up in the hepatocaval conference. You're not coming all the way down, no? And your veno-venous bypass is already there. So you don't need to do a portocaval shunt, no? So you just reconstruct the cava and then take your time to resect it because your bypass is already set up.
And the hypothermic perfusion with the HTK, which you give, is it a continuous infusion or you give it intermittently?
It's continuous.
And the venting, you told it is being vented out through the cava.
Yeah, again, it's tricky when you're doing anticytum. So you have to make a hole somewhere. So if you have adequate length on the top, means below your suprahepatic clamp, close to your liver, which you are going to excise as a part of the tumor, you can make a nick there and drain it. If not, the best thing is at the back of the liver, the cava behind the liver, just make a cut there, just vent it out there.
Nice presentation, Professor. I enjoyed your presentation.
Thank you.
Hello, Ravi. Anandakrishnan here. Nice
Hello,
to
sir.
see
How are you?
I am fine, thank you. I don't know enough to ask you a question, but nice presentation anyway.
Thank you, sir. Nice to see you there, actually.
Right.
Now I can see the video, all of you. I can see Professor Jagdish and Professor Smiles and Ranjit as well. Nice to see all of you.
Dr. Srinath did his MS from here and MCH from All India Institute of Medical Science. Afterwards, he moved to US, worked in Baylor Institute. Later, he moved to Minnesota. Currently, he's doing is a lead in pediatric liver transplantation. Is also practicing total pancreatectomy and auto transplantation pilots. So over to you, Srinath. Please appear on the screen and can start your presentation.
I would request
Thank you very much,
Dr. Rajesh,
Vishnu.
to chair the session.
Actually,
And Dr. Rajkumar.
I am so grateful to be on the Zoom. I wish I was a person, and it brings back wonderful memories. And my colleague GVSN actually is on the Zoom as well. Hi, Prasad. Good afternoon. So way back in 1990, myself and Prasad were very fortunate to train under Dr. Anandakrishnan. And good morning, Chief. It's morning here, so good afternoon, Chief. And it's so wonderful to see Chief and Dr. Jagdish and Dr. Smile. And we are very, very grateful for all the training and the foundation you gave us. Thank you, sir. And then Vishnu, congratulations on a wonderful program. And it's so nice to see that the Jipmer alumni have really taken off and actually leading the field. I mean, it's so nice to listen to talks about robotics, small bowel transplantation, ex vivo resection. Mine is going to be a really simple talk, but congratulations on the program. So briefly, I'll try to talk a little bit about what we are doing at our center using the normothermic liver perfusion. So what it is, I'll talk a little bit about the challenges in liver transplantation as of today, what is going on with our wait list, the concept of the normothermic liver perfusion, what are the extended criteria donors, and touch a little bit upon what the landscape of liver transplantation in the US is using donation after cardiac death livers, describe our experiences, and hopefully there'll be some time for questions. As of today, the results of liver transplantation have really, really improved. When we looked at our data for last year, I think we have a 90-day survival of 99%, and the 1-year survival is also at 99%. So things are really, really good in terms of outcomes. And we are also transplanting more compared to nationwide. But the main problem that is plaguing liver transplantation as of today is death on the wait list. As you can see, last year we have probably done close to 120 adult liver transplants and another 20 pediatric transplants. But we've lost 15 patients. 8 of them died on the list, and 7 of them deteriorated to the point that they had to be removed. So that remains the real problem in liver transplantation today. So what were we doing in the past? In the past, we would just retrieve the liver from a donor and then put it on cold storage. And on cold storage, you could keep the liver for 12 hours. But then the number of livers we were using was quite restricted. So now this concept came somewhere in 2016. Transmedics kind of invited us to join a trial. So at that time, the plan was, instead of putting the liver on ice, what if we perfused the liver through the portal vein and the hepatic artery? This was the schematic diagram then. And then the advantages clearly were when you the disadvantages of cold storage are there's no energy, there's an anaerobic metabolism resulting in lactic acidosis and vasoconstriction in the liver. Whereas if you were to perfuse it, then you would recapitulate the human body environment and then get a good acid-base balance, keep the vasodilatation going, and have a near physiologic function. So the trial was very limited. We were one of the centers for TransMedics, and it was only for standard criteria donors. So we played around with many things. One is the duration of the NRP. We were actually doing it only for a very short duration. And we looked at the bile production and then played around with the flows. And after that, once it got, and we are also, it got approved, we started using it for extended criteria livers. So just to give you an example, on your left side of the screen is a normal liver, and then right side is steatosis, and you biopsy that, it's almost 50 to 60% macrosteatosis. These are livers that typically don't work, or we don't know if it work or not. So that's a situation where we would, as all of you know, obesity is pretty rampant in many countries, and a lot of the livers are not usable because of the fat content. So this is a type of liver that we would put on a pump. And then once you put on a pump, you can check the lactate production, and if the lactate decreased from whatever the starting was, like 6 or 8 or 10, and came down to 2, then we would do the proceed with liver transplantation. Although the initial results were quite good, we are still struggling to understand this. One of the reasons we are struggling to understand this is that, as all of you know from our physiology days, there are 3 zones in the liver: zone 1, zone 2, zone 3. Lactate is predominantly cleared by zone 1. So even if you have complete necrosis of zone 2 and zone 3, the liver will still clear lactate. And if you transplant that liver, the chances of primary non-function could be present. So now we are looking at other things like bile pH, and recently the Cleveland Clinic has started work on flamin mononucleotide. So more to come on this. But as of today, although we are experimenting putting steatotic livers on the pump, we still don't have definitive knowledge on what to do with the numbers and how to assess the liver. So more to come on that. But there is one area that we have made significant progress in the last 2 years, that is in donation of cardiac death. I know that in India, donation of cardiac death is legally approved, but not widely practiced, but it's become extremely useful in the United States and the West. So essentially what has happened in the last 2 years is that the neurosurgical management and neurological management of patients has significantly improved. So a lot of the patients that are treated by neurosurgeons and neurologists retain some brain function, don't proceed to brain death criteria, but then they are completely have zero prognosis. So those are what we call as donation of the cardiac death. So in them, what is done is the patient, the family gives consent, the donor is taken to the operating room, the life support is withdrawn. And if the donor arrests within 30 minutes, then there is a mandatory 5-minute period, no touch, to make sure there's the patient has in fact passed away. And then we retrieve the liver. Now, this time is like putting a Pringle maneuver when we do liver resection. So what happens is that the bile ducts get damaged, and this is a patient of ours in 2016. Within a month, you can see they develop liver dysfunction, and when we did an ERCP, the entire biliary system is gone. So we have tried in the past to limit the number of donors and somewhat keep guardrails so that we only take low-risk DCD donors. So we did that at our center, and we kept the donor age to less than 50, kept the cold ischemia time to less than 6 hours. That means real quick transplantation, and tried to inject some TPA into the hepatic artery and only picked low-risk recipients. But then we were able to reduce that ischemic cholangiopathy from around 25% to 15%, which is still super high. So what has helped us with this, which was still high? So this is a slide giving you the picture of ischemic cholangiopathy. One is normal, two is diffuse necrosis. These patients essentially need a retransplant. The C is the multifocal strictures, and this patient also needs a retransplant. And then D and E are the minor forms which can be treated by ERCP. So when we say 15%, I was referring to the diffuse necrosis as well as multifocal progressive. So this is an area which has really changed in the last 2 years with normothermic liver perfusion. We didn't know about this when we were doing the trial because during the trial, DCDs were excluded. But then after FDA gave us an approval and we started using them, we realized that we could actually make an impact. And as you can see, in the United States, approximately 1,500 livers were transplanted using DCD donors in 2023. And now we are up to 3,000. So it's doubled. And I anticipate this number going up. If you look at the total number of liver transplants done in the country, it's about close to 12,000, and out of which, as you can see in this graph, the DCDs now constitute about 30%. We do have some amount of living donation. I know in India, almost 100% or 95 and more percent are living donors. The major advantage in the West has been that the organ procurement agencies and deceased donor consenting has been extremely good. So we are very fortunate to have that and don't have to put normal people under the knife. But we do living donors for particularly patients that don't have a high MEL score. For example, patients with primary sclerosing cholangitis, autoimmune liver disease, or primary biliary cirrhosis, where the severity of the liver disease does not reflect the MEL score, and these patients don't reach the level of getting an organ on the list. Those are the ones we are using living donors. Now, there are two devices, and as Shrikant alluded, this device on your right side is the one developed in Oxford. The device on your left is the device that's developed in the United States by Walid and his group. It's a Transmedics company that has taken over and gone private. So what are the outcomes? I have on purpose removed any trial that was sponsored by the company to avoid any bias. But there's one good study that has been published in January from JAMA, from our colleagues, actually, Reddy and his group from Mayo Clinic Consortium. You can see that there were about 300 patients of DCD before the trial, before the FDA approval of the device. And then once it was approved, they did about similar number, 264. And when they looked at early graft dysfunction, as you can see in the graph here, the group that had normothermic perfusion, even if they were DCD, they had the least amount of graft dysfunction. And the worst was when you don't use a pump for DCD. And then statistically, the brain dead donors had lower, but not significantly different. Then among those four groups, statistically, the benefits were most seen for normothermic perfusion with the DCD livers. As you can see here, the length of stay was 5 days. Length of stay, total hospital stay was 5 days. And the total ICU stay is about a day and a half. And then the incidence of kidney dysfunction was also significantly lower. Not only that, these patients had a much lower incidence of readmission compared to the cases where you did not use the normothermic perfusion. To be honest with you, for a straightforward liver at our institution, the average length of stay is about 7 days. And then you use a pump, it drops down to 5 days, which is remarkable compared to where we were 20 years ago. Now, the other advantage of the using the normothermic perfusion has been the operating time, which is much lower with these cases. They tend to go faster. This is primarily because of two things. One is once you pump the liver, all the bad stuff doesn't reperfuse when you open the clamps, so the hemodynamic stability is much more. And the second piece is that the liver seems to be well preserved and kicks in faster. So the amount of oozing, the amount of coagulopathy you see after reperfusion is significantly lower, and that results in less utilization of blood products in terms of the packed cells, the FFP, the cryo, platelet volume, and as well as the total volume of all the blood products. Now, as of today, what has been achieved is that the graft survival is the one that is statistically better now. So compared to using the pump versus not using pump, as of today, we are able to increase the graft survival and reduce the number of grafts that have primary non-function or graft loss. The primary endpoint of overall patient survival is not yet seen, but I'm expecting that in the next couple of years, we will be able to achieve that. The reason we don't see a change in survival for the patient is that all those patients that have lost the graft, we have retransferred. Now, what is the experience? After the trial, we were initially slow adopters, but then in the recent last 6 months, we have actually expanded our criteria. So now, in the past, we would take only donors that were 50 years or lower, but now we have expanded it to 60. And we use the DCD donors for all our patients on the list, except those that are pediatric or expedited or candidates with MELD score of more than 35. Those are the ones that we transplant with brain dead livers. In line, the utilization at our program has increased since we are using pumps in the past, like 2-3 years ago, only 25% of all the referred donors were retrieved. We were able to retrieve livers, but now it's gone up to 60. And the numbers, as you can see, have also gone up. I'll show you a little bit of a video of how this pump works. How we put it. Can all of you see the video? Yes.
Yes, Prof. We were able to see the video.
Great. So this is the machine, the one we use at our program. So the first thing is you have to prime the machine with blood, and then this is the liver that has already been benched on the back table. And as you can see, if you can appreciate, there is a cannula already placed in the portal vein, there's a cannula in the hepatic artery, and there is a cannula in the IVC. The most important thing is to make sure that there's no kink on the outflow or any obstruction to the outflow. And then the first thing we do is we connect the portal vein cannula. You can see my fellow doing that. Once it's done, that's the critical piece because the pressure in the portal vein is only about 15 millimeters of mercury. So if you have any kind of obstruction, the liver will not perfuse. And the second step is to connect the hepatic artery. The key in the hepatic artery is all the branches of the hepatic artery need to be tied off because the pressure that we put in the hepatic artery is similar to around 60 to 80 millimeters of mercury. So that is the main step for the artery. And once the artery and vein is connected, this is a beautiful machine in the sense that it's almost like a computer with sensors. So once the machine is connected, then you can see everything on your computer. And on the top is the hepatic artery flow. Below that is the portal vein flow. In general, what we aim for is we aim for at least a liter or more in the portal vein, and then about half of that in the hepatic artery. That's 500 ml. Then the good news is that this device is so good that it has an inline vasodilator prostaglandin in there. So you can adjust everything on the computer to increase the flow. And it takes about 30 minutes or so to stabilize the liver. But once you inject the prostaglandin, the arterial flow goes up. And once we get the flows and make sure that and there's also an inline for nutrition for the liver, which is essentially TPN with some bile salts. So once that's set, then we start our recipient. And as you can see, our my fellow resident is setting that up. And once we do the hepatectomy, essentially what is done is we connect an online HTK to the liver and flush it out, and then implant the liver. Thus far, we have done 52 cases. The oldest age has been 46 years, and we have pumped his livers for almost 12 hours and had a stable reperfusion. Clearly, it's a lot of work looking at all these offers, as you can see there. What has been the experience of the pump and how has it correlated to the outcomes? Like I mentioned to you earlier, the results of liver transplantation are extremely good now. It's about 100% for this cohort in the last 1 year, 99 including the brain death donors. We have had 12 biliary strictures out of 36. And when we look at the pump characteristics and trying to correlate with the outcomes, this is, we haven't published this data yet. But the one thing that stood out was the portal vein flow. If the portal vein flow is higher, this seems to be associated with biliary strictures. But what is interesting is that in the past, like I showed you, we used to have type B and type D and E strictures where there was significant intrahepatic biliary strictures and cholangiopathy. By using the normothermic perfusion, we now only have anastomotic strictures, and some of them are actually, some of like the case you see on your left, this was just a size discrepancy, probably a small duct on the donor connected to a larger duct on the recipient, and probably some amount of edema. And the second one here, this one was also minor. So the strictures are minor and easily manageable. So this is one after 2 year CPs. You can see the stricture has completely gone away. So what does it mean to the program? So essentially, the major benefits for surgeons have been that we are now not doing cases during the night. We put the liver on a pump, and from 50% to almost 90%, we are doing daytime, like the living donor transplants we do. The length of stay has actually decreased. However, this has been associated with a significant cost. Like I showed you earlier, the cost of using the TransMedics pump, which is now commercialized, is almost $90,000. So it's about $135,000 more when we use this machine. So in summary, normothermic perfusion device has become quite popular in the last 5 years. And as of today, the main role of the normothermic perfusion has been for donation after cardiac donors. Regarding the extended criteria donors and fatty donors, we are still experimenting, trying to understand what the viability or assessment of the liver on the pump is. But at the end of the day, the goal of liver transplantation today is to eliminate the waitlist mortality, and increasing this donor utilization by using normothermic perfusion is probably going to take over the next 5 years. And clearly, there are other devices like cold perfusion, which are not yet FDA approved. So hopefully when they come in, the competition will go up and the cost will come down. With that, I want to thank the colleagues I work with in the liver transplant program. And this is our hospital. And once again, it's a privilege to be able to speak to you even online, and so wonderful to see my colleague GVSN as well as Professor Anand Krishnan. With that, I'll stop.
Excellent talk, Dr. Srinath. This is Rajesh here. And
Hi,
always,
Rajesh.
hi, sir. So I always look up to you for your discussions in pediatric liver transplantation, the technical aspect. And in Houston, there was a wonderful discussion that you had on the pediatric liver transplantation, the technical aspect of it. Nice to hear the talk, sir. May I ask? So I heard that this machine perfusion thing, organ normothermic one, has transformed the logistics of liver transplantation in the US completely, where most of the transplants are happening only in the day. I don't think any transplant is happening in the nighttime. So that's a big, big transformation, isn't it?
That is very true, Rajesh. Thank you so much for that good question. So like I showed you in the statistics, in the past, we were doing 50% of the liver transplants at night. And now 90% of them are done during the daytime, except for cases like fulminant. We do them during the nighttime. The major advantage of the pump has been that you can, if you have 2-3 liver transplants in a day, you can just put one on the pump and in fact do the one the next day because we have used the pump for almost 24 hours.
And the other thing is, for example, you're doing a lot of pediatric transplants. You want to split. Now you extend the criteria and then getting pediatric transplants also into this DCD organs. So do you split it and then put the organs on the machine?
Yes, that's a very good question, Rajesh. So when I showed you the video there, what happens is you pump the blood into the liver and then the blood goes back through the inferior vena cava and then it gets recirculated, right?
Yeah.
We have done one split on the pump. The major problem with the splitting on the liver is that when you split, as you know, you have particulate matter, right? Even if you use an RP jet. So when the particulate matter goes back into the circulation, it blocks the hepatic artery.
Yeah.
So that's one of the limitations of the pump. But what we have done is that we have essentially put the liver on a pump, isolated the, this was for a left lateral segment like kid, right? So we essentially isolated the left portal vein, divided the caudate branches from the left portal, isolated the left hepatic artery, and divided the bile duct on the pump. But then the actual parenchymal transaction we did it after taking the liver off the pump. The reason is that if you do that, you're going to have particulate matter and cause hepatic artery microthrombus.
So essentially, you're just perfusing the liver that is going to be used later in the child, and then
that's right,
preserving the transaction later.
Right.
Thank you for the wonderful talk.
Thank you again.
Thank you, Prof, for such a wonderful overview on machine perfusion. Prof, this is Dr. Shaktivel. I'm one of the junior consultant here in surgical gastro.
Hello,
we were part of a trial in UK where we did a plus study on Argonauts machine, a perfused liver utilization study. So as fellows, we were putting this liver in the machine. So that time, what you said, like early allograft dysfunction, everything was significantly less in Argonauts. But one thing, what we observed on the preliminary results, we found that the non-anastomotic biliary strictures, especially in DCD livers, were not very significantly reduced in Argonauts perfused machines. And Prof. Nigel used to say hope is better when for a non-anastomotic biliary stricture in a marginal liver. I mean, the final results are not out. Just want to know what is your experience and what is your experience on this ischemic cholangiopathy.
Yeah, that's an excellent question. Like I mentioned to you earlier, the cold perfusion, which is primarily used in Europe, we have a machine that's in clinical trials in the US. We are not part of the trial, but it's not approved in FDA as the FDA, so it's not widely used. But there has been a European randomized controlled trial which showed that the ischemic cholangiopathy decreased from 16% to 5%. And then between Argonauts and Transmedics, there has not been a comparison trial, but I can tell you from our experience that Transmedics is a much superior machine. It has got a lot of computerized changes that you can make, particularly using the prostaglandin and the TPN. So between Transmedics and Argonauts, I think Transmedics is a much superior device. With Transmedics, we are able to get to almost 0% intrahepatic biliary strictures and cholangiopathy. The main thing we're having is extrabiliary strictures. On the organox, I've noticed that from colleagues that are using it, they still have some amount of ischemic cholangiopathy. So maybe it's something to do with the infusion of the prostaglandins that happens differently between the two platforms.
Prof, and another thing regarding the viability assessment criteria which you follow, sometimes what we see is when we start perfusing the liver, the pH comes to the normal range, lactate falls down, liver starts metabolizing glucose, but the morphology also, liver looks well perfused, but we don't see any bile coming out. So do you wait for some time till the bile comes out? I mean, we check all the cannula, everything, cannula is in position. Sometimes we take out the cannula also and see. Bile doesn't come out also. So do you really take bile production as an objective criteria to use the liver, especially in a DCD liver?
Yes, that's a very, very good question. I'm glad you asked. So bile production, like I said, the viability assessment we are doing is primarily by using lactate. If the lactate comes down to less than 2, and if the liver looks good and the biopsy looks okay, we go ahead. Bile production has been not very useful, particularly for DCD livers. And I've had at least a couple of livers where we had less than 10 ml of bile and we used the liver and transplanted it and it worked just fine. So I think that bile production, particularly in DCDs, amount of bile probably is not very important. However, the quality of bile, I think, could be a little more indicative of the liver function. I agree with you. Bile production doesn't mean low bile production or hematuria, or blood and hemophilia actually doesn't mean anything for a DCD liver. The liver still might be good.
One last question, Prof. What is your take on NRP now, Prof?
Yes, very good question. Normothermic regional perfusion has become very popular in the United States. It's upcoming. The major upshot of the normothermic regional perfusion is that the cost is low. It's $10,000 versus $90,000. That's the upshot. But the downside is that even if you the viability assessment is a little bit more challenging when you're doing NRP. And then with NRP, as Rajesh pointed out, if you do NRP, you'll still have to do livers at the nighttime and not during the daytime. So that's one of the downsides.
Oh, that was an excellent lecture, Dr. Srinath. We have come to the end of the session. Thank you very much.
Thank you again, Vishnu. My respects to all my teachers there.